हेलो हेलो। आवाज आ रही है? हेलो। हेलो। आ रही है साउंड? ठीक। स्टार्ट करें?
ठीक।
स्टूडेंट्स, स्टार्ट कर दो ना। हेलो स्टूडेंट्स, let me know if my audio video is fine. I know you are studying since long time, so please let me know. If the audio video is fine, please let me know in the comments. Okay, on my side it's absolutely fine. Can we start? Just give me one comment, nod, something like that, so that I can start the class. Comments नहीं. Can I start, बच्चों? Just give us a minute.
ठीक है।
I'm not able to see your comments, so that we are just fixing that thing. All right, now I can see your comments. So let's start. All right, fine. Thank you. Good evening, Aditi. Good evening, Aditya, Rehan, Dr. Sneha. So, okay, let's start. Good evening, bacho. Very good evening. Very good evening. Let's start the class. All right. Not all the positive changes feel positive in the beginning, right? I know it's the end of the day and you're studying since long hours, but yes, we have to continue, right? The courage to continue, that matters. So we have to continue, you know? So I'm going to give you a very smooth kind of 4 hours of session, right? So if you want a bit of break, we can start with the nerve muscle physiology. The recorded videos are available. I know whenever you need a break, just note down the timing of the video. You take a break. It's okay, right? And tomorrow just watch that part only. All right. Thank you. Thank you. Thank you. All right. So let's start with a positive smile. Smile, everybody. Smile like anything. Okay. And let's start with the nerve muscle physiology, because I know the general physiology is going to be easier for you guys. So we are going to start with the nerve muscle physiology, then respiratory, and the CVS, CNS first. And as soon as our efficiency is going to go down, we are going to cover the rest of the topics which are less important, but definitely the questions are going to come from them. So let's start with the nerve muscle physiology. We know our cell membrane is going to be partial. That means it shows partiality. Why I'm saying so? Because some ions are able to diffuse through the cell membrane during the rest, and some ions are not able to diffuse. So we are going to convert these two things into diffusible ions and non-diffusible. We are going to divide them into these two groups, right? So who are the friends to whom this VIP pass is given by the cell membrane? This is nothing but the potassium and chloride. So please remember, the potassium is fully permeable. It is fully permeable during the rest, and each and every word of mine is important, because we are going to, read with the whole of enthusiasm. All the important things will be told here, okay? And the question paper has been already made, and please remember, you have to put all the right answers over there. I want my bacha party to get 17 out of 17 marks in physiology at least, okay? So potassium, fully permeable during the rest. And please remember, potassium is more inside, wants to go outside, and that's why my cell polarity is going to be negative most of the time, right? No personal questions are allowed over here, right? Then comes the chloride. Chloride is partially permeable, right? It's like 45% permeable. So yes, it is important for the RMP, but not as much as the potassium is important. So if I have to choose between chloride and potassium, whom should I choose? I should choose the potassium. All right. What about the non-diffusible ions? All other ions, even the protein, phosphates, they are non-diffusible. So I hope you got the an annotated PDF. So you can just mention over here protein, phosphate, bicarbonate, everything is non-diffusible except the potassium and the chloride, right? Gibbs Jonan, what it says that because of this non-diffusible ions, my permeability of the diffusible ions or the distribution of diffusible ion is going to be hampered. So please remember, if it talks about diffusion and distribution or the diffusible ion, non-diffusible ion, it cannot be any other than Donan's effect. If you have DDD, then it is going to be Donan's. D for Donan's. Please remember, if they talk about diffusion, distribution, diffusible ion, non-diffusible ion, it is going to be Donan's effect. Please remember that diffusible ions are also known as permeant ions. So non-diffusible can be called as non-permeant ion also. So either they can give you diffusible, non-diffusible, or give you permeant, non-permeant. It is going to be the same thing. Now, two things you have to remember for this slide, that the cell is a bag of potassium. What is the cell? Cell is the bag of potassium. Sildenafil, you should change your name though. But yeah, absolutely right. Cell is a bag of potassium. And the second thing is, our cells are floating in a sea-like water. Sea water is salty, right? And the salt means sodium and chloride. So please remember, the cell, inside the cell, I'm going to call that fluid as ICF, that is intracellular fluid. Cell is a bag of potassium. So cation, T is looking like a positive, N is for negative, right? So negatively charged ion is called as anions, positively charged ion cations inside the cells. Positively charged ion, which are the maximum positively charged ion? Potassium followed by magnesium. Why I'm writing magnesium? If the question is asked, which of the following divalent cation is more inside the cell? If the potassium is given in the option, you're not going to mark the potassium because they're going to ask the divalent. Even if the potassium is given in the option, if they ask divalent, you're going to mark the magnesium. If they just asked about which of the following is more inside the cell, then you're going to mark the potassium. What about the anions that are more? Please remember, the maximum anions are going to be phosphate followed by proteins, right, which are non-diffusible. What about ECF? We have talked about the salt. Salt is sodium and chloride, right? With that, please make a note of the calcium also, as well as the bicarbonate. All of them are more outside. Why this is important? This is important because as soon as these cells are going to move, that means whenever I'm going to open up the channels, there are going to be changes which are going to occur, and that is important for the signs that are going to be given for my Nernst equation or for their equilibrium potential per se, right? What I mean by that, let me check. All right. So let's solve that over here itself, that if I say that I open up the sodium channel via giving the stimulus, sodium is more where? Sodium is more outside, right? And where it wants to go, we always want to go on the other side, right? एक बार एग्जाम हो जाए बस हम उस तरफ जाना चाहते हैं, है ना? So we always go on the want to go on the other side. So sodium also wants to go inside the cell. Whenever I open the sodium channel, the sodium is containing the positive charge. As soon as the sodium channels are going to be opened, high concentration to low concentration movement is going to occur. Sodium is going to come inside, which is a positively charged ion. Positively charged ion coming inside the cell will become positive. Also, same with the calcium. Calcium is more outside. We know that. And as soon as I'm going to open up the calcium channel, what is going to happen? Calcium also enters inside and make the cell positive. On the other hand, if I open up what thing? If I open up, they only gave me two colors. Okay. Minimalism is followed over here in the cerebellum also, I see. Then the chloride. What is going to happen in the chloride? The chloride is negatively charged ion. As soon as it comes inside the cell, what is going to happen? It will make the cell negative. Please remember that. Same with the potassium. Potassium, though it is a positively charged ion, but it wants to go outside. And as soon as it goes outside, what is going to happen? The positivity left the cell. The cell will become negative. So please remember, if I ask you who create the inhibitory postsynaptic potential, the opening of which channel? The efflux of potassium and the influx of chloride is going to cause the IPSP, right? So, beta, three classes are going on simultaneously. नीचे just इस फ्लोर के नीचे जहां पर मेन स्टूडियो है वहां पर ना स्माइली मैम की क्लास चल रही है. सो टाइम बिंग के लिए मैनेज कर लो, 8 o'clock में हम स्टूडियो चेंज कर लेंगे आपके लिए. ऑलराइट पीपी फाइन. ऑलराइट सो नेक्स्ट EPSP. If I talk about EPSP, excitatory postsynaptic potential, what is going to happen? So please remember the sodium and calcium. Sodium and calcium, they are going to be what thing? They are going to create the excitatory potential, right? Be excited. Next, equilibrium potential or Nernst equation. Please remember, this is of single ion. That cannot be the RMP. RMP is different. Equilibrium potential is different. Equilibrium potential may we are going to be only worried about one single ion, right? So net flux, whenever the net flux is going to be zero, we are going to call it as equilibrium potential. That means the equilibrium has been reached, right? So that is called as no flow, that is net flux is zero. You have to remember one formula. What is that formula? The formula is RT by ZF upon RT by ZF into log of concentration outside upon concentration inside. But we have simplified that formula for the calculation. That is 61 upon Z. 61 upon Z, this is for the equilibrium potential, is equal to 61 upon Z log 10 of concentration outside upon concentration inside. Concentration outside upon concentration inside, please remember outside is going to be on the top and inside is going to be on the bottom. And how many zeros are going to be there? That is going to be my value. What I mean by that, let's say iska value आया आपका 10 है ना. So what is the log 10 of 10? How many zeros are there? 1. So this value is going to be 1, right? If I say log 10 of 100, that is going to be 2, right? If the value came somewhere in between, let's say 50 or 60, that is going to be 1 point something, you know that, right? So that you have to multiply with 61 and you're going to get the value, because the calculation can come as the question in the exam. So please remember this formula, ultimately important. Now, what is the difference between equilibrium potential and RMP? Equilibrium potential, yes, Abhishek, it is enough. Don't ask this question. Whatever you can grab, just grab it and keep it at least till the exam. All right. RMP, EP and the permeability. You have to take the permeability into the consideration also, which were not bothered about the permeability into the equilibrium potential. And we are going to submit all these ions which are permeable during the rest. So please remember, this is given by the GHK equation, that is nothing but Goldman-Hodgkin-Katz equation. Nobody is going to ask you the equation. Just remember Goldman's Hodgkin-Katz equation. Just remember the name. Okay, he gave the RMP. RMP is of 3 words. So please remember GHK, it is of 3 alphabets also, right? Equilibrium potential given by the Nernst equilibrium. All right. Now solve this question. Fatafat says solve this question. Resting membrane potential of the nerve fiber is mainly because of which one of the following ion? Its equilibrium potential. Fatafat say yes. Absolutely wonderful, wonderful, wonderful. All right. So I got the answer from Jay, Abhishek, Gautam, Dr. Smiley, okay, Prakash Pandya. All right, everybody, absolutely wonderful. So you're going to mark the potassium. If I don't give you the potassium as the option, then if the potassium is not there, what you will mark? Then you're going to mark? No, 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 no. You're not going to mark the magnesium. No. You're going to mark the chloride. Please remember, divalent cation more inside, that is magnesium. But that has nothing to do with the RMP. RMP पे अगर मैं पूछूं तो क्या बताओगे? Potassium followed by chloride followed by sodium potassium ATPase. All right. Now we have talked just now about the positivity and negativity. I told you IPSP, that means inhibitory potentials are created by chloride influx and potassium efflux. So see over here, potassium के आगे value के आगे negative sign is there, and even in front of the chloride value the negative sign is there, right? That means they are creating the negative potential, है ना? Negativity को बाहर करना चाहिए. Then what about the sodium and calcium? They are going to create the positivity. That means they are going to excite the cell, right? You have to remember the value S for sodium, S for 60. So please remember, sodium के साथ साथ कौन चलता है value में? The chloride, but it is having negative 70 MV value. All right. Then comes the potassium, that is minus 90, which is also the RMP of cardiac muscle as well as skeletal muscle. Please remember, these are same values, similar, easy to remember. And calcium is going to be having the maximum value. How to remember? It is having 2 on the top. So please remember, it is going to be almost maximum. That means almost double that of the sodium. So please remember that. IPSP, EPSP, हमने already discuss कर लिया था, chloride and potassium is going to be causing the IPSP whenever I'm going to open up these channels, right? And EPSP is because of the sodium and calcium. Sodium and calcium. All right. Can we move on? मायोकार्डियम में आ रहे हैं बच्चे, आ रहे हैं अभी, है ना? Nernst potential of sodium is, फटाफट से आंसर दो, we don't have time, right? Absolutely wonderful, wonderful, wonderful. Why you are saying positivity? Why? Because the sodium is positively charged ion, and my bacha party knows that when the positively charged ion comes inside the cell, the whole environment becomes positive, है ना? So that's how we are going to learn with the positivity, right? And not the minus 61. You are going to write the approximately nearby values, है ना? A little progress each day adds up to big results, right? The exam is nearby, everybody feels anxious. Even I feel anxious for my bacha party. If the exam comes, I become nervous कि क्या result आएगा, मेरे बच्चे पास होंगे नहीं होंगे, right? So even we feel the anxiety, even before the class we feel the anxiety, कैसे manage होगा, क्या होगा, ये होगा, but we know everything is going to be okay, है ना? Everything is going to be okay. You don't have to give up, है ना? It's like a war and you're standing right on the field, right? You don't have to give up, just continue, right? Coming to the RMP, I told you RMP mein we are going to summate all the equilibrium potential multiplied by their permeability. Two things are taken into the consideration. Just remember these values. Very, very important. They can be asked as a direct question. Neurons का minus 70 MV, neuron बोलो, nerve बोलो, one and the same thing. All right. So neurons, nerve minus 70. Skeletal muscle, cardiac muscle, fourth generation के लिए we require a lot of higher potential difference. So please remember, they are going to be maximally negative. That means minus 90 MV. Talking about smooth muscle, it is going to be minus 50 MV. Smooth muscle, little bit contraction is there. Force of contraction is not that much high as compared to the skeletal muscle. So please remember, it is going to be minus 50. And what about the SA node and BER? What is BER? BER is nothing but basal electrical rhythm. Basal electrical rhythm, which is seen in the GIT. And please remember, who produced this basal electrical rhythm? The interstitial cells of Cajal. Cajal was the name of scientist. He was Spanish, जिसे हम मोइतो बोलते हैं, वैसे कहाल बोलते हैं. You can remember the way you want to remember. Just mark it correctly in the exam, है ना? काजल बोलो, कजाल बोलो, जो बोलना है बोलो. Just mark it correct, okay? So please remember, this is having fluctuating RMP. How I used to remember? Pacemaker cells of heart, है ना? एंड पेस मेकर सेल्स ऑफ जीआईटी. खाना और दिल लगाना, किससे दिल लगाना है? पढ़ाई से, राइट? दीज टू थिंग्स आर फ्लक्चुएटिंग ऑल द टाइम, है ना? खाने की चीजें बदलती रहती है और दिल लगाने की चीजें भी बदलती रहती है. सो फ्लक्चुएटिंग आरएमपी. सो प्लीज रिमेंबर दैट, है ना? सो this is going to be minus 40 to minus 60. That is the RMP which is fluctuating. That is not the action potential. Please remember that. Next, who now tell me the answer of this. Genesis mein maximum contribution is given by which ion, bacho? It is going to be the potassium, followed by chloride, followed by our Nokia pump, sodium, potassium, ATPase. Right? Minor contribution is going to be there. If I ask you, what is the role of sodium? Does the sodium has any role in the RMP? Yes or no? Answer me. Only sodium has any role or no? Tell me. Na 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 na. नाम में ही है ना 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 ना. So it has no role. Absolutely no role in the RMP. किस में रोल होता है बच्चों? where the sodium role is more important in the action potential. Please remember, resting में the sodium is going to be saying no, 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 na, 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 na. But as soon as you come in the action, they are going to make you reach till the spike potential. So please, please, please remember, action potential में yes, role is there, but not in the RMP. What is this Nokia? Please remember, Nokia means sodium out, potassium in, ATPase. How many sodium out, bacho? Sodium. Two alphabets are there in the symbol. Just add one into it. That has become three, right? Three sodium out and only one alphabet of potassium. The symbol is there. So add one into it. That becomes two. So three sodium out, two potassium in. What is going to happen? If I give you 3,000 rupees, you return me only 2,000 rupees. So three positive out and two positive in. So I'll be in the loss of one positive, right? I'll be in the loss of 1,000 rupees, or I can say I got one, or I can say the gain of one negative, right? So that's how it is adding up into the negativity during the rest. And that's why I said that minor role is there of the sodium potassium ATPase. ATPase में role है, sodium alone is going to have no role. Please remember that. Coupling ratio. What is the coupling ratio? 3:2 is going to be my coupling ratio. 3:2. Absolutely right, Dharam. 3:2. Aditi, superb, right? Then maximum ATP consumption at the rest. All the nucleated cells are going to have the sodium potassium ATPase pump on their cell membrane. So please remember, on the cell membrane, they're always active. Even if you're sleeping, they are going to be active. And please remember, they are active. That means they are using the ATP. And please remember, when I say BMR, that is basal metabolic rate, I'm going to calculate that during the resting condition. Even in the resting condition, all the cells which have this pump, that is going to be active and that is going to use the maximum ATP, and that's why my BMR is going to be dependent on this pump, right? And since it is present on all the cell, I'm going to call it as universal pump or the omnipresent pump, right? Omnipresent or universal pump. Maintain this high sodium out because it is continuously throwing the sodium out. Why? Because we don't want the sodium to accumulate inside the cell. होने दो, क्या दिक्कत है? What is the problem? If I allow the sodium to accumulate inside, what is the problem? Absolutely wonderful, MS. That is going to be followed by the only crush, that is water. Water has crush on the sodium. So wherever the sodium goes, water is going to follow. We have problem with the water. If water start to accumulate, my cells are going to burst. I don't want that. So that's why sodium is going to be thrown out, right? And potassium is taken inside. So RMP genesis mein it has a minor role, electrogenic pump, because it creates one negative charge inside my cell. All right. Let's move on. Solve this question फटाफट से. What is our cutaneous sensory neuron में? Site of generation of action potential. We are turning from the RMP into the action potential. क्या होगा answer? Answer is hidden into my next mnemonic. That is nothing but Miss Senor. What is Miss Senorita or Miss Senor, बच्चों? Miss motor neuron में if they ask initial segment is going to be the site for the genesis of action potential. You have to remember this, Miss Senor, right? And sensory mein, be that any sensory neuron. Sensory neuron mein, I'm going to have NOR, that is nothing but nodes of Ranvier. Nodes of Ranvier. Ranvier was the scientist who discovered this. So the gap between the myelin sheath, that is known as nodes of Ranvier. In that, I'm going to have the generation of action potential in the sensory neuron. Since they have asked about sensory neuron, my answer is going to be D. जिन्होंने आंसर A या B दिया है, reconnect that, है ना? ये mistake बाद में नहीं होनी चाहिए. Do as many mistakes you want to do in the class, just do not repeat those mistakes in the exam, है ना? All right. Watsil and Foez, I hope you got the answer and you got the correct this thing, right? क्वेश्चन नहीं देखा, अब देखना है आगे. ब्रिज, ओके. Now, answer this question फटाफट से. Phase 3 of action potential, NEET 2023 question, right? I know it's a question of NEET, but my Bacha party is going to solve this question. Yes, absolutely correct. They have asked about the phase 3. That is going to be the repolarization phase. Repolarization phase. Right? And let's see, the answer is going to be potassium efflux over here. Potassium efflux. Let's see how the action potential works. है ना? Revise करवा दो बच्चों मेरे को. If I say this is the action potential of this is the RMP of the neuron, RMP कितना होता है बच्चों? Minus 70 MV. If I give the stimulus of plus 15 over here, what is going to happen? I'm going to reach to a firing level as you are reached to firing level, right? That is going to be the minus 55 MV, which is said to be a firing level, right? What happens when you reach to a firing level? When you are into a momentum, what happens? Study becomes easier, isn't it? So what is going to happen? Definitely, I'm going to open up a lot of sodium channels. Sodium influx will start, right? Up to what point the sodium is going to come inside? Unless and until I reach a peak. That peak is known as spike potential. As soon as you reach to a spike potential, you have to do two things. Close whatever channel is open and open the potassium. What is the channel which is open right now? This was the sodium channel. You're going to close the sodium channel, open the potassium. What is going to happen? The potassium wants to go outside, isn't it? So once the potassium wants to go outside, the potassium start going outside. Potassium is the positively charged ion leaving the cell, will bring my cell towards the negativity. The problem with the potassium is that it is a kachua. Potassium, K for kachua. It's a kachua channel. It takes a lot of time to close. So slow closure of the potassium. During that time when it was closing, right, some potassium leaks out, and because of that slow closure के वजह से we do have hyperpolarization, but after some time it is going to come back to my RMP. How to remember? There is a mnemonic Dinkar. What is Dinkar बच्चों? Depolarization. Whenever I'm going to go away from the normal negative polarity, I told you the RMP of most of the cell is going to be negative, right? If I'm going dur, D for dur, that is nothing but the I'm going in the positivity. I'm going to remember this is known as depolarization, away from the normal negative polarity. If I'm returning back towards the RMP, returning back, repolarization, right? And if I'm going more in the negativity than the RMP, it is going to be called as hyperpolarization. So please remember, the depolarization is because of the influx of sodium. That is, depolarization is because of the influx. I for influx, N for sodium. कर क्या है? Potassium. This कर is potassium efflux. Potassium efflux causes repolarization. Question आएगा इस पे जीटी में. गलत नहीं करना किसी ने, है ना? इफ यू डू रॉन्ग इन दिस ऑल्सो, तो क्या करना है? शाम में जैसे ही पता चले कि गलत किया था ये क्वेश्चन, एक चुल्लू भर पानी लेना, आगे क्या करना है आपको पता है ना? सो डोंट डू द मिस्टेक इन दिस. ऑलराइट. This was the question came in the FMGE exam 2018 as well as 2020, है ना? So what is this? You have to identify this X and Y. This is the permeability of the ion. Tell me what is X, what is Y? What is X, what is Y? The X is nothing but your sodium. See over here, the sodium, as soon as you reach to a firing level, what is going to happen over here? First of all, your sodium permeability start to increase. The permeability दिन कर उसमें N पहले आ रहा है, so sodium is going to increase first, right? And then comes the Y, that is nothing but the potassium. It is going to be the sodium and potassium. Please remember, twice the question has been come, right, as the diagram. So please remember, पहले sodium आता है and then comes the potassium, right? Perfect. Right? Next comes the refractility. What do you mean by refractility? Refractility means no response. That means refractility. But it can be absolute refractory, right? That means as my bacha party is absolutely refractory to the distractions, right? You are not allowing the distractions to come, right? So that means you are absolutely in the refractory period. That means you don't give a damn to the distractions, right? So absolute refractory period is going to be start from the starting of the action potential till 1/3 of the repolarization is complete, somewhere down here, right? If I just give you the scenario over here. So let's see, this is 1/3 of repolarization, which is completed. So from here to here, from here to here, I'm going to call it as ARP. ARP, right? On the other hand, if I ask you from one third of repolarization till the time I come back to my normal RMP, I come back to my normal RMP, this is going to be my relative refractory period, right? One third of repolarization. From there, once I come back to the RMP, that is going to be my relative refractory period. What is the difference between two? Absolute refractory means you are not allowing any distraction. You know, that is going to be during the class. You are not allowing any distraction to happen. That is no response absolutely whatsoever, no matter whomsoever calls you, है ना? कोई लड़की भी बोले आपको या आपका गर्लफ्रेंड बॉयफ्रेंड कोई भी बोले कि चलो बाहर घूमने चलते हैं, चलो ये करते हैं, you are not going to give any response till the exam time, है ना? So that means no matter how strong stimulus you give, there will be no response whatsoever. What about the relative refractory period? Exam के बाद you are going to be somewhat, slacky कि चलो अब enjoyment कर सकते हैं ना. So that is relative refractory. If you give a strong stimulus, you are going to get the second response. That is relative refractory period. Please remember that. What is the benefit of that? The ARP is longer in the heart muscle. Longer in the heart muscle. That means if I give the another stimulus during this phase, I'm not going to get any response. So my heart cannot go in the sustained contraction. Tetanization means what? It means sustained contraction. My heart cannot go in the sustained contraction, and if it cannot go in the sustained contraction, my heart cannot be tetanized, and my heart is prevented from going into the cardiac arrest. So cardiac arrest is not possible because of the ARP, thanks to the ARP. All right. ARP is the reason is sodium channel inactivation. Okay, Khushi, just remember ARP is because of sodium channel inactivation if you want this answer, right? Which becomes close later on. Close से open करना आसान है, inactivation से open करना आसान नहीं है. So that's why this is the reason for ARP. And what is the significance? What is the benefit of RRP, or why the RRP is important? Because RRP में if you give a strong stimulus, you are going to get the second response. It can be abnormal response. It can break your rhythm of the heart. That's why it is the most risky period for the arrhythmia. And please remember, abnormal contraction can happen during this period, and that is going to give rise to something called as premature ventricular contraction. That means the systole was going on of the first this thing stimulus, and the relaxation was about started just now, but suddenly the heart, rather than relaxing completely, started contracting again. That is known as the premature ventricular contraction. Premature ventricular contraction, isn't it? So that is going to be कोई बात नहीं मेडिको, just study whatever you are able to do it right now. What I tell you always, that convert your worry time into study time, है ना? So convert your worry time into study time. That is the only mantra I can give you, है ना? So whatever we are discussing over here, just focus on to it, right? Just relax. All is going to be well, okay? Just relax, all right? You're going to do well, okay? Next, axon. देखो यहाँ पर what is shown? Axon is shown. The CNS and PNS shown. Why they are shown? They are shown because to show you the myelin sheet. Myelin sheet is nothing but the covering. CNS में कौन करता है covering? The CNS. In the CNS, the covering is done by my oligodendrocyte. Oligodendrocyte. And what about the PNS? In the PNS, the myelin sheet is formed from the Schwann cell. Now, my question to you guys is, if I form the antibodies against the PNS cell or CNS cell, who is going to be more severe? Obviously, if I form the antibodies against the oligodendrocyte, it is covering lot many areas. So you can see they are covering lot many, or they are forming multiple myelin sheets. At multiple sites, they are going to form the myelin sheet. So that's why it is going to, if I damage this cell, almost the 6 sites will be gone from the myelin. So this is known as multiple sclerosis. Multiple sclerosis. Please remember, this is going to be very, very dangerous. Why? Because one oligodendrocyte is gone. That means multiple myelin sheets are gone. Now the velocity of my neuron is going to be slower down. है ना? So please remember that Schwann cell peripheral nervous system में it is going to cause the myelination. All right. So this question, bacha party. रेबीज वायरस के बारे में पूछा है, राइट, एंड दे हैव आस्क्ड अबाउट द मॉलिक्यूलर मोटर. कौन है ये मॉलिक्यूलर मोटर विच इज इंपॉर्टेंट? हाँ जी, क्या आंसर दोगे? व्हाट इज योर आंसर? बताइए बताइए, जल्दी जल्दी बताइए. All right. So, absolutely correct. It is going to be dynin. Rabies, you cannot treat it if that happens to a patient and after the disease, the patient comes to you, you cannot prevent it. Yes. Vaccination you can give, that is prophylactic purpose, right? But once the rabies patient comes to you, he's going to die. So who help him to die? It is dynin, right? So the patient is going to die. Why I am saying so? Because see over here, this is the neuron and this is the soma of the body and this is the axon. See over here, if I'm going from the soma towards the axon terminal, this is the axon terminal. If I'm going to go in this direction, my cargo is going to help me out. This cargo is none other than the kinesin, right? Kinesin is going to be going forward. That's why I'm going to call it as anterograde transport. And which transport I'm talking about? This is happening inside the axon. So can I call it as exoplasmic transport? Yes, this is the exoplasmic transport. So please remember, anterograde is going to happen with the काइनेजिन. क्या क्या जाता है एंटीरोग्रेड ट्रांसपोर्ट से? व्हाट ऑल थिंग्स कैन गो देयर? न्यूरोट्रांसमीटर, वेसिकल्स, नर्व ग्रोथ फैक्टर, different, even the mitochondria can be transported sometimes there, right? So please remember all these proteins that is going to go towards the axon terminal. But let's say my vesicle got empty but I want to recycle it back, है ना? We are Indians, we follow our culture, right? We respect our culture and in our culture wastage is not allowed, है ना? So we can, what we do, we recycle it, we reuse it to prevent our beautiful nature, है ना? So what we do, we try to recycle it back, है ना? So if I'm coming back from where? If I'm coming back from the axon terminal towards my soma for the recyclement of the vesicles, even the nerve growth factor or whatever neurotransmitter is left, I want to reuse it, right? So it is going to be helped by the dynin. Okay, this cargo is nothing but the dynin. But please remember, some toxins such as rabies virus, herpes virus, not only that, the polio and tetanus toxin, they can come through this dynin. And that's why, remember, once the dynin is there, reach to the soma, my all factory is there inside the soma. What do you mean by factory? I have mitochondria, I have Golgi apparatus, I have the endoplasmic reticulum, I have nucleus. If the virus comes there, they get whole party-like environment and they're going to grow and proliferate there because they have everything, whatever they require for the proliferation. So please remember, the person is going to die if my this virus has reached to my soma. So please remember, that is going to happen with the help of dynin. So please remember, this is coming back. So I'm going to call it as retrograde transport via the dynin. All right. Next, Erlanger-Gasser classification. What is this classification? This classification is of nerve fiber. Erlanger and Gasser, there were two scientists who said that there are three different types of major nerve fiber: A, B and C. Thankfully, they don't give any other name, है ना? A, B, C आसान है हमारे लिए, आसान है, right? So A, B and C, these are three type of nerve fiber, but the A fiber is subdivided into four different other types, that is alpha, beta, gamma, delta. A alpha, A beta, A gamma, A delta, right? Let's see about the B and C fiber. They are easier, right? B is preganglionic ANS fiber, easiest. That's all, right? C fiber is postganglionic ANS fiber. What do you mean by ANS? Autonomic nervous system. You must have studied that in the sympathetic system. The preganglionic fibers are smaller and the postganglionic fibers are longer. On the other hand, in the parasympathetic system, what happens? In the parasympathetic system, the preganglionic fibers are longer and the postganglionic fibers are smaller, right? So you must have studied that. This preganglionic and postganglionic, that we are talking over here, all right? Not only that, the C fiber also carries the pain and temperature, right? So pain and temperature is also carried by my A delta fiber. Please remember that pain and temperature is also carried by A delta fiber, right? ए फाइबर को याद कैसे रखना है? हाउ टू रिमेंबर द ए फाइबर? यू हैव डिवाइडेड दैट इनटू 4 टाइप्स, राइट? उस 4 को आप 2 के ग्रुप में डिवाइड कर दो. 2 आर मोटर, 2 आर सेंसरी, राइट? Which 2 are motor? You must have heard of lower motor neurons, alpha motor neuron, gamma motor neuron. What are that alpha and gamma? These only. Alpha motor neuron, gamma motor neuron. So these two are motor. Beta and delta, they are sensory. But there is a twist in the kahani. What is the twist? The alpha also carries the sensation of position. What it is called as proprioception. राइट? मेडिसिन इतनी आसान होती तो बात ही क्या होती है ना, 2 मोटर 2 सेंसरी हो गया काम, है ना? बट there are some twist, है ना, on which the questions are going to be asked, right? So proprioception is a sensory. So please remember, proprioception is the sense of position which is carried by A alpha, right? Pain and temperature is also carried by A delta. Pain and temperature is also carried by the C fiber. What is the difference between different types of pain? Please remember, as you go down from A fiber towards C fiber, the velocity is going to be decreased. The myelination is going to be decreased. Velocity मतलब क्या होता है? Velocity means speed. Speed of conduction of the action potential is decreased. So that means my C fibers are going to be the slowest and A fibers are going to be the fastest. Amongst the A fiber, the A alpha is going to be faster. A beta will be slower than the A alpha. A gamma will be slower than the A beta, like that. Okay. But if I compare A delta and C fiber, definitely the A delta is faster. So whatever pain is carry forwarded by this A delta is going to be called as fast pain. It will be carried turant se, quickly, right? So if the mosquito give you a kiss while you're sleeping, that means mosquito bites you. What is going to happen? That is going to give you a sharp pain that is carried by the A delta fiber, right? So C fiber is going to carry the, of course, the slow pain. Question aata hai, please remember, if you want to remember one thing from this slide, please remember this A delta and C fiber wala thing. Now, what about the A beta? Rest all sensation. Just remember, rest all sensation. Okay. What are the other sensation? The touch sensation, pressure sensation, vibration sensation, stereognosis, graphesthesia, whatever they give you, right? Except the proprioception, pain and temperature. All of the sensations are carried by my A beta fiber, right? A beta fiber. All right. So let's move on with that. Understood completely, right? अभी समझ में आया बच्चों? परफेक्ट, लेट्स मूव ऑन. परफेक्ट, मूव ऑन. ए गामा सबसे आसान है बच्चे, मोटर फाइबर, बस उसका कोई और काम नहीं है, राइट? सो लाइफ इज मेड इजी बाय द ए गामा फाइबर, है ना? वरना हम गम में चले जाते. लेट्स मूव ऑन. स्केलेटल मसल. स्केलेटल मसल में 2 मेन फाइबर यू हैव टू रिमेंबर, एक्टिन एंड मायोसिन. बट कहानी में ट्विस्ट तो आना ही है. व्हाट इज द ट्विस्ट? दैट सॉल्व दिस क्वेश्चन फर्स्ट, देन विल गो ऑन फॉरवर्ड, है ना? क्या है? ट्रोपोमायोसिन का क्या काम है? What is the work of tropomyosin? Yes, bridge. Perfect, है ना? You are the best student who remember all my mnemonics, है ना? Papa G of myosin. So see over here, this is the Papa G of myosin who is having the gun, who do not allow the myosin to meet his or her dash dash, that is actin, right? So what we have to do if we want this actin myosin to meet each other, है ना? NBO को उड़ाना चाहिए बीच में से, है ना? So this is like NB, right? इसको distract करो. कैसे distract करोगे? We want troponin plus calcium. I need troponin and calcium to distract or displace. Troponin and calcium to displace this tropomyosin, Papa G of myosin, to remove in between so that my actin myosin can meet with each other and the contraction can happen. Helps in the fusion of actin myosin. पापा जी ऑफ मायोसिन नेवर अलाउ अस टू फ्यूज, है ना? हमारे सक्सेस से जलती है इन बी, सो दैट इज नॉट पॉसिबल, राइट? नेक्स्ट, कवर मायोसिन एंड प्रिवेंट द अटैचमेंट ऑफ एक्टिन एंड मायोसिन. दैट्स ट्रू, इट प्रिवेंट्स द एक्टिन मायोसिन का अटैचमेंट. दैट्स ट्रू, राइट? Slides over the myosin, it is not going to slide over the myosin and it is not going to cause the calcium release, right? So please remember the answer is going to be B. Let's see how this can be applied. So the green यहाँ पर जो दिख रहे हैं and the light blue color chain that you can see over here, that is nothing but actin. Or if you can see the pink fiber over here, this pink fiber is nothing but the Papa G of myosin, that is tropomyosin. See this dark blue color, these dots are nothing but the active site of actin. Only there the myosin head can bind to each other, but that is covered with Papa G of myosin. I have to remove this papaji of myosin. So I'm going to take the help of troponin. But troponin alone cannot do anything. It requires the help of calcium, right? So as soon as the calcium is released, see over here, the calcium is going to bind to the troponin. As soon as this complex is formed, calcium and troponin, they are going to displace the papaji of myosin, that is tropomyosin. Now you can see these dots are available for the binding of the myosin, that is active site of actin. तो क्या करना है? Actin and myosin से बीच में से you have to remove the tropomyosin with the help of troponin calcium complex. So please remember, what is the role of troponin? Alone it actually helps the myosin, but when it meets with the calcium, troponin calcium complex displaces tropomyosin. Please remember that, है ना? So I'm going to write over here troponin plus calcium complex. It displaces the myosin, displaces the tropomyosin, and you can see actin can meet with the myosin head, that is known as cross bridge formation. Cross bridge formation, all right? Cross bridge formation. All right, let's move on forward. Let's move on forward. Solve this question, bacha party. Which one of the following band or zone disappears on muscular contraction? There is only one band which disappears completely. Disappear completely. राहुल, हमारी गुड इवनिंग तो बहुत पहले हो गई. You are late. All right. Very good. Absolutely wonderful. So H zone is going to be disappear. What I told you about M line and A band, Ma never change. Or Mama never change. Hai na? Ma never changes. I band, it is going to be, yes, it is going to decrease in size, but it never disappears. Disappearance kiska hota hai? H ka hota hai, H zone ka, right? So see over here, this pink are nothing but myosin fibers. Myosin fibers, hai na? This is going to be the myosin fiber. C answer क्यों दे रहे हो पीपी? The answer is not C बच्चे. Disappear पूछा है ना? The answer is going to be B, है ना? Myosin is going to be the pink fiber, which is the thick fiber, and these thin fibers are nothing but shown by the green color, that is nothing but the actin. If I take only actin, which is not overlapped by the myosin, that is known as I band. That is known as I band. It is shown over here. The I band is nothing but the only actin. So see over here, this is the I band, right? So I band is not covered by the myosin. So यहाँ से यहाँ तक लूंगी मैं, that is going to be the I band, isn't it? But see over here, if I draw exactly in the middle of I band, in the middle of I band, if I draw a line, that is going to be called as Z line. And the adjacent Z line to Z line, this is going to be called as sarcomere. Sarcomere. This is the functional unit of the muscle, right? Sarcomere ke exact middle mein if I draw a line, that is known as M line. This over here you can see in middle of the sarcomere, if I draw a line, that is called as the M line, which is also going to come in the middle of A band. What is the A band? It is the complete myosin. It can come as overlapped part also and non-overlap part. Doesn't matter. Doesn't matter whether it is overlap, it is non-overlap with the actin. It is going to come under the A band. So what is I band? Only actin. What is A band? Whole of the myosin, right? What is Z line? In between of the I band. It is going to be called as Z line if I draw a middle line in the I band, right? In the middle of the sarcomere, I'm going to have the M line, and the H zone shows only myosin. Only myosin means it should contain only non-overlapping part. So see over here, there should not be any green part in between, right? But as soon as I'm going to start the contraction of the muscle, what is going to happen? This green and pink color, that means actin and myosin, they are going to overlap with each other. So non-overlap part is going to decrease. So you can see non-overlap actin is decreased. So I band is decreased. And over here also I band is decreased. Z line came together, right? M line. What happened to the M line? M line was the middle line. Does it change? No. The M line is not going to be changed. Okay? It does not change. कौन कौन नहीं बदलता? The M line will not change. Plus, you can see what is A band, बच्चों. A band is complete myosin. That is also not going to change. राइट. सो माँ नेवर चेंज, है ना, मम्मा की फीलिंग हमारे लिए कभी नहीं बदलती. माँ नेवर चेंज, प्लीज रिमेंबर. Except all these things, everything is going to decrease. And if I completely overlap the actin and myosin, only myosin will not be available, right? If I completely contract this myosin, only myosin will not be available, and H zone is going to disappear. H zone is going to disappear. Please remember that. Let's move on forward. What is the next slide? Blood is red, cyanosis is blue. I know that. I get tachycardia when I think of you. किसके बारे में सोच रहे हैं हम सिर्फ और सिर्फ एग्जाम के बारे में सोच रहे हैं ना, हम और किसी के बारे में नहीं सोच रहे. उसको सोच के इनफ टैकिकार्डिया हो जाता है. ओके, सो प्लीज रिमेंबर दैट, है ना. सो कार्डियोवैस्कुलर सिस्टम, तो यही पढ़ रहे हैं हम टैकिकार्डिया के बारे में. कार्डियोवैस्कुलर सिस्टम, राइट. First, I'm having two types of cell in the heart. What are the two types of cell? First is the nodal tissues and second is the cardiac muscle. Nodal tissue, it has the property of autorhythmicity. Do you tell your heart, now you have to contract, now you have to relax, you have to contract, now you have to relax? ऐसे तो sleep भी नहीं कर पाओगे, है ना? That doesn't happen. It contracts automatically, thankfully, right? So autorhythmicity means it creates a rhythm automatically on its own. How this is possible? This is possible because of the pacemaker potential. What is pacemaker potential? What was the RMP of the nodal tissue? I told you the pacemaker cells का क्या होता है? Fluctuating RMP, right? So उल्टा लिख दिया, क्या है? -60 is more negative, madam, है ना. आपकी कॉफी लगता है पहुंची नहीं अभी. -60 to -40, है ना. That is going to be your pacemaker potential, and you have to remember the ionic changes of the pacemaker potential via the mnemonic. Funny cat pick, you have to remember her, है ना. क्या है ये? फनी कैट पिक. पेस मेकर पोटेंशियल. फनी क्या है? फनी सोडियम चैनल, दैट इज नथिंग बट, बड़ा बड़ा एन निकाला है, 2 N है. प्लीज रिमेंबर, सोडियम लीकी चैनल्स और सोडियम फनी चैनल्स, वन एंड द सेम थिंग, right? So for sodium funny channels, they are going to help us. That means the sodium is going to leak inside without giving any stimulus. It is going to leak inside, which will make somewhat positivity over here, right? Somewhat positivity. But that was not enough. So we asked the calcium to open up for some time, है ना. So transient opening channels of the calcium. T, cat, ट को अलग कर दो, टी को अलग कर दो. टी is for calcium transient channels, right? So they are going to open for the shorter duration, and calcium entry will also give me the positivity inside my myocardium cell. So calcium T channels, please remember that, transient opening channels. And I told you the potassium, usually P is for potassium, पोटेशियम, के फॉर कछुआ हमने बात करी थी. बट ओवर हियर दिस इज द मॉडिफाइड मसल, राइट? इन दैट व्हाट हैपेंस, द पोटेशियम क्लोजेस early. The early closure is there. That means it is not kachua in my myocardium. I cannot allow it to close slowly, so I'm going to close it faster. So what is going to happen? The potassium closure, channel closure, causes the potassium to accumulate inside my cell, positivity accumulating in my cell. So definitely it is going to cause what? Depolarization. I'm going to reach to my firing level. I'm going to reach to my firing level. So please remember potassium early closure, or अगर हमने pick लिखा, pick क्या है? Immediate closure. Immediate closure. As soon as you reach to -40, it is going to close immediately. All right. So early closure या immediate closure is going to be helping us in what thing? In the pacemaker potential. एक बार ड्रॉ कर लेते हैं फटाफट से, क्या होता है नोडल टिश्यू का. बच्चों बताओ फटाफट, क्या था ये? -60 to -40. कौन कौन से थे? फनी सोडियम चैनल, एंट्री हो रहा था सोडियम का, कैल्शियम का एंट्री हो रहा था थ्रू व्हाट चैनल? टी, दैट इज ट्रांजिएंट चैनल कैट. एंड पिक का पोटेशियम इमीडिएट क्लोजर और early closure. So potassium accumulation is going to occur, which will reach me the firing level of the pacemaker tissue. And जैसे ही I'm going to reach back to my firing level, what is going to open up? Please remember over here, calcium L channels are going to open up. Calcium L channels, it is not the sodium. Please remember, right? And as soon as you reach to a spike potential, I told you two things you have to do. Whatever channels are open, close those channels and open the potassium. Always do that thing, है ना. So close किसको करोगे बच्चों? Close the channels that are open. You close the calcium L channel and open the potassium. As soon as I open the potassium efflux will start, and I'm returning back to my RMP. Please remember the RMP is nothing but -40 to -60. This is again the RMP. So I'm again going to go and cause the funny cat pic over here, and this is known as autorhythmicity. Autorhythmicity, इसको याद रखना, भूलना नहीं. Nodal tissue में it's different than the neurons and cardiac muscle. This was about the nodal tissue, है ना. Nodal tissue क्या क्या होता है बच्चों? SA node, AV node, bundle of His, bundle branches, Purkinje fibers. These are nothing but the nodal tissues, right? They are going to give the stimulus to my cardiac muscle. They're like a labor. They don't have their own brain, so they require nerves, right? They are acting through the nodal tissues. Now cardiac muscle ka action potential, how it is going to differ? It is going to differ like this. Okay, so let's see that how it is going to differ. Why it is not adding? It's not adding the page. Why? All right, of course this is going to happen in my class. All right, fine. एक बार ये क्वेश्चन सॉल्व कर लो. आई हैव सम स्पेस इन द वाला स्लाइड. I'll call them. So इसका आंसर क्या होगा बच्चों? फेज जीरो. फेज जीरो का आंसर क्या है? क्या है इसका आंसर? बताओ फटाफट फटाफट फटाफट. It is absolutely wonderful. It is going to be C, C, and C, right? It is going to be C, C, and C only. All right. Even if they do not give you the option, so please remember this is the phase zero. Phase zero हमेशा depolarization होता है बच्चों, और RMP हमेशा phase 4 होता है. Please remember RMP is always phase 4. Repolarization is always phase 3. Phase 3 is going to be repolarization. All right. So please remember that. Okay. इसका आंसर सॉल्व करो क्या है, तब तक मैं कार्डियक मसल का बना देती हूँ. All right. This is minus 90 was the RMP. Yes, you have told me the answer. Now concentrate over here. This is the RMP. RMP कौन सा phase होता है? Tell me. RMP कौन सा phase होता है? Is it phase 0 or it's phase 4? It is phase 4. Absolutely correct. Abhishek, right. And Adishan and Prakash Bridge, yes, it is phase 4, right? Why I'm focusing? Because they have given the questions directly. 2 questions in INICET, 2 questions in the NEET in one exam itself, right? So remember, as soon as my nodal tissue stimulate my cardiac muscle, what is going to happen? The sodium channel is going to open, right? Cardiac muscle and this neuron is similar. You just have to add 2 phases in between. I'll tell you how. Sodium influx will start till what point? Till I reach to a peak. Peak को हम क्या बोलते हैं? Spike. Spike potential, isn't it? And as soon as I reach to a spike potential, I have to do 2 things. क्या करूंगी मैं? 2 things. That means whatever channels are open, I'm going to close them, close the sodium and open the potassium, right? Whatever channels are open, we have to close them. Sodium I closed, potassium open. What is going to happen? दिनकर में potassium क्या कर रहा था? Potassium was causing the repolarization. The repolarization will start. But. There is a twist in the kahani. What is the twist? There will be something known as plateau phase. Two changes are going to happen during the plateau. What are the 2 changes? First thing you have to remember, this is plateau, so phase 2, and 2 ionic flows are going to happen. 2 याद रखना, 2 right? So what are the 2 changes that are going to occur? Potassium will continuously start going outside, but during this phase the calcium channel is open, so one positively charged ion coming inside the cell, one positively charged ion leaving the cell. They balance each other, and that's why I'm going to get a flat line in between. If I check the action potential, that flat line is called as plateau, and this is the phase 2. Please remember, 2 ionic change, phase 2, plateau, 2. Remember that. Now, but the calcium channels are not that stubborn. They close relatively early. So these are calcium L channels only, but they are going to close, you know. So write down, calcium channels are going to close after some time, but potassium continue to glow outside. Potassium continue to go outside unless and until it reaches to the RMP. What I told you about repolarization. Repolarization is always a phase 3. This is phase 3, right? What is phase 1? Phase 1 is this one. Phase 0 is always the depolarization. Phase 4 is RMP. This is phase 3 and this is phase 2. Please remember that when you give calcium channel blockers, it is going to block the phase 2, plat 2 block karenge. All right. So please remember that. Let's come to this question. S3 किसके वजह से होता है? Please remember it is due to rapid filling, early rapid filling. You have given me the answer already. This is because of rapid filling. All right. Wonderful. I'm loving your what thing? Responses है ना. It feels lively, it doesn't feel stupid when because if you just talk to the camera it feels very stupid. So S1, S2, S3. What is the first alphabet, बच्चों? We have studied in the LKG, UKG, A, B, C, D, A for apple पढ़ा था ना. So please remember A is the first alphabet and my S1 sound is going to come whenever the valve is going to close. Please remember the valve closure is going to make a sound. Opening of the valve will never make a sound. So always the valve closure is going to make the sound. All right. So A comes first. So AV valve closure is going to make the S1 sound. What about S2 sound? Second, S for second, S for SL valve. SL क्या है बच्चों? SL is nothing but semi-lunar. It looks like a half moon shape. So that's why we are going to call it as semi-lunar valves. What are the semi-lunar valves? My aortic valve and pulmonary valve, they are nothing but the semilunar valve. Again, the valve closure is going to make the sound. Opening of the valve will never make a sound. So please remember S for second, S for SL valve closure. All right. Coming to the S3 and S4, please remember always the filling is going to, as you fill the bucket, if the tap water is open, if you fill the bucket, it makes a sound, right? So similarly, if you fill the ventricle, that is going to make a sound. But that sound is relatively lower frequency, lower than the 20 hertz. That's why with the human ear, we cannot hear that unless and until you open the tap very forcefully. That means in the pregnant female, what happens? A lot of plasma is produced, right? So the force is going to be produced. More water you want to fill, right, into your ventricle. That is going to make the sound which can cross the 20 hertz and that can be audible. So this is the only physiological condition where the S3 is going to be normal. All other condition, the S4 and S3 are abnormal. That is pathological, right? Please remember that. Coming to the cardiac cycle, let's come to the cardiac cycle. We know that systole and systole, diastole, that completes a cycle and this continues unless and until we are alive. है ना? One cardiac cycle normally is of 0.8 seconds. Atria ka different cycle is going to go on. Ventricle ka different cycle is going to go on, right? Atria करता है काम only for 0.1 second. It is going to do the work and rest of the 0.7 second it is going to relax. Chill mata, chill, right? On the other hand, my ventricles are going to contract for 0.5 seconds. Sorry, 0.3 seconds they are going to contract and for 0.5 seconds they are going to relax. This is the approximate value. All right. What is the exact value? No need to remember. I just wanted to show you. What thing? That how much the difference is there. If you multiply it by 2, it is going to be your relaxation time. That means in a day your heart works only for 8 hours and 16 hours it is going to chill, right? So please remember, double the amount of time it contracts, it is going to relax for the double amount of time, right? So systole is for 8 hours, diastole is for 16 hours in a day, right? So please remember that. That's why whenever I talk about systole and diastole, this is going to be the thing that systole is of 1 time and diastole is going to be for 2 times, right? Why I'm saying and why I'm focusing on that? Because whenever I have to make the average of this, I have to take this time into the consideration, especially if I'm measuring the mean blood pressure or mean arterial pressure. I have to take this duration into the consideration. I know that the diastole is double for the double duration. So I have to take diastole for the 2 times, diastolic BP for the 2 times and SBP for 1 time. So 1/3 of SBP plus 2/3 of diastolic blood pressure. That is going to be the formula for mean blood pressure. We'll see in the blood pressure. Just remember this diagram over here. All right. The formula comes from this. Okay. Now, duration of cardiac cycle is inversely proportional to, it is inversely proportional to the heart rate. That means if you increase the heart rate, the duration for each cycle is going to decrease. That means 0.8 में जो contraction relaxation हो रही थी, now that is going to happen in the 0.7 or 0.6 seconds itself, because you have to contract the heart for more times in a same duration. right? So please remember that when you do the exercise, the cardiac cycle duration is going to be decreased. And when you're chill, you're relaxed, at that time, the duration of cardiac cycle is increased, the heart rate is going to decrease. They are inversely proportional. Absolutely right, Dr. Send enough film. Okay, let's move on. So cardiac cycle is having two parts. We saw that systole and diastole. Please remember, systole is from S1 to S2, and from S2 to next S1, that is going to be diastole. We are not going to talk about the diastole right now. We are going to focus on the systole. We all know that the systole S1 sounds come because of the AV valve closure. Okay, ji, मान लिया. AV valve closure is going to give me the systole. Just give me 1 second because I need a blank slide. But okay, so we are going to divide this S1 to S2. S1 से S2 में I'm going to divide it into three parts. Why? Because I want to know if the murmur is there early, mid, and late. What is this early, mid, and late? It is nothing but the अर्ली सिस्टोल, मिड सिस्टोल एंड लेट सिस्टोल. इसमें स्लाइड नहीं ऐड हो रही है. ओके, अर्ली सिस्टोल, मिड सिस्टोल एंड लेट सिस्टोल. ऑलराइट, ऑलराइट, थैंक यू. So what you have done? Okay, just give me a minute, बच्चों. Just give me a minute. आ रहे हैं आगे. All right, so now we are getting the blank slide. I'm very, very happy. So see over here. Thank you. So, okay. First thing, this is my AV valve. This is my semilunar valve. Okay, AV valve and semilunar valve. AV valve and semilunar valve. All right. Just right. So AV valve and semilunar valve. AV valve, that means it is in between the atria and ventricle, and semilunar valves, aortic and the pulmonary valve. Now I've closed the AV valve, but the semilunar valve was closed. Now tell me, what is the pressure in the systole in the aorta? The pressure in the systole in the aorta is going to be 120 maximum, and during the diastole it is going to be 80, right? This is about the aorta. What about the left ventricle, बच्चों? Systole में कितना होता है? Yes, it is again 120, but during the diastole it is 0 to 5 mmHg. Very, very less as compared to the aorta. You can see over here, it's almost zero. If I want to open these doors, there is one prerequisite. Terms and condition apply. What is the terms and condition? To open this valve, I require ventricular pressure more than the aortic pressure or pulmonary valve pressure. Let's say this is the left atrium and left ventricle, and this is the aorta, right? I need to have more ventricular pressure to open this valve, because this is a valve which can open only one side. Another side, if the pressure is high, this valve will be closed forever. Now, I have such a low pressure. How can I increase pressure? How can I increase pressure, बच्चों? डॉक्टर साहब बताइए कैसे बढ़ाऊं pressure? I'm going to contract. I'm going to contract this ventricle, and that's how, Dr. Saab, I'm going to increase the pressure, right? So, if I start contracting this pressure from 0, it is going to go up to 10, up to 20, up to 50, up to 80. Over here, it is also 80, right? Till that point, my valves are not going to open, but my ventricles are contracting. What should I call it, sir? What should I call it? Just please let me know. क्या बोलना चाहिए हमें यहाँ पर? We are going to call it as isovolumetric. Why? Because the volume is not changing. कैसे करूँ change volume? I have both the valves closed, है ना? So the volume is not going to go outside of the ventricle. It is not going to come inside the ventricle. So volume of the blood is going to be same. I'm going to call it as isovolumetric contraction, isovolumetric contraction, right? Now, because of this, what is going to happen? My prerequisite is going to be met, right? That was एओटिक प्रेशर से ज्यादा मेरा वेंट्रिकुलर प्रेशर चाहिए. एनबी जितना टफ क्वेश्चन पेपर बनाएगी उससे ज्यादा का नॉलेज हमें चाहिए, राइट, टू क्रॉस दैट थ्रेशोल्ड, एंड डेफिनेटली वी आर डूइंग द जॉब फॉर दैट, राइट. सो एनबी से ज्यादा प्रेशर हमें बनाना है कि ऐसे कैसे सारे बच्चों के 200 से 200 करेक्ट आ रहे हैं ना. सो शॉक में आ जानी चाहिए एनबी भी, है ना. सो वेंट्रिकुलर प्रेशर इज मोर देन एओटिक प्रेशर. दैट इज मेट. नाउ व्हाट इज गोइंग टू हैपन? If I cross this 80, it becomes 81. What is going to happen, bacho? Definitely, my this valve is going to be open. And as soon as this valve is open, what is going to happen? The blood started to go outside, which I'm going to call it as ejection, right? So please remember that, है ना? So over here, my SL valve are going to be open. And what will start, bacho? What will start? The ejection will start. I'm going to write the ejection in between over here of the mid systole and late systole. Why? Because ejection has two parts: early ejection, which is also called as a rapid ejection, during which my ventricle is contracting, and for the contraction I require the energy. I'm going to call it as active ejection, right? Active ejection, early ejection, or rapid ejection. In that, I'm going to throw out two-third of the stroke volume. Two-third of the stroke volume will go out. Later on, what happens? Just say if you are driving a vehicle, what happens if you put a brake suddenly? What is going to happen? Your vehicle is stopped, but your body goes forward and then you come back, right? That is known as momentum, right? So same happens over here in the late phase or in the slow ejection. What happens? The blood was in the momentum. The ventricle stopped contracting. It has done its job. It fully contracted during the mid systole itself. But now the blood was in the momentum, and that's why through the momentum it is going to go out. Am I using the energy to contract my ventricular muscle? No, this is because of the momentum, and that's why what is going to happen? Yes, this is going to be called as passive ejection. And how much blood will be ejected? One-third of the ejection is going to occur in the late systole. As soon as all of the stroke volume is ejected outside, what should I do? My ventricles job is done. Now I'm going to relax. And after the class, what you're going to do? I know. है ना? What you're going to do? You're going to भाई बस करो. अब मुझे bed दे दो, है ना? So you're going to chill, है ना? So as you are going to relax after this class, the same is done by the ventricle. As soon as he throwed out all the stroke volume, his job is done. Now he started to relax. But there is a problem. What is the problem? As soon as it start to relax, the ventricular pressure is going to be lower than the aortic pressure. And now no longer this terms and condition is met, and that's why what is going to happen? As soon as this ventricular pressure is going to go down, my SL valve is going to close. The SL valve closure is going to occur. SL valve closure, which makes which sound? S2 sound. S for second, S for SL valve, right? Are we on the right track? Yes, we are on the absolutely right track. S2 sound, absolutely right. All right, so I hope you understood the right. You understood the systole. Let's move on to the diastole. Let's move on. Can I move on? Yes. Thank you. Thank you, Prakash. Right. So S2. क्या होता है S2 बच्चों? S2 is from S2 to S1. I'm going to have a diastole. But what happens is when my ventricle was started relaxing, during that time, SL valve will start to close. But for complete closure of the SL valve, it takes 0.04 seconds. कितना time लगता है? 0.04 seconds is required to close the SL valve. During this 0.04 time, it is called as protodiastole. Protodiastole. क्या होता है ये protodiastole? At that time, the SL valve was open. It was not completely closed, and the ventricle started relaxing. Right? It happens in the diastole. I'm going to include that in the diastole. Why? Because my ventricle is going to go and relax, right? So it is coming in the relaxation phase, but my SL valve is not closed. It is not the S2. It just happened just before the S2. Kitna before? 0.04 seconds. Milliseconds. बहुत ही millisecond. 4 milliseconds होता है ये phase, that is known as proto. Pro means before diastole. Just before the diastole, it is going to happen. Then the S2 sound is going to come. That means the SL valve is going to come, right? And I'm again going to divide that into early, mid, and late phase. Early diastole, mid diastole, and late diastole. Don't get confused between the late diastole and the late filling, right? Don't get confused between mid diastole and the filling, which is early filling. Don't get confused between early diastole and early filling. Both of them are completely different. This early, mid, and late is for murmurs. You are going to learn in the medicine early diastolic murmur, mid diastolic murmur, late diastolic murmur, pan diastolic murmur. For that, this is the phases. All right. S2. Now my S2 valve is closed. So see over here. Again, left atrium, left ventricle. Let's say this is the aorta. My AV valves were already closed, right? Now I wanted to do the filling. My SL valve is closed. SL valve जैसे ही close हुआ, my S2 sound is going to come. Now I wanted to do filling. Filling के लिए this was the pressure. 120 was the highest pressure at the beginning of the diastole. At the end of the systole, 120 was the pressure in the ventricle, right? How much is the pressure in the left atrium during the diastole and systole? It is going to be 0 to 10. 0 to 10 is going to be the pressure inside the left atrium. Let's say it is somewhere in between, let's say 5. Why? Because some amount of venous return is also there. Now, what is the prerequisite to open the AV valve? This is the AV valve, atrioventricular valve. Iska kya terms and condition hai? What is the terms and condition? Over here, I require atrial pressure should be more than ventricular pressure. Then only my valve is going to open up, right? But over here, see, 120 is the pressure. What should I do? What should I do, bacho? I should ask my ventricle to relax so that the pressure comes down, है ना? So that the thakawat goes off, right? As the class is going to over, what you're going to do? The same thing is done by the ventricle, right? So 120, from 120, as soon as my ventricles start to relax, the pressure is come down. Let's say 80 हो गया, फिर 60 हो गया, फिर 20 हो गया, फिर 10 हो गया, right? But this is going to take time. During that time, my ventricles are relaxing, but the volume is not changing. What should I call it? What should I call it? Isovolumetric relaxation. हाँ या ना? बोलो फटाफट. I know you are tired, but let's run through it and let's call the day very, very productive. है ना? Thank you, Dr. Benny. Thank you. कोलकाता से आया मेरा दोस्त. From where you get these names, huh? Isovolumetric relaxation. Isovolumetric relaxation. After that relaxation, see over here, the pressure is going to decrease. And as soon as from 10, it becomes 8 or 5, let's say 5 or 0, what is going to happen? My prerequisite is going to be met and I'm going to open up the AV valve. AV valve open होते ही क्या होगा बच्चों? It start to fill the ventricle, right? First thing, what are the two things which are going to happen as soon as the AV valve is open? पहला, यहाँ पर प्रेशर ग्रेडियंट है, डेल्टा पी मीन्स प्रेशर ग्रेडियंट इज देयर. एंड सेकेंड, इफ आई एम सिटिंग और आई एम स्टैंडिंग, दैट मीन्स आई एम इन अ इरेक्ट position, that means I'm standing or sitting, the gravity is also helping me. Why? Because my ventricles are going to be down and my atria is going to be on the top, right? So atria से ventricle में blood आएगा. So two things are helping me out. Even if I lie down supine, what is going to happen? The gravity is not going to help me out, but the pressure gradient is still there, right? यहाँ पर 10 pressure होगा, यहाँ पर 0 होगा. That means from high pressure to low pressure, the blood is going to come. So please remember, in this filling, my atria is not going to contract, right? As soon as the isovolumetric relaxation is over, the AV valve will be open. And let's write with this pen. AV valve is going to be open. And what is going to start? The filling is going to be starting. Which filling? Ventricular filling is going to start. As soon as the ventricular filling is going to start, it is going to again have a two parts. Early ventricular filling is going to go in the mid diastole, please remember. And late ventricular filling is going to go in the late diastole. All right. Now, I just now told you that the early filling is going to happen with the help of gravity and pressure gradient. It is not. During that time, my atria is not going to contract. So I'm going to call it as passive filling, but it is going to be faster because of these two things. So I'm going to call it as rapid filling also, right? Now, please remember, late filling is during that time, what is going to happen? As soon as I start filling my ventricles, this pressure inside my ventricle from 0, it becomes 5, 6, like that. Let's say it became 5. And because my atria is getting emptied, so that's why the pressure from 10, it becomes 5.5, let's say, right? So the gradient of the pressure is decreased a lot. Now, still some amount of blood is remaining inside my atria. My atria want to fill all the ventricle, right? As the cerebellum wants to do all the things for you, है ना? रात के 10 बजे तक पढ़ा रहे हैं हम आपको. So we also want you to push, है ना? पुश टिल योर बेस्ट लिमिट इज रीच्ड, है ना? जब तक धुआं ना उड़ जाए दिमाग में से, तब तक पढ़ाएंगे, है ना? सो दैट हैपेंस, राइट? सो व्हाट वी आर गोइंग टू डू, वी आर गोइंग टू contract the atria. So that is going to be using the energy. I'm going to call it as active. But there is a twist in the story. What is the twist? In between there is a phase which is going to come when the delta p is almost negligible. At that time it looks as if my heart is stopped in the diastole. My heart is stopped in the diastole, so I'm going to call it as diastasis. Stasis means stop in the diastole. This is the best phase to do the echo if I want to measure the diameter of the valve, diameter of the myocardium, right? So in that phase, the diastasis phase, it is going to be the best because the movement of heart is almost negligible. All right, so please remember that, है ना? इसमें इन दोनों में मिला के 2/3 amount of blood is going to go, and in this phase 1/3 blood is going to go. I don't want to confuse you between the late rapid and early rapid and this and that. This phase is also known as rapid, and some amount of blood go in this phase which is almost negligible, so slow phase is going to come in the diastasis. So please remember that, है ना? Don't get confused. Slow ये वो, just remember early and late and passive and active. Slow होता है जब diastasis होता है because the pressure gradient is very less and it takes some time to atria to contract. Okay, so that's why it is going to be happening that once the atria filled you with all the knowledge, and once the cerebellum took the class till 10 o'clock or 10:20, let's say, we're going to stop the class, and so what is going to happen? The filling is done. Now what is going to happen? It's the time to close the studio, and so we are going to close the AV valve. The AV valve is going to close, है ना? As soon as you start to relax, we are going to close the studio, है ना? So कब relax करना start करेगा? Once your work is done, once you have done, you reach your target. What is the target? Till whatever time the class is going on, I'm going to study no matter what, which is going to make you to sit, and that is going to improve your concentration later on also, है ना? So please remember that, है ना? I'm sorry, I know you are going through a bad phase. I have gone through that also, but please remember, every penny, every second is going to be worth it when you're going to say that, yes, finally, I can write doctor in front of my name. All right, let's move on. Let's move on. So this is the thing that we have studied. Okay. And we haven't solved any question on this. So if I have to give a small chart, so please remember, ये chart बना लो बच्चों. इसको मत्था टेक के सोना है हर रोज, है ना? Systole and diastole, systole and diastole. And over here I'm going to write isovolumetric phase, and I'm going to write volume change over here, right? So please remember isovolumetric phase. Systole में हुआ तो I'm going to call it as isovolumetric contraction. Diastole में हुआ I'm going to call it as isovolumetric relaxation. Volume change में I'm going to do 2/3 early phase, right? First, and then 1/3 late phase. Okay. Now, early, if there is a systole, I'm going to call it as early. What thing? Early ejection. Early ejection and late ejection. I'll write in between. Early ejection or late ejection, right? And if I'm having the diastole, I'm going to call it as ventricular filling. है ना? इसको रोज मत्था टेक के सोना important है. Every year, every other year, they are giving this question, so very important. All right, let's move on to the next question. ये वाला solve करो बच्चों. Pressure changes in the jugular vein during the single cardiac cycle measure किया, और what they have asked following denote the period of atrial systole. Atria कब contract करता है? Atrial contraction में कौन सी wave? Lovely, there is someone known as Oppenheimer also, है ना? Please, अगर bomb बनाया तो NBA पे एक डाल ही देना, है ना? So atrial systole is going to give me the A wave. Absolutely wonderful, है ना? So he's giving the permission. Hopefully no one is there from the NBA, है ना? वरना मैं मुझे वो गाना गाना पड़ेगा, मैं चली जेल के पीछे मैं चली, है ना? So let's talk about this. We are going to attach the transducer into the jugular vein, which is going to give me the right atrial pressure, and I have the right atrial pressure as the central venous pressure. So इसी को JVP भी बोलता है, that is jugular venous pressure. इसी को I can call the central venous pressure, and this pressure is also known as right atrial pressure because I'm going to attach the transducer at the jugular vein, right? And there is no valve in between, so that's why it is the same. कैसे याद रखोगे? A for the atrial relaxation. So please remember over here, A for the atrial contraction, sorry, A for the atrial contraction. Whenever the pressure inside the right atrium is going to increase, I'm going to get the upstroke or upward deflection, right? Whenever the pressure inside the right atria is going to decrease, when the atria is relaxing, at that time, I'm going to get a downstroke. Okay, so please remember this depicts the pressure is increasing or decreasing into my right atrium, right? So C क्या होता है बच्चों? C is when the tricuspid valve bulges, है ना, tricuspid valve bulging into the right atria. At that time, what happens during the isovolumetric contraction? What happens? The ventricles are contracting, but both the valves are closed. So what happens in the tricuspid valve? The tricuspid valve cannot open into the atria, right? But it bulges into the atria, and because of that bulge, what happens? My atrial pressure is going to increase for a time being, and that is known as the C wave. All right. So please remember that. What is the X? X and Y, they are downstrokes. So I'm going to call it as descent. जब भी नीचे जाते हैं, we call it as descent, right? X descent is because of the atrial relaxation. Atrial relaxation. And what is the Y wave? Atrial emptying. Atrial emptying, right? How to remember over here? See, atrial relaxation, atrial emptying. X and Y is coming, so please remember that. Atrial relaxation, that means the ventricle must be contracting. And please remember, if I draw the ventricular thing over here, it is going to be called as ejection. Ventricle का मैंने रेड पेन में लिखा है. Ventricle में क्या चलेगा इस टाइम पे? Ventricle में ejection is going to go on. What about the V wave बच्चों? V wave, please remember V for venous return है ना? Venous return is going to be there. Venous return में क्या होता है? From the veins, the blood is going to come back to my right atria, right? And my atria is getting filled up. So can I write atrial filling over here? Yes, absolutely. The atria is filled up over here, and that's why I can write it as atrial filling also. All right. Please remember that. And if I ask you V for IVR, that means isovolumetric relaxation. In the ventricle, isovolumetric relaxation is going to go on. अगर IVR आए, VR आए, तो please remember it is V. Y is because of atrial emptying, X is because of atrial relaxation. Please remember that ejection के time पे X descent आएगा. There is something known as X dash, है ना? X dash, इसको हम X dash बोलते हैं. क्या है ये X dash? इस पूरे को X बोलते हैं और इसको हम X dash बोलते हैं. Alright? पूरे को X बोलते हैं और इसको हम X dash बोलते हैं. All right. So what is this X dash? X dash is nothing but जो tricuspid valve bulged into the right atria because of which the C wave came. That as soon as the ejection will start, जैसे ही semilunar valve is going to open up, this bulged TV is going to come back to its normal position. As soon as it's come back to normal position, this X dash is going to come. So this X dash is because of, I'll just wrap this up. This X dash is because of what thing? This X dash is because of, yes, please, tricuspid valve returning to its normal position. And for normal, please write it down. Normal position. All right, simple. Need में पूछा गया हुआ है. That's why I have mentioned over here. All right. हाँ, pressure decrease हो जाएगा. That's why. All right, let's move on. We have discussed about lot many pressures. Let's discuss about some volumes. अब नाम में इसका काम है. See over here. End diastolic volume. What do you mean by end diastolic volume? At the end of the diastole, whatever amount of blood is there, whatever amount of volume is there inside my ventricles, at the end of the diastole, I'm going to call it as end diastolic volume. What do you mean by diastole? What do you mean by diastole? Diastole means relaxation, right? During the ventricular relaxation, whatever volume was there, right? So amount of blood volume filled into the ventricle, कितना होता है? 120 to 130 ml, right? And that is dependent on the preload or ventricular this venous return है ना? जितना venous return आएगा, जितना वेन्स रिटर्न करेंगी उतना ही तो मुझे मिलेगा, राइट? हाउ मेनी मार्क्स यू आर गोइंग टू गेट इन द एग्जाम, दैट इज गोइंग टू बी द वीनस रिटर्न फॉर मी, है ना? जो आप मुझे रिटर्न दोगे दैट इज माई अचीवमेंट। इफ माई बच्चा पार्टी गॉट ऑल द क्वेश्चंस करेक्ट, आई विल बी द मोस्ट हैप्पीएस्ट पर्सन, है ना? सो दैट इज गोइंग टू बी द वीनस रिटर्न। यू हैव टू रिटर्न मी ऑल 100% बैक, है ना? सो दैट इज द ईडीवी. Now, what is the stroke volume? Stroke volume means in one stroke. In one stroke, my ventricle, how much blood it can eject, that is in the one stroke, that is nothing but the per beat. The blood, amount of blood that is pumped by my ventricle in one beat, that is called as stroke volume. कितना होता है stroke volume? That is going to be 60 to 70 ml. 60 to 70 ml. इस स्लाइड से एक क्वेश्चन पक्का आएगा. So please, please, please remember this slide. Very, very important. रोज मत्था टेक के सो इसको, है ना? It takes only 5 seconds to go through this slide. So एक बारी मत्था टेक के सो जाना, है ना? So please remember that. End systolic volume is nothing but at the end of systole, that means जैसे ही मैंने contraction complete की, at the end of systole, whatever amount of volume is left inside it. How I can calculate that? See over here, see carefully that यहाँ पर EDV मतलब जितना blood आया during the diastole and जितना जाने के बाद जितना गया, that is stroke volume. जितना बचा after the stroke volume, that is called as end systolic volume. So how can I calculate the stroke volume? क्या होगा stroke volume का formula? कितना आया था EDV, right? And उसमें से सॉरी ESV का फॉर्मूला क्या होगा? ESV का फॉर्मूला क्या होगा? हाउ कैन आई कैलकुलेट द ESV? ESV स्ट्रोक वॉल्यूम भी आप लिख सकते हो कि EDV कितना आया था, उसमें से मैंने ESV माइनस कर दिया, राइट? एंड इफ आई कैलकुलेट द ESV को उधर ले जाओ, स्ट्रोक वॉल्यूम को इधर ले आओ. द सेम थिंग, ESV कैन बी कैलकुलेटेड एज EDV minus SV. EDV minus SV, that is going to be ESV. SV is going to be equal to जितना ब्लड आया था और जितना बचा है, इसका मतलब बीच वाला कहाँ गया? That is going to be ejected outside. So remember this formula. You're going to require this formula. I have put up the question on this. So please remember that. Ejection fraction. इजेक्शन फ्रैक्शन ऑलवेज द परसेंटेज इज गोइंग टू बी बेटर, है ना? लेट्स से किसी को 5 मार्क आए, किसी को 100 मार्क्स आए, राइट? इफ वन पर्सन गॉट 5 मार्क्स, वन पर्सन गॉट 100 मार्क्स, हु इज द विनर? I don't know the winner because I did not ask. The question paper was of how many marks, है ना? So if he got 100 marks out of 500, then it is only the 20% marks he got, right? So I'm not going to be call it as passing percentage, right? On the other hand, he got 100%. So percentage is always better. So I'm going to calculate the percentage. अगर 55% से ज़्यादा है तो you are pass, है ना? So that means it depicts the ventricular efficiency. Your ventricle is efficient. You have studied efficiently, then you are going to pass. That is 50 से ज़्यादा आया, 55% आया, you are going to pass, है ना? 50 से कम आया, that is going to be giving me the sign of failure, heart failure. Right? If my ventricles are not going to contract even 40%, they are not able to eject the blood, I'm going to call it as failure, right? 50 से कम आया, that is 45% या 40%, it is going to be ventricular failure. How to calculate the ejection fraction? Formula याद रखना, it is going to be SV upon EDV. SV upon EDV. And if I have to convert that into percentage, I'm going to multiply it by 100. That is going to be the ejection fraction. क्या है ये? It is the percentage of blood pump. Percentage of blood pump. एक stroke में कितना गया? That is going to be stroke volume. Percentage calculate किया उसी का, that is going to be ejection fraction. Per minute calculate किया, what you are going to call it as? Per minute कितना मेरा blood बाहर डाल सकता है? That is going to be your cardiac output. Cardiac output. In one stroke, how much my ventricle ejected the blood? That is called as stroke volume. How many such stroke happens per minute? That is given by the heart rate, right? So stroke volume into heart rate is the formula for my cardiac output. If I take the cardiac output per unit body surface area, it is called as cardiac index. It is called as cardiac index. Cardiac output calculate करने के लिए I need something known as Fick's principle. Just नाम याद रख लो, Fick's principle. Fick's principle, it's not the Fick's law. यहीं पे लिख लो, Fick's law कहाँ पर काम आता है? Fick's law is useful in the calculation of diffusion, right? And fixed principle is useful for the measurement of cardiac output. Remember that, okay? Please remember that. All right, let's move on. Frank Starling law is also known as heterometric regulation. That means I'm going to change the length, है ना? Heterometric, that means hetero means change the length and measure or increase the output. कैसे होगा? Initial length, what it says, Frank Starling law says that जितना initial length बढ़ाओगे ना मसल का within the physiological limit, it is going to give you more output. For example, if the rubber band is there, more I stretch the rubber band, more with the more force it is going to contract. But that is within the physiological limit. If I stretch it too much, it is going to break away. That is not going to recoil back. Okay, so please remember this should happen within the physiological limits. So if I increase the venous return, what is going to happen? Venous return is more. That means end diastolic volume is going to increase. As the end diastolic volume is going to increase, what is going to happen? My initial length is going to be increased too. And as soon as the initial length is going to increase, what is going to happen? There will be stretch of the muscle fiber. It's like a balloon. If you fill the water in that balloon, the balloon is going to stretch, right? During that time, two things are going to happen. There will be increase in the actin myosin cross bridge formation. जितने ज्यादा क्रॉस ब्रिज बनेंगे उतना ज्यादा फोर्स ऑफ कॉन्ट्रैक्शन बनेगा. द फोर्स ऑफ कॉन्ट्रैक्शन इज डिपेंडेंट ऑन व्हाट इज दिस एफओसी. एफओसी इज नथिंग बट फोर्स ऑफ कॉन्ट्रैक्शन. I'll write it completely. Force of contraction is going to increase, bacho, and that is going to give me the more stroke volume. More stroke volume, that is nothing but the output. Input kya tha? Input was my venous return. Input to my heart is the venous return. Output from my heart is going to be the stroke volume. Up input increase karo, output is going to be much more, right? Increase the input, increased will be the output. All right. And the another thing that is going to happen, the troponin sensitivity, trop T sensitivity or trop C sensitivity. Troponin C, that means where the calcium is going to bind, troponin C sensitivity is also increased. याद रखना है, रख सकते हो, otherwise you can just let it go. Okay, at least remember that the actin myosin cross bridges is going to increase. And please remember, for the contraction we always require calcium. Calcium is ultimately important. Okay, the calcium is going to increase and the calcium binding to this troponin is going to increase, and hence the contraction will be increased. Are you with me? Are you with me, or you have slept? Okay, tell me. Yes, okay, let's move on. एक और चीज देख लो यहाँ पर क्या दिखा रही है ये. This is depicting what law? It is तनुज is saying slept. तो मैसेज कौन कर रहा है? डॉक्टर तनुज है ना. So see over here, overlapping. If you increase the overlapping within the physiological limit, contraction में क्या होता है बच्चों? Contraction में the length of the muscle is decreased. So I'm going to come from the right towards the left. Okay, so see over here, यहाँ पर overlapping कम थी. As you increase the overlapping, what is going to happen? As you increase the overlapping, the more and more cross bridges happens, but it should be within the physiological limit. If you overlap a lot, what is going to happen? Rather than actin myosin overlapping, the actin, both the sides actin, they are overlapping each other. So actually it is not the efficient overlapping. I want actin myosin to overlap, not actin. Okay, so that is not going to be heterometric, that is going to be homo, जो कि आजकल legal है, but we are not going to talk about it, है ना. So please remember, we are talking about heterometric. We have to contract it in a physiological limit, right? So हम हमारी limit में रह के बात करेंगे. All right. So यहाँ तक क्या हो रहा है? You can see over here, till the time I contracted in the physiological limit, my force of contraction has increased. But later on, if I go beyond the physiological limit, it is going to decrease. So please remember that. Okay. So this is showing the Frank Starling law. ऐसा कुछ graph आए, and if they ask the law, please tell them that this is the Frank Starling law. इसका आंसर दो फटाफट से मुझे. What is the answer of this question? डॉक्टर लायन, इट इज नथिंग बट जितना आप कॉन्ट्रैक्ट करोगे ना उतना. ओ दैट प्रीवियस स्लाइड में क्या नहीं समझ में आया बच्चे? प्रीवियस स्लाइड में आई हैव शोन दिस दैट इफ यू कॉन्ट्रैक्ट, दिस इज शोन द फोर्स ऑफ कॉन्ट्रैक्शन. देखो ये रेस्टिंग लेंथ ऑफ द मसल दिखाया है और ये टेंशन दिखाया है. टेंशन क्या है कि कितना आपका स्ट्रोक वॉल्यूम होगा, दैट इज नथिंग बट योर टेंशन, राइट? एंड दिस इज शोन द the resting length, and this is nothing but, ये graph क्या depict कर रहा है? This is depicting the force of contraction, right? This is depicting the myosin fiber, this is depicting the actin fiber. जितना actin myosin cross bridges होगा, कौन सा cross bridge? Actin myosin cross bridge होगा. जितना ज्यादा cross bridges बनेंगे उतना ज्यादा force of contraction होगा. बट इफ आई गो बियॉन्ड द फिजियोलॉजिकल लिमिट, इससे ज्यादा कॉन्ट्रैक्ट करूंगी, बहुत ज्यादा कॉन्ट्रैक्ट कर लिया, तो एक्टिन एक्टिन ओवरलैपिंग होगी. यहां पर एक्टिन एक्टिन दे आर ओवरलैपिंग ऑन ईच अदर. इफ यू कैन सी ओवर हियर, I don't want actin actin overlap. I want actin myosin overlap. And that's why the force of contraction is going to reduce over here. It is going to reduce beyond the physiological limit. So please remember, जैसे आप ओवर स्ट्रेच करोगे या ओवर कॉन्ट्रैक्ट करोगे, आपका फोर्स ऑफ कॉन्ट्रैक्शन कम होगा. बट अगर आप फिजियोलॉजिकल लिमिट में रह के करोगे, then the efficiency is going to be maximum. I hope, Lion, you understood this. है ना? You have given the absolutely correct answer. That is arteriole. We talked a lot about the heart, है ना? But we have talked scientifically, है ना? ऐसे हमने बात नहीं किया कि तुम्हारे दिल में रहना है, ये रहना है, वो रहना है. We are not streptococcus to live in someone's heart, है ना? We want the place in the limbic system. Why limbic system? Because the emotions are generated by limbic system. Another question, है ना? So please remember that. दो दिल होते तो पहले हम आपको इमरजेंसी में भेजते हैं, है ना? क्यों? Because it's a गहरा वाला म्यूटेशन, अ बिग डेंजरस म्यूटेशन, है ना? वी डोंट वांट दैट, है ना? लेट्स मूव ऑन. Types of blood vessel. Types of blood vessel. There are 5 types of blood vessel depending on their properties. Wind Kessel vessel. Wind Kessel vessel में क्या property होती है बच्चों? It has the elasticity. Elasticity. And how it is helpful? Elasticity say I'm going to get the diastolic blood pressure. Let's understand that via the diagram. Suppose this is your ventricle and this is your aorta. As soon as the ventricle contracts, what happens is it is going to throw the blood in the aorta. Aorta is like a rubber band. It has a lot of elastic fibers, right? What is going to happen as soon as the blood hits this aortic valve? This aortic valve is going to stretch. It is going to stretch like this, and the blood start to accumulate inside this. As the blood is coming out of the ventricle, the aortic valve is going to stretch. But as soon as my systole is over, systole over होने के बाद क्या होगा? At that time, what is going to happen? Let's say this was the condition. Now my systole is over. Now this SL valve, that is aortic valve, is going to be closed. No one is there to put the more blood onto my aorta. The aorta, which was stretched before, what is going to happen now? It will come back to its normal position. It will come back to its normal position. And please remember, when it was coming back to the normal position, what is going to happen? Whatever blood that was accumulated in the aorta, it is going to come back and it is going to come into the flow, right? So please remember, at that time, my ventricles are relaxing. That means it is the diastole which is going on, है ना? But still the blood pressure is maintained. Thanks to what? Thanks to the aortic recoil. Aortic recoil is going to be the property because of which I'm going to get the diastolic blood pressure. Ventricles themselves are relaxing. If you are relaxing, you cannot put the pressure of studying onto some other person, right? You yourself are relaxing, right? So जो खुद relax कर रहा है वो किसी और पे pressure नहीं डाल सकता. Please remember, this is not because of the ventricle. This is because of the aortic recoil. The diastolic blood pressure is because of the aortic recoil. All right. So what is the property? Elasticity. किसमें होता है? Aorta and all large arteries. Large arteries. Aorta and all the larger arteries, they do have this wind Kessel effect. क्या है wind Kessel? Stretch करो तो contract करता है pressure जाने के बाद. Elastic rubber band, remember that, है ना? Next, capacitance vessel. What do you mean by capacitance vessel? It has the capacity to store the blood. It has the stretchability, but it is like a chewing gum. If you chew the chewing gum and you stretch them, they will not come back as the elastic rubber band do, right? So what is going to happen? They will remain in that stretched condition unless and until you compress it back, right? Disgusting example, but yeah, that is how it is going to occur, right? So they have a lot of high compliance. So please remember, high compliance is going to be there, and whenever you want to contract them, you can contract them. Who is having this property? The property is there in what thing? Property is there in the veins, larger veins, है ना? You want break? विल टेक मोर टाइम देन 10:30 तक चलेगी क्लास, है ना, वो बहुत लंबा हो जाएगा बच्चे. I'll go with the maximum students. What they are saying? They are saying no. I'm getting the no comments in the Zoom, है ना, because लंबी हो जाएगी फिर क्लास, आप थक जाओगे, है ना. थोड़ा सा पानी वानी पी आओ. You just note down this slide, है ना. You can watch it later, है ना. 5 मिनट आप खुद ले सकते हो. Veins are going to have, especially the systemic veins, है ना. Please remember that. Exchange vessel. Who is the best exchange vessel? Who are porous? Porous मतलब क्या होता है, जिसमें holes होते हैं, है ना. Permeability. Permeability is going to be the property of the capillaries, and they are arranged in the parallel, so that's why they have the low resistance. Low resistance, है ना. Low resistance is going to be your capillaries, right? So capillaries are going to be helpful in the exchange because ये बहुत thin होती है. There are very thin vessels, thin and porous vessel. ये क्या हो गया, इसको भी ब्रेक चाहिए लगता है. थिन एंड पोरस वेसल, है ना. थिन एंड पोरस वेसल्स, दे आर नथिंग बट योर एक्सचेंज वेसल्स, ऑलराइट. एंड वेन्स के बारे में एक और चीज याद रखो. जब हम शॉक में जाता है कोई पेशेंट, जैसे फॉर एग्जांपल समवन हैड द एक्सीडेंट एंड दे वेंट इनटू द शॉक, दैट इज hypoperfusion condition. During that time we are going to cause the activation of sympathetic system, which is going to cause venoconstriction, and because of that whatever blood was stored, now that comes into the flow, so it prevents us from the shock. So please remember that also. Okay, कौन prevent करता है? veins prevent करती है हमें shock से. Resistance vessel. Who is going to give the resistance maximally? जिसमें maximum smooth muscles होंगे. Who is going to have the maximum smooth muscle? They can contract the vessel maximally. So please remember, whomsoever is going to have maximum smooth muscle in the tunica media, they are going to give me the maximum resistance. And who are they, बच्चों? Who are they? Arterioles. My बच्चा पार्टी already gave me the answer. I'm very very happy, है ना. Conduit vessel, यहाँ पर हमने already पढ़ लिया था. Why? Because they have asked about the maximum resistance. You already gave me the answer. I'm very very happy, है ना. कंड्यूट वेसल क्या होता है? कंड्यूट मीन्स कंडक्शन, है ना. जस्ट कंडक्ट करना, कहां से कहां तक? पॉइंट ए से पॉइंट बी तक. ओके, व्हाट वी आर डूइंग द कंडक्शन, है ना. हम बुक से नॉलेज लेते हैं एंड वी कंडक्ट इट टुवर्ड्स यू, है ना, सो दैट यू कैन पास द एग्जाम. सो दैट इज द रोल ऑफ द आर्टरीज, स्मॉलर आर्टरीज. व्हाट दे डू? They just transfer the blood from one point to another point. That is the function of the conduit vessel. So please remember that also. All right, done. आगे बढ़े, फटाफट बढ़ जाते हैं आगे. इसका आंसर दो मुझे, क्या है? What is the answer of this question? देखो, ध्यान से देखो, यहाँ पर क्या बोला हुआ है. कोई हाइपोवोलेमिक कंडीशन में आया, फाइन फाइन फाइन. डिक्रीज ब्लड फ्लो टू द टिश्यू ब्रेड फ्रॉम द फॉलोइंग ऑप्शन. इफेक्टिव पैरामीटर, मोस्ट इफेक्टिव पैरामीटर पूछा है. ब्लड फ्लो को कंट्रोल करने के लिए विच इज द मोस्ट इफेक्टिव पैरामीटर? हाँ जी बताइए, क्या होता है? उसके लिए एक लॉ सुनेंगे हम, है ना. आंसर्स मुझे डिफरेंट डिफरेंट आ रहे हैं. किसी ने ए बोला है, किसी ने बी बोला है, किसी ने सी, कोई डी भी बोल ही दो, है ना. मैम आप चूज कर लो, है ना, कौन सा चाहिए. ओके, सी ओवर हियर देयर इज सम फॉर्मूला व्हिच इज नोन एज फ्लो फॉर्मूला. फ्लो क्या होता है? फ्लो इज इक्वल टू डेल्टा पी. डेल्टा पी क्या होता है बच्चों? इट इज द प्रेशर ग्रेडियंट, है ना. अगर मैं ऐसे एक वेसल निकालूं, यहाँ पर जो प्रेशर है, आई एम गोइंग टू कॉल इट एज P1 and P2 over here. P2 minus P1 is going to be my pressure gradient and upon resistance, है ना. Now this resistance का formula is given by this Poisson-Huygens, है ना. They were the scientists who gave the formula for the resistance. They said that the resistance का formula is 8 eta L upon pi r raised to 4. Pi r raised to 4, that means the radius is going to have the fourth power, है ना. So ये eta क्या है? 8 eta. Eta is the viscosity. 8 eta L. Eta is the viscosity, L is the length, and R is the radius, है ना. छोटा वाला R is always radius, बड़ा वाला R is always resistance. Please remember, capital R is always resistance, है ना. फाइन, एंड छोटा वाला R is radius. ऑलराइट, सो अगर मैं ये वाला फॉर्मूला यहाँ पर पुट करती हूँ, दिस फॉर्मूला इफ आई पुट अप इन द फ्लो का फॉर्मूला, व्हाट इज गोइंग टू हैपन? सी, फ्लो इज इक्वल टू डेल्टा पी, हम ऊपर ही रखेंगे, आर की जगह ये वाला फॉर्मूला डालेंगे. क्या है? 8 eta L अपॉन पाई आर एस टू फोर, डिनोमिनेटर becomes न्यूमरेटर, है ना, तो हम यहां पर लिखेंगे इसको पाई आर रेस टू फोर, पाई आर रेस टू फोर. Now if I ask you, if I double the radius, what is going to happen? Suppose करो पहले r is equal to 1 था, फिर मैंने r is equal to 2 कर दिया, बट जब मैं फॉर्मूला में डालूंगी it is going to be r रेस टू 4, है ना, so it becomes 1 रेस टू 4, है ना, that means 1 into 1 into 1 into 1. कितना आएगा आंसर? इज गोइंग टू बी 1. बट जैसे ही आपने रेडियस को डबल कर दिया, इट इज, इफ आई पुट इट इनटू द फॉर्मूला, इट इज गोइंग टू बी आर रेस टू फ्लो 4. तो फ्लो कितना बढ़ेगा बच्चों? 2 इंटू टू इंटू टू इंटू टू, कितना बड़ा? 16 गुना, है ना. So 16 times more it is going to increase. When you say that ma'am we do not require the break, so we also get the motivation कि बच्चा इतना energetic है, we should be double energetic, है ना. So our motivation goes high as 16 times, है ना. 16वें आसमान पे होते हैं. Why I am saying so? Because it is very very important. पॉइजले पे बहुत बारी क्वेश्चन आया हुआ है. अगर आप रेडियस को डबल करते हो, रेडियस को डबल कर दिया तो दैट बिकम्स डायमीटर. सो please remember the radius is the most important factor in this. Radius is most important factor in the whole scenario, है ना. क्यों? क्योंकि इसके पास फोर्थ पावर है, फोर्थ पावर, 4 गुना की पावर है इसके पास, है ना. रेडियस ऑप्शन में नहीं है. आई एम गोइंग टू चूज डायमीटर. मोस्ट ऑफ यू गेव द आंसर करेक्टली. ओके, इसका आंसर सी नहीं है, याद रखो, इसका आंसर ए है. आर्टीरियल्स कैन चेंज द पैरामीटर, बट दे आर अगेन एक्टिंग ऑन द वेसल का डायमीटर itself, है ना. सो इनडायरेक्टली इट इज गोइंग टू बी डायमीटर ओनली, है ना. तो रेडियस इज गोइंग टू हैव द फोर्थ पावर. सो प्लीज रिमेंबर दैट. कमिंग टू द टाइप्स ऑफ ब्लड प्रेशर. ब्लड प्रेशर कितने टाइप का होता है बच्चों? 4 टाइप्स ऑफ ब्लड प्रेशर आर देयर, है ना. सिस्टोलिक ब्लड प्रेशर, डायस्टोलिक ब्लड प्रेशर, पल्स प्रेशर एंड मीन आर्टीरियल प्रेशर. हमने मीन आर्टीरियल के बारे में ऑलरेडी बात कर ली थी. मीन आर्टीरियल प्रेशर मैंने क्या बताया था? सिस्टोल इज फॉर 1 टाइम एंड डायस्टोल इज फॉर 2 टाइम्स, एंड दैट्स व्हाई whenever I'm going to do the average of the systole and diastole, I cannot write systolic blood pressure plus diastolic upon 2. Why? Because the duration of systole and the duration of diastole is completely different. Systole is only for the 1 time, diastole is for 2 times, है ना, double that of the systole. So I'm going to write 2/3 of diastolic blood pressure plus 1/3 of systolic blood pressure. I can convert it into the form of pulse pressure. So I'm going to write it as diastolic blood pressure plus 1/3 of pulse pressure. You can use any of the formula. If you cannot remember all of that, at least please remember 2/3 of DBP plus 1/3 of SBP via this formula. Coming to the systolic blood pressure, ventricular contraction, whenever the ventricles are going to come in the systole, that is going to give me what thing? That is going to give me the systolic blood pressure. किस पे dependent है? कितना blood pressure बनेगा? How much blood pressure is going to be put up on my vessels? It is dependent on two things: how much stroke volume is there and how much compliant my vessels are there. All right, so it depends on the systolic the stroke volume and this compliance. Okay, it is due to the ventricular contraction. Please remember that. The questions are going to be asked on the diastolic blood pressure. Diastolic blood pressure, बताइए जी ये किसके वजह से था? You are going to tell me, and it depends on the total peripheral resistance. Depends on the total peripheral resistance. Pulse pressure is the difference between the diastolic and systolic blood pressure. So systolic blood pressure is usually more than the diastolic blood pressure. So this is going to be the formula for the pulse pressure. हाँ जी बताइए किसके वजह से था मेरा डायस्टोलिक ब्लड प्रेशर? बताओ जल्दी जल्दी बताओ. वेरी गुड. आधीश, Adi Seshan and Prakash, right? Abhishek, absolutely correct. So what is going to happen over here? Yes, it is because of the aortic recoil. Aortic recoil. All right, what is happening? This is because of the aortic recoil. We have saw that already in the wind castle vessel, है ना. तो ये तो हमारी हो गई स्लाइड डन, है ना. So please remember SBP minus GBP is going to be the pulse pressure. अब रेगुलेशन पे आते हैं. How it is regulated? Please remember, when the BP is high, you want to lower down the BP. When the BP is low, you want to increase the BP, है ना. So increase decrease का खेल चलना चाहिए. So when you have higher BP, you have to apply the brakes. Who are going to apply the brake? Brakes are nothing but the baroreceptors. Baroreceptors are going to be the brakes, and brakes, when I am going to apply the brakes, I'm going to inhibit the motor. Motor को हमें रोकना है. एंड इनिबिटरी को हमें एक्टिव करना है. दैट मीन्स द कार्डियो इनिबिटरी सेंटर इज गोइंग टू गेट एक्टिवेटेड, विच इज ऑल्सो नोन एज कार्डियोवेगल सेंटर. आई एम गोइंग टू एक्टिवेट द कार्डियोवेगल सेंटर. Please remember the baroreceptors are also known as brakes to the BP. Brakes to the BP are nothing but the baroreceptor. एक्सिलरेटर कौन है? अगर मुझे बीपी को बढ़ाना है, when my BP is falling down, my speed is low, I'm going to increase the BP via putting the foot on the accelerator. Who is the accelerator? The accelerator is nothing but my chemoreceptors. Chemoreceptors. है ना? So please remember, when I want to lower down the BP, I require brakes to apply. है ना? But when I want to increase the blood pressure, I'm going to activate the chemoreceptor, which is nothing but the accelerator. Accelerator में क्या करोगे यार? मोटर को एक्टिवेट करोगे and inhibition को inhibit करोगे, right? When you activate the motor, your speed is going to be increased, so you're going to activate VMC and you're going to inhibit the CIC or CVC. Easy, बस इतना याद रखो. There's one more thing you have to remember, that what is the range? Range is 60 to 200 mmHg. ये किसका रेंज है बच्चों? किसका रेंज है? This is the range of mean blood pressure or mean arterial pressure. Right? One and the same thing. Okay? और इसका रेंज क्या होता है? 40 to 60 mmHg. 40 to 60 mmHg is the range of chemoreceptor activation. So please remember this chart more than enough. Okay? ये कौन सा रेगुलेटरी मैकेनिज्म है? फीड फॉरवर्ड है, फीडबैक है, पॉजिटिव फीडबैक है, नेगेटिव फीडबैक है? बताना जरा, बीपी रेगुलेशन कैसे हो रहा है यार? ये कुछ समझ में आ रहा है? जब बढ़ा तब कम कर दिया और जब कम हो गया तो बढ़ा दिया, क्या है ये? एब्सोल्युटली वंडरफुल खुशी. इट इज द नेगेटिव फीडबैक. नेगेटिव फीडबैक. ये बताओ, आपका हार्ट दुक 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 कब करता है? When it is going to cause tachycardia, which is the following reflex, which is tachycardic reflex. गलत आंसर बताया, वहीं आके डंडा पड़ेगा, है ना? If you give me the wrong answer, if you give me the wrong answer, I will leave you on these bridges. क्या है ये bridges? They are very very scary bridges without any life support, है ना? So ऐसे scary bridges पे मैं छोड़ाऊंगी. If you do not scare via the heights, ऐसे एकदम सुनसान जगह पे एक रात के लिए छोड़ाएंगे आपको, है ना? सो दीज आर स्केरी ब्रिजेस वाई आर गोइंग ऑन विच यू आर गोइंग टू हैव द टैकीकार्डिया. दुक 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 दुक, है ना? सो प्लीज रिमेंबर, कब होता है आपको टैकीकार्डिया? जब आप ब्रिज पे जाते हो, ऐसे स्केरी ब्रिजेस पे जाते हो. सो प्लीज रिमेंबर, द आंसर इज नॉट ए, इट इज बी, है ना? सो बेन ब्रिज रिफ्लेक्स, ब्रिज पे जाते ही टैकीकार्डिया होता है. देयर इज ओनली टैकीकार्डिया रिफ्लेक्स, दैट इज बेन ब्रिज रिफ्लेक्स. पता चले इसको, है ना? सो क्या है बेन ब्रिज रिफ्लेक्स? चैट से ढूंढवा के मैं आप लोगों को छोड़ के आऊंगी जिन्होंने ए आंसर दिया है, डोंट वरी, है ना? सो बेन ब्रिज रिफ्लेक्स, बेन ब्रिज रिफ्लेक्स, that is going to be when you give the rapid infusion of any fluid, आपका venous return is going to increase, है ना? IV fluid whenever I'm going to give, ultimately it is going to go in the veins, ultimately it is going to go in my right atrium. What is going to happen? My heart started to do duk 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 duk. Why? Because there is a indirect and direct stimulation of SA node. When I stimulate my SA node start to beat or start to produce action potential on a higher frequency, that is the heart rate is going to increase. So जब भी आप ये word पढ़ोगे bridge bridge bridge, यू आर गोइंग टू रिमेंबर टैकीकार्डिया, है ना? जब भी हम ऐसे ब्रिजेस पे जाते हैं, क्या होगा? टैकीकार्डिया. नाउ व्हाट इज द बेजोल्ट जायरिश रिफ्लेक्स? बिजार चीजें अगर आप करोगे, व्हाट इज बिजार? बिजार मींस सम ऑकवर्ड थिंग्स, है ना? साइंटिस्ट को ऐसे कुछ खुमार चढ़ता है ना, एंड दे डू सम बिजार थिंग्स. व्हाट दे हैव डन? दे हैव गिवन द इरिटेंट्स आईवी. क्यों देना है भैया, है ना? when you give irritants IV, when you give bizarre things IV, what is going to happen? Your heart rate and respiratory rate and your blood pressure, everything is going to go down. It is going to shut down for some time. उनको समझ ही नहीं आएगा what is happening, why you are giving the IV irritants. That is why you are doing such bizarre things. When you give bizarre things, your respiration and the CVS system says shh, कोई है, that means you are going to decrease everything. You are going to decrease the respiratory rate. Even for some time it is going to stop, है ना? तो heart rate, BP and apnea को करना है, शांत करना है. सो प्लीज रिमेंबर, जब भी बिजार चीजें करोगे तो जायरिश रिफ्लेक्स आएगा, करना है. ट्रायड भूलना नहीं, है ना? ट्रायड भूलना नहीं. कुशिंग्स में क्या याद रखना है, कुशिंग्स इज फॉर क्रेनियल टेंशन, है ना। कुशिंग्स जब होता है सो क्रेनियल टेंशन बढ़ता है, बिकॉज ऑफ विच योर वेसल्स आर गोइंग टू कंप्रेस, एंड वेसल्स आर गोइंग टू कंप्रेस at that time hypoxia is going to take place, which is going to stimulate strongly your vasomotor center. That is going to increase the bp, but your baroreceptor, as soon as your bp is going to increase, your baroreceptor is going to get activated, and that is going to decrease the heart rate, है ना। so bp increase हो रहा है, heart rate decrease हो रहा है, so your respiratory rate doesn't know what to do. So it is going to cause the irregular breathing. Irregular, कभी बढ़ती है कभी कम होती है, कभी बढ़ती है कभी कम होती है. One is going to increase, one is going to decrease, and the regular irregular respiration is going to take place. So ऐसा उल्टा पुल्टा हो रहा है, तो that is going to be the cranial tension. जब यहाँ tension बढ़ जाती है, सब उल्टा पुल्टा हो जाता है. But only tachycardic reflex is my bridge wala reflex. So please remember, in all other things my heart rate is going to be decrease. So at least ये याद रखो, ये याद रखो, भूलना नहीं इसको, है ना। बहुत मेहनत करी है निमोनिक बनाने के लिए. दिस निमोनिक इज ओनली प्रेजेंट हियर ओनली बिकॉज दिस इज मेड बाय मी, है ना. इट इज नॉट देयर इन द any books, but you can remember that very very easily. Change brings challenges. I know it is challenging to give the exam, learning and the sense of new, but change is full of promise. That is the promise that if you learn this completely, you're going to get a very very good marks. अब ये question solve करो फटाफट से, क्या है आंसर इसका? क्या है आंसर बच्चों? ऑलराइट, वंडरफुल वंडरफुल. क्या है आंसर इसका? ऑलराइट, एक सेकेंड. What happened to chat? Alright. Now, conducting zone. Conducting zone वो होता है जिसमें you're not going to have any exchange. Till what point? Till the sweet 16. Nose till the termination of bronchiole. That is terminal bronchioles. You're not going to have any exchange of air, which is also known as dead space. Dead space. Okay. No exchange of air. That is known as only conduction. No exchange of air. No exchange of air. Please remember that. So Weibel's classification. Weibel's classification क्या है? Let's see. He said that Weibel was the scientist who said that you're going to have 0 to 23 generation. That means actually 24 generation, isn't it? So 23 generation, 0 to 23, that means actually 24 generation, but 23 generation is written in most of the books, right? Trachea. Trachea is cartilaginous airway, which is going to be called as 0 generation, generation 0, which is always going to be open. And please remember, sweet 16, sweet 16, 0 is trachea and sweet 16 is T, that is again the terminal bronchiole. So please remember, terminal bronchiole tak T से T क्या होता है? When you meet T with T, that is only going to conduct the air, only going to conduct the air. So it is known as conducting zone. There will be no exchange of air, no exchange of air. And if there is no exchange of air, that air is actually like a useless air, but that's why I'm going to call it as dead space. Dead space, that air is useless to me. Why? Because there is no exchange of air over here. Now after the 17 to 23 generation, what is 17? 17 is exchange zone or transitional zone. Transitional zone or the exchange or respiratory bronchioles are going to start over here. This respiratory bronchioles are going to start. So respiration is going to occur over here. Why I'm going to call it as respiratory bronchioles? Because the exchange is going to start, and 23 kya hai bacho? 23 is my alveoli. So this zone is known as respiratory zone, transitional zone, or this is also known as exchange zone. Kyun bola exchange zone? Because the exchange is happening over here. So please remember these two things. 0 से 16, T से T आएगा मेरा conducting zone, and exchange zone या respiratory zone से exchange bronchiole से मेरा exchange zone is going to start. Alright. Mechanics of respiration. एक law हमेशा याद रखना है, Boyle's law. Boyle's law gave his life for the development of this law. हम कम से कम याद तो रख ही सकते हैं, है ना? That is nothing but P is inversely proportional to V. When the temperature and everything other things are constant, the pressure is inversely proportional to the volume. That is very very important. इज गोइंग टू बी हेल्पफुल नेक्स्ट टाइम, है ना। अब इंस्पिरेशन एंड एक्सपिरेशन में देखते हैं क्या बोलते हैं। नेक्स्ट 5 to 10 minutes आई वांट योर कंप्लीट अटेंशन ओवर हियर बिकॉज आई एम गोइंग टू टीच यू लॉट मेनी प्रेशर्स इन द रेस्पिरेटरी सिस्टम। एक क्वेश्चन रेस्पिरेटरी प्रेशर से या रेस्पिरेटरी वॉल्यूम से पक्का आता है, 101%। सो प्लीज गिव फुल अटेंशन ओवर हियर। Now, inspiration में याद कैसे रखोगे? Inspiration में S is there. So always remember, whenever you are doing the inspiration, suction pressure is applied. Suction pressure is always a negative pressure, है ना? So be that the IAP, that is intra-alveolar pressure, or the intrathoracic pressure, they are going to be more negative during the inspiration. And X को ऐसे कर दो, that becomes positive. So remember that during expiration, I'm going to have a positive pressure. Be that the intraalveolar pressure or intrathoracic pressure, relatively they are going to be positive as compared to the inspiratory pressure. Let's see what you will be able to solve this question or not. ये बताओ, during quiet inspiration what is the alveolar pressure? Normally alveolar pressure क्या होता है बच्चों? Inspiration के दौरान during क्या होता है? There is only two negative values are there, but please remember alveoli. A is the first alphabet. So please remember when they asked during the quiet, normally क्या होता है? A पहले आता है, right? So please remember it is going to be the -1. We have seen inspiration में it is going to be suction pressure, negative pressure. So ये वाला तो out हो गया, right? 50-50 out, है ना? This is the intrathoracic pressure. T for 2, याद रखना, T for 2, that is going to be intrathoracic pressure, intrathoracic pressure. ये 2 आता है, सो 2.5 आया माइनस, तो इट इज गोइंग टू बी इंट्राथोरासिक प्रेशर. अल्वियोलाई आया ड्यूरिंग नॉर्मल रेस्पिरेशन, इट इज गोइंग टू बी चेंज बाय ओनली 1 डिग्री. प्लीज रिमेंबर दैट, है ना. तो बात करते हैं हम इसकी. तो ध्यान से देखो यहाँ पर क्या हो रहा है. दिस इज इंस्पिरेशन एंड एक्सपिरेशन इज शोन ओवर हियर. नाउ ड्यूरिंग the inspiration you can see that the pressure is going in the negative. कितना negative? In the -1 suction pressure, right? And as soon as the inspiration is got over, what happens? The air entry happens unless and until the pressure becomes 0 back again. So if I ask you at the beginning of the inspiration or at the end of inspiration, beginning और end पूछा है तो आपका आंसर 0 आना चाहिए. अगर during पूछा है, during, then only your answer is going to be -1. Okay. If I ask you at the beginning of expiration or at the end of expiration, what is the pressure inside the alveoli? That is again going to be 0. But if I ask you during expiration, the value is going to be positive, है ना. x को उल्टा करा था हमने ऐसे. So if you tilt the x, it looks like positive. So please remember +1. A is again a positive sign, है ना. So quiet resting में you are going to have 2 phases, inspiration and expiration. I'm going to write during over here. During expiration and during inspiration. Inspiration में -1 mmHg and it is going to be +1 mmHg. But if they ask at the beginning or at the start of the respiration or at the end of inspiration or expiration, it is going to be 0, 0, 0. Okay. Now, what is intrathoracic pressure? ITP is intrathoracic pressure. क्या होता है ये intrathoracic pressure? If I ask you this is my lung, not my lung. ये थोड़ा टेढ़ा मेढ़ा है, ऐसा मेरा लंग नहीं है, मेरा लंग अच्छा है ना. So this is pleura, है ना. Let's say the purple was the lung and this is the pleura. Inside the pleural space, whatever pressure is there, I'm going to call that pressure as intrathoracic pressure. And inside the alveoli, whatever pressure is there, I'm going to call that as intra-alveolar pressure. Please remember that. ITP is also known as intrapleural pressure and IAP is also known as intrapulmonary pressure. पल्मनरी और प्लूरल में कंफ्यूज नहीं होने का. ओके. अल्वियोलाई पल्मनरी सेम है, प्लूरल thoracic सेम है ना. सो कितना होता है? सी ओवर हियर इंट्राथोरासिक इज आल्सो शोन -2.5 एट द बिगिनिंग ऑफ इंस्पिरेशन. जैसे आप इंस्पायर करते जाओगे क्या होगा? इट इज गोइंग टू बी मोर नेगेटिव. कितना नेगेटिव? -6, है ना. एंड एज सुन एज यू स्टार्ट एक्सपिरेशन इट विल कम बैक टू -2.5 बैक अगेन. ओके. सो अगर मैंने पूछा इंस्पिरेशन के टाइम पे कितना था, दे आर नॉट गोइंग टू आस्क यू ड्यूरिंग एंड एट द एंड एंड एट द beginning. They are going to ask you inspiration and expiration directly. So please remember inspiration में हमारा हमेशा suction pressure, that means more negative pressure होता है, and expiration में it is going to be minus 2.5 mmHg. So please remember 2 2 T for 2 2 है ना, minus 2.5 and minus 6. ये क्या दिखाया है? Volume. I told you pressure, whenever the pressure is going to fall, तो इसमें दोनों में देख सकते हो आप, the pressure is decreasing in both of them. The pressure is decreasing over here. What should happen to the volume? Boyle's law, volume should increase. The volume is increasing over here, inversely proportional, है ना? And when my pressures are increasing, see over here, the pressure is increasing. What should happen to the volume? Boyle's law, the volume should decrease. ये 0.5 लीटर है, तो ये कौन सा वॉल्यूम होगा बच्चों? 0.5 लीटर है तो कौन सा वॉल्यूम होगा? इट इज नथिंग बट द टाइडल वॉल्यूम, क्योंकि क्वाइट रेस्पिरेशन में हम टाइडल वॉल्यूम की बात करते हैं. सो प्लीज रिमेंबर दैट. इसका आंसर दो. इंट्राप्लूरल प्रेशर इज नेगेटिव बिकॉज ऑफ, क्या आंसर होगा इसका? व्हाट इज आंसर? देखो, chest wall always wants to spring out. The chest wall, natural tendency of the chest wall is to spring out, and the natural intrinsic tendency of my lungs are to recoil inward. And the hilum, that means at the hilum, my parietal pleura and the visceral pleura, they are going to meet with each other, and that's why they are a closed system. They are a closed system. They can have any pressure, right? But the lung is going on the opposite direction. The thoracic cavity wants to go in the different direction, and in between there is no amount of air. Vacuum is created, and that's why I'm going to have a negative pressure over here. So please remember, both are going in a opposite direction. Opposite direction में जा रहे हैं, and that's why I'm going to have a negative pressure or suction pressure. Please remember that these all are the pre-YQs. So please इसमें mistake नहीं करने का अगर आ गया एग्जाम में, है ना? Next question, inspiration, expiration. I always tell you, in goes with x, x goes with in, है ना? So ये वाला फंडा आपका हर जगह, everywhere it is going to be applied in the respiratory system. In goes with x means during the inspiration, normal inspiration, external intercostal is going to help me. During the forceful expiration, internal intercostal is going to help me. Why during the expiration, during the quiet expiration, it is passive? Because I'm going to recoil my, or I'm going to relax these muscles. Just the relaxation of the diaphragm and external intercostal is going to give me that compression pressure which is required, and expiration is going to be passive. Very important, है ना? And accessory muscle, what is accessory muscles? They are the extra muscle that I'm going to contract during the forceful inspiration. Please remember that. That is the sternocleidomastoid muscle and the scalene muscle, which is going to increase my vertical diameter of the chest wall. So please remember this chart, very important. यहाँ से दो चीजें याद रखनी है. So please at least remember, passive is going to be the expiration, and the maximum contribution during the excuse me during the normal inspiration is going to be of diaphragm. It is going to be of diaphragm. Please remember that. Okay. नेक्स्ट, कंप्लायंस पे आते हैं. व्हाट डू यू मीन बाय कंप्लायंस? होता क्या है ये कंप्लायंस? कंप्लायंस मीन स्ट्रेचेबिलिटी और डिस्टेंसिबिलिटी. फॉर्मूला क्या है इसका? द फॉर्मूला इज वेरी सिंपल. कितना वॉल्यूम चेंज होता है थोड़ा सा प्रेशर चेंज करने के बाद? डेल्टा वी बाय डेल्टा पी इज गोइंग टू बी योर कंप्लायंस का फॉर्मूला. प्लीज रिमेंबर दैट. इसमें कैलकुलेटिव क्वेश्चंस भी आए हुए हैं. द सेम ग्राफ विल बी शोन ओवर हियर. क्या नहीं समझ में आया बच्चे? क्या नहीं समझ में आया? लायन, ओके. डेल्टा वी बाय डेल्टा पी, है ना? हम एक काम करते हैं, यू जस्ट रिमेंबर द स्लाइड नंबर और द टॉपिक, वी कैन कम बैक ओवर हियर. ओके, ऑल ओके, चलो बेस्ट, है ना? पैसिव कुछ नहीं होता है यार. इंस्पिरेशन में वॉट एवर मसल यू हैव कॉन्ट्रैक्टेड, दैट इज गोइंग टू इंक्रीज योर थोरैसिक चेस्ट कैविटी, है ना? और जैसे ही आप एक्सपिरेशन स्टार्ट करोगे, यू जस्ट हैव टू रिलैक्स देम. जैसे आप रिलैक्स करोगे, इट विल कम बैक टू द नॉर्मल पोजीशन, है ना? और आपकी हवा जो है वो बाहर चली जाएगी. ओके लायन, आई होप यू अंडरस्टूड दैट, है ना? सो वी डू नॉट रिक्वायर टू कॉन्ट्रैक्ट सम अदर मसल. जिसको कॉन्ट्रैक्ट किया है बस उसी को रिलैक्स करो. ऑलराइट, दैट इज द थिंग. देन कम्स द कंप्लायंस. कंप्लायंस इज डेल्टा वी बाय डेल्टा पी. दैट इज हाउ मच volume is going to change if you change some amount of pressure. So see over here, this is my normal thing, है ना? So if I change 10 mmHg of pressure or 10 centimeters of water, so pressure is going to be there on the x-axis and volume is going to be there on the y-axis. Whenever the graphical questions are going to come, you have to do two things. पहली चीज, घबराना नहीं, don't get scared. if the question comes on the graph. Second thing, see the x and y axis. All right, you're going to solve this question. So if I change the pressure 10 centimeters of water, see how much volume change should occur. If I draw this perpendicular line over here, almost 4.5 liters are going to be changed. Almost 4.5 liters are going to be changed over here on the 10 centimeter pressure change. 10 centimeter of water pressure change, 4.5 liter is going to be changed. But if I have higher compliance, that means it is easier to stretch. The stretchability is increased. When this is going to happen? This is going to happen when I'm going to have the disease, parenchymal disease, that is known as emphysema. देखो, it is going to be double, almost double, that is 7.5. The compliance, the stretchability is increased. When the stretchability is increased, what is going to happen? The stretchability is increased, that means increase in the compliance in seen in what thing? Increase in the compliance is seen in the emphysema condition only. So ऐसा कुछ upward left shift या upward shift दिखे तो आपका आंसर होना चाहिए emphysema only. Okay, and if I have lesser like fiber like thing है ना, it is not like a wooden thing or the steel like a thing, that it cannot stretch like a rubber band or it cannot recoil. जब stretch ही नहीं किया तो recoil कैसे करेगा, है ना? When it is not stretch, it cannot recoil. So it is like a fibroblast, it is like a fiber, है ना? So in the all restrictive lung diseases, fibrosis is going to occur. And see over here, fibrosis में आपका volume change is going to be very low volume change on the same pressure change. Okay, so please remember, on the basis of compliance and recoil, I'm going to mention those things, है ना? Emphysema में क्या होता है बच्चों? Emphysema में the compliance is very good, compliance is good, the stretchability is very good, but what is poor there? Poor is going to be the recoil. Recoil is going to be poor. Why is it so? Because let's say this is my normal alveoli. I do have elastic fibers. This is like a spring. I have elastic fibers which can compress the alveoli if I leave the pressure. If there is no pressure on the rubber band, if I leave the pressure, this rubber band will come back to the normal position, right? But if I break those rubber bands, है ना, rubber band break कर लिया आपने तो क्या होगा? If I break those rubber band, it is easier to stretch. जैसे आप socks use करते हो या rubber band use करते हो, it becomes loose. So my alveoli becomes loose. It is easier to stretch, but the problem is it is not going to come back to its normal position. Every time the person is going to inspire, some amount of extra air is going to accumulate inside the lung, and the lung started to look like this. ये कैसा दिख रहा है आपको? This is looking like a barrel. So please remember, the barrel chest is the phenomena, right? आपका diameter, anterior posterior diameter is going to increase. So this is known as barrel chest. This is a normal chest, है ना? Normal chest ऐसे है, which is not looking like a barrel, but later on, if the emphysema is there, it looks like a barrel chest because of the air trapping that is going to occur, है ना? Which is known as air trapping that is going to occur during the emphysema. Chewing gum दिखाया हुआ है, which is easier to stretch, but it will not recoil, है ना? It's like that. It's like a chewing gum. Fibrosis में क्या होता है यार? दोनों ही चीजें poor होती हैं. There is poor compliance because it doesn't have the stretchability and it doesn't have the recoil. Stretch ही नहीं किया तो recoil कैसे करोगे? कहाँ से आया ये recoil, है ना? So ऐसे नहीं बोलने का कि उल्टा हो जाता है, उल्टा कभी नहीं हो सकता, है ना? That fourth possibility is not there. So please remember, fibrosis में the compliance is going to decrease. The compliance is going to decrease, and that's why ये वाला ग्राफ हमारा नीचे आता है. Okay, please remember this. सरफेस टेंशन पे आते हैं. बहुत सारे टेंशन है दुनिया में, मुझे पता है, बट ये एक और टेंशन पढ़ लो, आसान हो जाएगी जिंदगी, है ना? सो व्हाट इज सरफेस टेंशन? व्हेन यू हैव alveoli, व्हेन यू आर बेबी, फीटस होते थे आप, तब क्या होता था? यहाँ पर ना ऐसे एक वाटर की लाइनिंग होती थी. वाटर लाइनिंग इज देयर व्हेन वी वर fetuses, है ना? बट द प्रॉब्लम वाज these were collapsed before, so we don't have any problem because the mother was giving us the oxygen. But as soon as we are born, now this water wants to collide with all the molecule and form a single bada sa molecule of water, single drop of water. With combining, there are adhesive forces and cohesive forces, which is nothing but the inward force. This water creates the inward force that is known as surface tension. Why? Because now the air is there inside it. As the baby start to breathe, it is going to be the air which is coming inside it, right? So this air water interface means what? It is the phase, that means it is the junction where the air water interface is there. when the junction is there, air और water का junction होता है, in that I'm going to have this adhesive and cohesive force which is going to collapse my alveoli. That is a problem. Inward force is generated. That is nothing but your surface tension. I do not want that surface tension. Otherwise, I'll be having very, very difficult to breathe. है ना? I'll be having a lot of difficulty to breathing. So what I'm going to do, I'm going to attach some lipid molecules. क्या बोलते हैं इसको जरा बताना तो, जिंदा हो मेरे बच्चों? क्या हो गया है आज का दिन का, है ना? बता दो जरा, हो यहाँ मेरे साथ तो। वेरी गुड. सो दे आर नोन एज सर्फैक्टेंट. दिस लिपिड मॉलिक्यूल्स आर नोन एज सर्फैक्टेंट. लिपिड ऊपर कैसे आया अपने आप से? बिकॉज लिपिड्स आर लेस डेंस मॉलिक्यूल, दे आर गोइंग टू फ्लोट ऑन दिस वाटर, एंड बिकॉज ऑफ दैट दिस वाटर एयर इंटरफेस, एयर वाटर इंटरफेस इज डिक्रीज बिकॉज ऑफ दिस lipid lining over here. And that's why if I decrease this air water interface, what is going to happen? This air water interface was the surface tension, na? If I decrease that air water interface, my surface tension will be reduced, na? And that is going to help me in the inflation of this alveoli. So please remember that if the surface tension is higher, two things are going to happen. First is the alveoli is going to be collapsed, है ना? The alveoli is going to collapse and it is going to drain lot of water, है ना? यहाँ पर ऐसे blood vessel भी होती है, right? Pulmonary capillaries are there inside the lung, and if I have inward force, that is going to pull lot of water inside the interstitium of the lung as well as in the alveoli. So that is going to lead to pulmonary edema, pulmonary edema. So I don't want that, and that's why I need to have the surfactants. I need to have the surfactant to prevent this, है ना? Pulmonary surfactant is secreted by, खुद्दू क्वेश्चन है, आंसर दे दो. Absolutely wonderful, यार. MS Dhoni, Arpita, I did not expected that. Very good, yaar. Very good. I cannot even read your names. You are that, absolutely wonderful. So this is B, right? They know that it is the type 2 pneumocyte, but if the type 2 is not there, I told you, you have to mark the Clara cell. क्यों mark किया Clara cell? Because the Clara cells are going to produce surfactant proteins, which helps in the stabilization of the surfactant. है ना? सर्फैक्टेंट ना सही, कम से कम जो सर्फैक्टेंट है उसको तो स्टेबलाइज करो, है ना? डोंट फॉल इनटू रीडिंग अ लॉट ऑफ थिंग्स. whatever things you have read already, please make sure that उससे कुछ गलत नहीं होना चाहिए. You should not make the mistake what you have read already, है ना? So stabilize your knowledge, Clara cell की तरह, है ना? So if the type 2 pneumocyte is there, go with that, and if the type 2 pneumocyte is not there, go with the Clara cell. Very good, absolutely wonderful. I'm loving this. Composition क्या होता है बच्चों? कॉम्पोजिशन में सबसे आगे होता है लिपिड, देन द प्रोटीन्स, है ना? लिपिड एंड प्रोटीन. लिपिड में सबसे कॉमन होता है आपका डीपीपीसी. प्लीज रिमेंबर दिस इज द कोलिन एंड नॉट इथेनोलामिन. द आंसर, the question came in the NEET PG and they have given the 4 options like dipalmitoid, phosphatidyl, ethanolamine, then some other options like sphingomyelin and other lipids, and then they have given the lecithin. The answer was lecithin. The most common lipid is going to be the DPPC, which is also known as lecithin. It is not ethanolamine. Choline है तभी मार्क करना, वरना lecithin को मार्क करना. इसका फायदा क्या है? दिस इज द मेजर surfactant. हम जब LS ratio लेते हैं, if it is more than 2, I say that my this baby which is born, it is going to have a mature lung. If the mature lungs are not there, this LS ratio, that is lecithin to sphingomyelin ratio, is going to be less than 2, less than 2. Please remember that DPPC and lecithin. Applied aspect क्या है बच्चों? Surface tension कम होगी किससे? If I want to decrease the surface tension, I have to give the स्टीरॉइड्स एंड थायराइड. देखो ये भी एसटी दिखा रहा है. एसटी क्या है? सरफेस टेंशन. सरफेस टेंशन को कम करना है तो क्या देना पड़ेगा? एसटी देना पड़ेगा. वी प्रेफर द स्टीरॉइड, है ना? सो अगर हमें लग रहा है कि ममा को प्री मैच्योर लेबर हो रहा है, प्री मैच्योर बर्थ कैन अकर, वी आर सस्पेक्टिंग दैट द बेबी इज गोइंग टू कम बिफोर टाइम, वी आर गोइंग टू गिव द स्टीरॉइड, है ना? सर्फेक्टेंट डिक्रीज हो गए तो क्या होगा? इफ द सर्फेक्टेंट लेवल्स आर लो, my baby is going to have lot of problem in the respiration. Why my baby? Someone else's baby, है ना? जो prematurely born हो रहा है, हमारा तो कुछ है ही नहीं, है ना? So RDS and HMD. What is RDS? Respiratory distress syndrome. Respiratory distress syndrome. baby is going to be in the distress. Why? Because he's going to have a lot of difficulty in breathing. क्यों? क्योंकि surfactants कम है. इसी को आप हाइलीन मेम्ब्रेन डिजीज भी बोल सकते हो. हाइलीन मेम्ब्रेन डिजीज भी बोल सकते हो, विच इज गोइंग टू बी सीन इन द प्री टर्म बेबी. एक बड़ा लंबा चौड़ा केस दिया जाएगा आपको रिगार्डिंग द प्री टर्म बेबीज, एंड दे विल आस्क यू व्हाट इज डेफिशिएंट और व्हाट इज द कंडीशन. रेस्पिरेटरी डिस्ट्रेस सिंड्रोम. ये वाला सॉल्व करो. देखो यहां पर, देखो यहां पर कुछ नहीं बच्चे. स्टीरॉइड जब देते हो सामिया, when you give the steroid, that helps to produce the surfactant faster, and that's why it helps to reduce the surface tension. If you want to reduce the surface tension and you are suspecting that the baby is going to be born prematurely, अगर ममा आपको आके बोल रही है, अगर फीटस अभी है वहां पर, pregnant lady is going to come to you and she gives you the symptoms, and you suspect that the premature labor is happening and the baby is going to be born, you are going to give the steroids, okay, to reduce the surface tension, to produce more surfactant. It enhances the surfactant production, you know, reduce the surface tension. Now, if I inspire, I'm going to get a positive upstroke. This is the thyroid भी same करता है बच्चे, thyroid भी same करता है, but on the lower level. That's why we prefer steroids, है ना. steroid है तो दे दो, but अगर कोई contraindication है, मम्मी को कोई disease है जिसमें steroid allowed नहीं है, then we give the thyroid. All right. Next, coming to the spirometry. This is known as spirometry. इंस्पायर करोगे तो अपस्ट्रोक आएगा, एक्सपायर करोगे तो डाउन स्ट्रोक आएगा. लेट्स से एक्सेल है ना, एक्सपायर हम नहीं करने वाले. सो पहली चीज, इंस्पायर करोगे तो अपस्ट्रोक आएगा, राइट. सो इफ आई डू द क्वाइट रेस्पिरेशन, वट एवर अमाउंट इज गोइंग टू बी एक्सपायर्ड और इंस्पायर्ड, दैट इज कॉल्ड एज टाइडल वॉल्यूम. कितना होता है? 500 ml. इफ I ask the subject to inspire forcefully, he is going to inspire forcefully, it is going to be called as inspiratory reserve volume. Inspiratory reserve volume, right? I'm going to call it as IRV. कितना होता है? 2 to 3 liters. Please remember, this is liters, this is not ml, right? If I write in the ml, it is going to be 2000 to 3000 ml, है ना. So ये ml में है, this is in the ml, and IRV is in the liters. Same. If I ask the subject to expire forcefully, whatever extra amount of air he's going to expire, I'm going to call it as expiratory reserve volume. I'm not going to write it completely. You already know that it is going to be called as ERV. ERV is usually 1200 to 1300 ml or 1.2 to 1.3 liters, है ना. But there is some amount of air, no matter how forcefully you contract your lungs, it is residing inside your lung, it is not coming out. So please remember, if it is residing inside your lung, there will be no wave which is going to come, and this is known as residual volume. कितना होता है residual volume? The residual volume is going to be around 1100 to 1200 ml. 1100 to 1200 ml. Please remember that. Okay. Now, if the amount is not going to come out, I cannot measure it with the spirometer, and that's why there is no graph of it, right? So residual volume cannot be measured with the this spirometer, but residual volume is not there in the option. What we should do, we should learn the capacities, and we are not going to give up. So what is the capacity? The tidal volume plus IRV, I'm going to call it as the inspiratory capacity. Inspiratory capacity. If I add the ERV plus the RV, I'm going to call it as expiratory capacity. Expiratory capacity. When you add two or more volumes, it is called as capacities. Capacities, right? Now, if I ask you, if I just add, expiratory capacity is this one. If I add ERV and TV, right? If I add ERV and TV, that will be called as expiratory capacity. If I add ERV plus RV, that will be called as functional residual capacity. Functional residual capacity. Okay. तो अगर मैंने आपको क्वेश्चन पूछा, if I ask you a question, after normal expiration, how much amount of air is there inside your lungs? So please remember, normal expiration is over here, है ना. So the FRC is going to be residing in your lungs functionally, right? So that's why it is called as functional residual capacity, right? If I add IRV, TV and ERV, what you are going to call it as. These are the volumes which are going to be measured by my spirometry, and this gives a vital function that how my lungs are working, right? So it is very, very vital for knowing the functionality of my lungs. So I'm going to call it as vital capacity, you know. So this capacity is known as vital capacity. Now, if I add all the volumes, क्या बोलोगे बच्चों? Total lung capacity, total lung capacity, total lung capacity. Now, please remember, if you cannot measure the RV, if you cannot measure the RV, RV से जो capacities बनती है, whatever capacities are made up, including the RV, I cannot measure that also because I cannot measure the RV itself. This volume cannot be measured by the spirometry. Obviously, whatever capacities are containing this RV, I cannot measure them also. So three things cannot be measured. First thing is RV, second is the FRC, and third thing is TLC cannot be measured by the spirometry. Spirometry से ये measure नहीं कर सकते, and that's why I'm going to mark A as the answer. A as the answer. Right, you have given the answers already. I'm very happy. I'm getting chat in the YouTube also. I'm getting the Zoom in the Zoom also. So I hope you understood the phenomena. जिन्होंने नहीं answer किया, I hope you will be able to answer in the GT and in the exam. I'll see personally कैसे कैसे काम किया है सबने physiology GT में, है ना? Next, volume of the gas in the lungs at the end of the normal expiration is referred as. क्या बोलोगे? ये क्वेश्चन अभी पूछा था. फंक्शनल रेजिडुअल कैपेसिटी है ना. नॉर्मल एक्सपिरेशन के बाद whatever amount is remaining, that amount is going to be called. यहाँ से लेके यहाँ तक you're going to be called, you're going to call it as, yes, functional residual capacity. अब ये क्या चीज है? This is a dynamic volume, है ना. थोड़ी एक्शन करते हैं. What is a dynamic volume? See over here. This is the FeV1 and FVC. क्या होता है ये FeV1 and FVC? I'm going to ask the subject to inspire forcefully and hold it for some time and then expire as much as forcefully possible as soon as possible, right? As quicker, as forcefully as possible. Genong says that it takes 3 seconds to expire the amount of functional vital capacity, post vital capacity outside, right? So I'm going to draw a perpendicular line from here and perpendicular line from here where he stopped expiring the air outside. And I'm going to divide this into the 3 seconds, first second, second second, and third second, right? Whatever amount of air he expired during first second में जो भी amount of air is going to be expired, I'm going to call it as FeV1. FeV1. The amount of air expired in first 2 seconds. Please remember, this is not second. This is first 2 seconds. Combining the first one and the second one, I'm going to call it as FeV2. And whatever amount of air is expired in first 3 seconds, 1, 2, 3, that I'm going to call it as FeV3. This FeV2 and FeV3 is very, very less. क्यों? क्योंकि यहाँ पर आपने याद रखना है 80, 90, 100, है ना? That is 80, 90 and 100. 75 to 80%, 90 to 95%, 95 to 98 or 100%. Don't remember that. Make it easy. Life is going to be very, very easy if you remember this way. 80, 90, 100, है ना? So 80, that means maximum amount of air is expired in first second. 80 plus 10 is going to be 90. That means in the second, I only expired 10% of the air, or 10, whatever 10% that is there, extra amount of air. So I'm going to bother about only the FeV1 and not about the FeV2 and FeV3, right? So I'm going to calculate the percentage. I told you the percentage is very, very important, not the marks per se, right? So please remember, if I do this formula, FeV1 upon FVC. What is FVC? FVC तो बताया नहीं मैम आपने. FVC is nothing but the total amount of air, right? It can be similar to FeV3 also. It can be different also. Please remember, it can take more time to expire the air. So it can be more also. So I'm not going to call that they are same, right? They are a bit different, okay? But you have to multiply it by 100, all right? Now, please remember, if I have an obstructive lung disease, let's say what is obstructive and restrictive. If I obstruct the airway, let's say यहाँ पर problem है, it is going to take more time Air is going to take more time to come inside. So what is going to happen? My FeV1 is going to decrease. The numerator is decreasing, but all air can come out, right? So FVC is going to be normal. If my numerator is decreased, what is going to happen to the ratio? The ratio is going to decrease too. ये कब होता है? When you have a obstruction. So old में FeV1 percentage is going to decrease. कैसे याद रखोगे? ओल्ड एज में सब कुछ डिक्रीज होता है. सो प्लीज रिमेंबर, दिस इज द ऑब्स्ट्रक्टिव लंग डिजीज. इन द ऑब्स्ट्रक्टिव लंग डिजीज FeV1 percentage is also decreased. Let's see about the restrictive. If I tie you to your chair, है ना, like this, you will not be able to give the exam, है ना, you will not be able to give the exam while going on the exam center, right? So that amount of air is going to be wasted. That area is wasted. I'm not having any ventilation. When this is going to happen? When my lungs are going to, why my lungs? When anyone's patient's lung is going to be fibrosed, है ना? So please remember that is known as restrictive lung disease. Restrictive lung disease mein what is the problem? Is the problem in the airway? No. So my FeV1 can be normal also? Yes, absolutely right. The numerator can be normal. And but the FVC is going to be decreased. If my denominator is decreased, or it can happen in the severe cases that the FeV1 start to reduce a bit, but remember at that time my FVC is going to be reduced much more. So please remember, in the RLD, the FeV1 percentage, that means the ratio is going to be increased. याद रखो एक चीज, old में it is going to be decreased, and rest you are going to know that it is going to be increased. Okay, please remember that. All right, so see over here, if they give the value like this, आपको बस इतना ध्यान रखना है what they have given over here as a percentage. If the percentage is decreasing, doesn't matter, it is going to be OLD only, है ना? If you can see over here, the percentage FeV1 percentage is increase, that is going to be your RLD. RLD समझ में आ रहा है? हाँ या ना? कुछ बोल दो यार, है ना? perfect. All right, यहां पर तीन चीजें याद रखनी है आपने. फ्लो वॉल्यूम कर्व, इसमें तीन चीजें याद रखनी है. व्हाट आर द थ्री थिंग्स? फर्स्ट थिंग, इट इज द अपोजिट thing that they have given. When you go from the right hand side towards the left hand side, the volume is increasing. यहाँ पर उल्टा हो रहा है, सब कुछ उल्टा पुल्टा है, ध्यान दो यहाँ पर. So it is going to increase over here, है ना? Lion, you asked me the question at the end because it's already 10 o'clock. We have around 80 slides left, है ना? Easy है बाद वाली slides, but it is important, है ना? Now the volume is increasing. What is this, bacho? This is the effort dependent part. Just remember whatever I'm telling you. This is effort dependent part and this is effort independent part. Independent part. All right. Please remember, whenever you're talking about this down wala curve, that is nothing but the inspiration ka curve, right? And when you talk about upward curve, that is expiration wala curve. This is a normal curve. Right hand side, we are going to have residual volume, which is a lesser volume. And we are going to have total lung capacity over here, which is a more volume. Let's see what questions they are going to ask you. When the restrictive lung disease is going to happen, restrictive lung disease hota hai. So the curve is going to shift towards the right hand side. So R से R याद रखना है. What is R से R? Whenever I'm going to have a restrictive lung disease patient, the curve is going to shift towards the right hand side. Mainly the problem is going to be in the expiration. That's why the curve is going to be on the upward side itself. And whenever I'm going to have the obstructive lung disease, ulta hota hai, the curve is going to shift towards the left hand side. Please remember this thing only over here. Right hand side, RLD, left hand side, OLD. If you have scooped legged pattern or scoop pattern or dog leg pattern, that is going to be emphysema. Scooped pattern, scooped out pattern or dog leg pattern. ऐसा कुछ नाम दिखाई दे, so one extra example याद रखो, it is none other than emphysema. All right, so please remember that also. all right, इतना ही याद रखो काफी है. Dead space क्या होता है यार? Dead space, what is dead space over here? Tell me. नॉर्मल में पूछा हुआ है. It is going to be anatomical is equal to physiological. होता क्या है ये बता दो. There is only one type of dead space, that is physiological dead space, because I'm teaching physiology, है ना? Physiological dead space, on the other hand, is divided into two types. कौन कौन से two types? दो A alveolar and A एनाटॉमिकल, एनाटॉमिकल इज नॉर्मल, अल्वियोलर, नॉर्मली अल्वियोलर डेड स्पेस कितनी होती है यार, 0, है ना. इफ आई हैव टू कैलकुलेट द फिजियोलॉजिकल डेड स्पेस, हाउ कैन आई कैलकुलेट द फिजियोलॉजिकल डेड स्पेस, एनाटॉमिकल डेड स्पेस प्लस अल्वियोलर डेड स्पेस इज गोइंग टू बी physiological dead space. How much is the anatomical dead space, ma'am? It is 150 ml. It is 150 ml. And how much is the alveolar dead space, बच्चों? It is going to be 0 in the normal individual. So 0 किसी में भी add कर दो, that is going to be that value only. So can I say that the physiological dead space is also going to be 150, which is equal to anatomical dead space? Yes. So in the normal individual, my physiological dead space is equal to anatomical dead space. But अगर किसी में हो गया pathology, pathology में what is going to happen in the pathology, the dead space, the alveolar dead space is going to increase. Now I cannot say, that the physiological is going to be equal to anatomical. Now the physiological dead space is going to be more than anatomical dead space, राइट क्योंकि उसमें जो भी वैल्यू इज गोइंग टू ऐड इनटू द अल्वियोलर डेड स्पेस, इवन इफ इट इज लेट्स से 10, it is going to be physiological is going to be 160, right? So in this example 160 is going to be physiological, anatomical is not going to change, it is going to be 150 only. 150 160 से कम होता है, प्लीज एग्जाम में करेक्ट करके आना, है ना, अ जेन्युइन रिक्वेस्ट. एनाटॉमिकल डेड स्पेस is measured by Fowler's method. मैम कैसे याद रखे, इतना सारा है याद करने के लिए. Just remember, anatomy में dissection hall में जाते हो, there are dead people available which smells very foul, है ना, foul smell आती है, चक्कर भी आके गिर पड़ते हैं लोग, right? So foul smell is going to come when you go in the anat hall to dissect the dead people. Dead people gives foul smell, okay? So please remember that. Next, which of the following value depict the normal VQ ratio? क्या होता है normal VQ ratio? Absolutely wonderful, loving it. You know, the way you are answering the question is absolutely wonderful. You're going to rock the exam. It is 0.8. 0.8 होता क्या है ये VQ? जितना ventilation होता है, V क्या होता है और Q क्या होता है? The amount of air that came into the lung for exchange कितना होता है यार? How much is the V? V over here is going to be around 4.2 liter, है ना, and the amount of blood that came for the exchange, it is going to be how much? It is going to be 5 liters. 4.2 upon 5 comes out to be 0.8, 0.8, है ना. Now tell me one more thing, that if I ask you ventilation perfusion कहाँ पर ज्यादा होता है, कहाँ पर कम होता है? If I ask you that, let's draw it in the another paper itself. V, Q and V by Q. Okay, तीन चार्ट बनाएंगे हमने. And then we are going to discuss apex पे क्या होता है. At the apex and base, your lungs are this triangular, they are not cylindrical, है ना. यहाँ पर space कम है, there are less space, so ventilation is going to be minimum over here, it is going to be lower. But please remember, the perfusion is going to be much lower over here. अगर numerator कम है but denominator is much low, what is going to be the ratio is going to be increased. Why? Because the perfusion is very less, very less, है ना. What is going to happen at the base? In the base we do have lot of surface area, the ventilation is going to be maximum. The ventilation is going to be maximum as compared to the apex, but there will be more blood vessels also. So the perfusion is going to be much more. What is going to be happen to the ratio? Ratio is going to be decrease. Who is the culprit? Always remember, the culprit is going to be perfusion. The culprit is going to be perfusion. Please remember that, है ना, perfusion is going to be the culprit, है ना. इतना याद रखो. VQ कहाँ पर मैक्सिमम होता है? अगर रेशियो मैक्सिमम पूछा, यू आर गोइंग टू आंसर इट एज एपेक्स. अगर उन्होंने पूछा मैक्सिमम वेंटिलेशन कहाँ पर होता है, देन इट इज बेस. मैक्सिमम परफ्यूजन कहाँ होता है, वो भी बेस पे होगा, बट द रेशियो इज गोइंग टू बी मैक्सिमम एट द एपेक्स, है ना. दोनों चीजें डिफरेंट है ना, इसको छोड़ दो. And since I'm having the lesser, you can say VQ ratio is more at the apex, that means ventilation is comparatively more as the perfusion. जितना blood आ रहा है उससे कई ज़्यादा हवा आ रही है. So much more air is there, and that much more air is helpful in the aerobic bacteria growth, है ना. Aerobic bacteria growth is going to be aerobic bacteria is going to grow at the apex. So please remember the tuberculum bacterium that is going to grow over there. TB is going to be common in the apex, है ना. VQ minimum होता है आपके बेस पे. रिफ्लेक्सेस में आते हैं. हेड्स पैराडॉक्सिकल रिफ्लेक्स क्या होता है यार? न्यूबॉर्न बेबी में फर्स्ट फ्यू ब्रेथ्स आर गोइंग टू बी the baby cries and everybody is going to be happy. The inflation stimulates further inflation, that is known as Head's paradoxical reflex. That is the paradox that happens only first few breaths. जिंदगी में दोबारा ये कभी नहीं होगा. You are reading this for the first and last time. So first and last time यही reflex activate होता है when the baby is born, right? So that is nothing but the inflation stimulates further inflation. Now, rest of the life, what is going to happen? There is another reflex which will be activated, that is hearing blower inflation reflex और hearing blower deflation reflex. क्या है ये दोनों reflex? Inflation inhibits further inflation. That is your hearing blower inflation reflex, and deflation inhibits further deflation. That is my hearing blower deflation reflex. Simple सा फंडा है. जिंदगी में बाद में सब नेगेटिविटी आती है. जब पैदा होते हैं तभी बस खुश होते हैं हम, राइट? दैट इज पॉजिटिविटी. सो प्लीज रिमेंबर, ओनली द न्यूबॉर्न बेबी इज हैप्पी. पॉजिटिविटी स्प्रेड्स पॉजिटिविटी ऑल द टाइम, अदरवाइज दिस इज गोइंग टू हैपन. सो प्लीज रिमेंबर दीज रिफ्लेक्सेस, है ना. गैस ट्रांसपोर्ट, CO2 है, O2 है, दो गैस पढ़ लेंगे बहुत एग्जाम के लिए, है ना. बाकी गैसेस बाद में पढ़ लेना, है ना, वरना धुआं निकल जाएगा. सो 4 ml%. Yeah, if I have to calculate per minute, it is going to be 200 ml per minute is going to be transported. The CO2 is transported from my tissue towards the lung to exhale it outward, है ना. फॉर्म्स कौन कौन सी फॉर्म होती है? BCD याद रखना, है ना. सो BCD क्या है? बाइकार्बोनेट. C is carbamino compound, है ना, कार्बोमिनो हीमोग्लोबिन. एंड D is dissolved form. इसी सीक्वेंस में याद रखो. मैक्सिमम is going to be transported by the bicarbonate, then the 20% is transported via the carbamino compound. कार्बोमिनो हीमोग्लोबिन क्या होता है? कार्बोमिनो हीमोग्लोबिन वो होता है जिस हीमोग्लोबिन से CO2 अटैच्ड है. सो कार्बोक्सी हीमोग्लोबिन क्या होता है फिर बताइए? कार्बोक्सी हीमोग्लोबिन क्या होता है? कार्बोक्सी हीमोग्लोबिन एक पॉइजनिंग में मिलता है. व्हाट इज दैट पॉइजनिंग? दैट पॉइजनिंग एब्सोल्युटली वंडरफुल प्रकाश एंड अभिषेक, वंडरफुल एंड ब्रिज ऑल्सो. सो इट इज गोइंग टू बी द मोनोऑक्साइड. ये कभी भी नॉर्मल पर्सन में नहीं मिलता. इट इज नॉट गोइंग टू बी फाउंड इन द नॉर्मल पर्सन. इट इज पैथोलॉजिकल, हैपेंस इन द कार्बन मोनोऑक्साइड पॉइजनिंग. ओके, लेट्स मूव ऑन टू द ऑक्सीजन. ऑक्सीजन थोड़ा सा ज्यादा ट्रांसपोर्टेड होता है, दैट इज 5 ml% और 250 ml per minute. इसके दो ही फॉर्म है, इधर इट लाइक्स टू स्विम और इट लाइक्स टू गो वाया शिप. व्हाट इज द शिप ऑफ द oxygen? That is nothing but oxyhemoglobin. Oxyhemoglobin carries 98 to 99% of the oxygen, है ना. डिजोल्व फॉर्म कितना होता है? डिजोल्व फॉर्म इज ओनली 1 to 2%. चुट्टू पुट्टू, है ना. दैट इज 1 to 2% ऑक्सीजन इज ट्रांसपोर्टेड वाया द डिजोल्व फॉर्म. ओके, सो मोस्ट ऑफ थिंग्स आर गोइंग टू प्रेफर द शिप्स, है ना. पानी में शिप्स प्रेफर करोगे, फ्लो करना आप प्रेफर नहीं करोगे. सो प्लीज रिमेंबर दैट. इसका आंसर सॉल्व करो, ये सॉल्व करो, आंसर दो फटाफट. वेरी गुड. सो इट इज गोइंग टू बी अल्कलोसिस. कैसे पहचाना? whenever I'm going to talk about the right shift, you have to put a right tag. Tag क्या है? whenever you increase all these things, then I'm going to have a right shift. क्या होती है बच्चों right shift? Temperature, whenever the temperature is high, it is going to cause the right shift, है ना. blood bank में क्या करते हो आप? store करते हो blood को low temperature पे, so that is going to cause the left shift, है ना. acid, A for acid याद रखना. It can be any acid, it can be carbon dioxide, it can be lactic acid, it can be what thing? It can be your H plus ion also. Lactic acid कब बनता है? When you have hypoxia, anaerobic metabolism होता है. So hypoxia also causes right shift. Okay, and G for glycolysis. Glycolysis में via the Lubering Rappaport pathway, I'm going to form something known as 2,3-BPG. all these things, if I am going to increase, it is going to cause a right shift. Left shift में extra thing you have to remember, that is nothing but the hemoglobin. Fetal hemoglobin is going to cause the left shift. राइट टैग पुट करना है इस क्वेश्चन पे. इफ यू डू इट रॉन्ग, मेरे से बुरा कोई नहीं होगा, है ना. देन विच ऑफ द फॉलोइंग फिनोमेना अकर्स इन द ऑक्सीजन हीमोग्लोबिन डिसोसिएशन कर्व. कौन सा होता है इन द लंग्स. सो प्लीज रिमेंबर एल 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 आर आर आर. देर आर हैल्डन इफेक्ट एंड बोहर्स इफेक्ट, है ना. आई एम deliberately writing this Halden's effect and Bohr's effect. This is going to cause left shift and this is going to cause right shift, right. Halden's effect is going to cause uh, left shift and it is going to cause loading of oxygen onto the hemoglobin, right. And it is going to cause a release of oxygen, and it is going to happen in the tissues, है ना. So what you have to remember, you have to remember L L L L R R R. So please remember that. So if they are asked in the L, it is going to be Halden, है ना. So ये आपका आंसर हुआ, ये आपका आंसर हुआ. आगे बढ़ते हैं. ट्रांजेक्शन ऑकर्स बिलो मेडुला. व्हाट चेंज इज गोइंग टू बी सीन इन द रेस्पिरेशन. रेस्पिरेशन के एंड में आ रहे हैं हम. चलो पढ़ लेते हैं, ये ध्यान से दो. आई एम नॉट गोइंग टू रिपीट दैट अगेन. आई एम अज्यूमिंग दैट यू नो दिस ऑलरेडी, है ना. सो लेट्स लर्न दैट. ये आपका हुआ वीआरजी, ये डीआरजी, ये प्री बॉटजिंगर कॉम्प्लेक्स, है ना. पीबीसी क्या होता है, प्री बॉटजिंगर कॉम्प्लेक्स, एंड दिस इज द डीआरजी विच इज वेरी वेरी इंपॉर्टेंट. वाई? बिकॉज आई एम हैविंग द eye neurons over here, eye neurons over here, and they are going to be, this is my pacemaker. PBC is pre-Botzinger complex, which is the pacemaker of respiration. Both of them is the on off center of the respiration. On किया off किया, on किया off किया. But जब आप FM on करते हो for the first time, it is very irregular and shallow. irregular and shallow respiration, ऐसा कुछ respiration आपको मिलेगा. which I don't want. I want regular and deep respiration. So I'm going to put something known as apneustic center. Apneustic center. ये क्या करता है? It is going to cause the stimulation of eye neurons. It is going to cause stimulation of eye neurons and it is going to increase the depth of respiration. Depth of respiration. But if I do not stop this, it is going to cause inspiratory spasm. Inspiratory spasm, which is known as apneusis. Apneusis, inspiratory spasm. So I have to prevent this. I have to prevent this. So there are two ways to prevent this. What are the two ways, bacho? First is I'm going to inhibit via the vagus nerve, which is coming from the stretch receptor from the lung. And I'm going to put one another center over here, which can inhibit that also. That is known as pneumotaxic center. Pneumotaxic center. न्यूमोटैक्सिक सेंटर क्या करता है? इट रेगुलेट्स द रेट ऑफ द रेस्पिरेशन, है ना. सो ये प्रॉपर रेस्पिरेशन करवाता है. लेट्स ब्रेक इट डाउन. अगर मैंने यहां काटा, व्हाट इज गोइंग टू हैपन इफ आई रिमूव और इफ आई कट बिलो द मेडुला, नो मैटर व्हाट विच स्टिमुलस आई एम गोइंग टू गिव, दैट इज नॉट एबल टू रीच टू माई लंग. So the medulla, below the medulla, if the cut is there, what is going to happen below medulla? No signals from the medulla is going to able to reach to my lung, है ना. तो क्या होगा? The respiration is going to be stopped, है ना. The person will not be able to inspire, he will expire, है ना. So please remember that. आगे सब लिखा हुआ है. So below medulla कट करोगे तो the respiration is going to stop. अगर आपने यहाँ काटा, let's see, the lesion is here between the pons and medulla, what is going to happen? At least the irregular and shallow respiration can be seen. The regulation, the tuning of the respiration is not going to occur. Now there are two things when I'm going to cut over here, that is mid-pontine lesion में I have to see whether the vagus is intact or vagus is cut. Vagus intact है तो at least one inhibition is intact, so the deep respiration is going to occur. But if I cut the vagus also, no inhibition on the apneustic center, the person is going to land up into the apneusis. It is going to have the inspiratory spasm. apneusis हो जाएगा अगर मैंने दोनों nerve cut कर दी तो, right. But if I cut below the medulla क्या होगा कि voluntary respiration is not going to occur, है ना. इसके ऊपर आपका होता है cortex. cortex क्या करता है बच्चों? voluntary respiration is going to happen with the help of cortex. That is not going to happen if I cut below the, जैसे ईयर में, once in a year you have a birthday, you want to blow your candles or the cake, so for that you require forceful expiration. That is not going to happen. You will not be able to blow the candles via the mouth, है ना, हाथ से बुझा सकते हो. So now if I destroy, let's say somehow, if I have destroyed the brainstem but the cortex is intact, such as in the bulbar polio. bulbar मतलब जो brainstem को affect करे, right? So what is going to happen? If you damage the brainstem, the automatic respiration is proper, but the problem is that he has to, automatic respiration is gone, but the voluntary respiration is active, right? He has to voluntarily respire all the time. He cannot sleep, because when you sleep, who is going to inspire and expire voluntarily? That is not going to happen. So he's going to go, as soon as he's going to sleep, he's going to have apnea, he's going to wake up, and due to lack of sleep, he's going to die. Okay, that is known as a curse. That is ondine curse. ondine curse. ये हो गया न्यूरल रेगुलेशन. लेट्स कम ऑन टू द केमिकल रेगुलेशन. क्या होता है ये केमिकल रेगुलेशन? होता है बिकॉज ऑफ द ग्लोमस सेल. देयर आर टू टाइप्स ऑफ सेल. It is because of the glomus 1 cell. Just remember this, there are oxygen sensitive potassium channel which are going to close, and the potassium start to accumulate inside, which causes the depolarization, है ना? So because of these potassium channel closures, this action potential is formed in the chemoreceptor. You have to remember this two names: glomus cell, which has the oxygen sensitive potassium channel. There are two types of chemoreceptor: central chemoreceptor, peripheral chemoreceptor. Peripheral chemoreceptor is present in the carotid body and aortic body. Carotid body and aortic body is far away from my medulla, है ना? So I have to make their action potential reach to the medulla, so I have to go through the nerves. So who is going to carry the message from the carotid body? It is going to be the ninth nerve or glossopharyngeal nerve. Aortic body is 10th nerve, that is aortic nerve. What are the stimuluses that are going to be present? Increase in the PCO2, increase in the PO2, and increase in the H plus ion in the blood, right? And increase in the H plus ion in the CSF is going to be the only stimulus. Remember, only stimulus in the medulla, that is nothing but the central chemoreceptor. But if I did not give you the option as H plus ion, what is going to happen? Remember, the PO2 is already less over here, so it cannot cross the membrane, right? And the H plus ion in the blood, it is the polar molecule. It has a charge. It cannot cross the blood-brain barrier and cannot go in the medulla. Now, what is going to happen? My CO2 is going to cross over. It is going to combine with the water, and with the help of carbonic anhydrase, the carbonic acid will be formed, but it is unstable. It is going to divide into H plus ion and bicarbonate. And this H plus ion, where it is increased in the CSF. So if the carbon dioxide is there in the option and H plus is there in the option, go with the H plus ion. But if the H plus ion is not there in the option, who can stimulate the central chemoreceptor? Central chemoreceptors are stimulated by carbon dioxide if the H plus is not there in the option. H plus in the blood cannot stimulate the CC. वो सिर्फ PC को stimulate कर सकता है. What is PC? Peripheral chemoreceptor. Please remember that. Follow your heart, but take your brain with you. So let's talk about the brain, है ना? It does not matter how slowly we are going, we are progressing at least, है ना? Please remember that. ये क्या है बच्चों? This is your somatosensory system. Next 20 minutes, I want your full attention क्योंकि हम CNS पढ़ने वाले हैं. Alright? So somatosensory system में I want you to focus on this. What is this? डीपर लेयर में क्या है? पैसिनियन कार्पसल. कैसा दिख रहा है? अनियन शेप. कैसा अनियन? दे हैव गिवन द क्वेश्चन लाइक कॉकटेल अनियन. पता नहीं कौन सी कॉकटेल पी के ये क्वेश्चन बना रहे थे. फालतू फालतू क्वेश्चन बनाते हैं ना. सो एनबीई सस्ता वाला पी रहे हैं. सो कॉकटेल अनियन दे हैव आस्क्ड अबाउट. सो प्लीज रिमेंबर, कॉकटेल अनियन क्या होता है? इट इज इन द डीपर लेयर and it is none other than the Pacinian corpuscle. So please remember, Meissner corpuscle. It is going to be most abundant. मतलब सबसे ज्यादा कौन होता है? Meissner corpuscle. Glabrous skin क्या होता है बच्चों? Glabrous skin. What is glabrous skin? This is the skin which is a glabrous skin. where I'm not having any hair. वैक्सिंग के बाद वाला नहीं, naturally पूछ रही हूँ, right? Not after waxing. Without waxing, I do not have the hairs over here and at the sole. So, and the glabrous skin, Meisner carpuscles are going to be the most abundant, okay? Over there, this question, please remember, and they are important for fine touch and 2 point discrimination. But, if I ask you 2 point discrimination में who is the best, क्या आंसर दोगे? इफ आई आस्क यू द बेस्ट कौन है, प्लीज रिमेंबर, जब भी ये फाइन टच और 2 point डिस्क्रिमिनेशन आता है ना, तो एम वाले लगाने हैं. एम वाला दूसरा कौन है? मर्कल्स डिस्क. मर्कल्स डिस्क इज गोइंग टू बी द बेस्ट इन द 2 point डिस्क्रिमिनेशन. बेस्ट इन द 2 point डिस्क्रिमिनेशन. ये क्या है? ये क्या दिखाया हुआ है? This is a braille reading. When the person is blind or he is not using the visual input, we require the edges and the 2 point discrimination so that we will know that yes, there is a two different point, right? So please remember, in the blind person, this is known as braille reading. Braille reading में कौन सबसे ज्यादा help करता है? The Merkel is going to be more helpful as compared to the Meisner's. दोनों ऑप्शन में होंगे, गो विद द मर्कल्स. ओके, मर्कल्स नहीं है, देन यू हैव टू मार्क द मीजनस कार्पसल. प्लीज रिमेंबर दैट, है ना. बेस्ट कौन होता है? बेस्ट कहां पर होते हैं ये मीजनस कार्पसल? बेस्ट होता है फिंगर टिप्स पे और लिप्स पे. ओके, बेस्ट आर 2 point डिस्क्रिमिनेशन इज बेस्ट. दैट मीन्स छोटे डिस्टेंस में 1 to 3 mm में ही आई कैन गेट टू नो दैट yes, this is a two different points. These are two different points. I can get to know with the minimum distance between these 2 points. Where it is best? Best in the fingertips and lips. Where it is worst, ये बता दो. Worst कहाँ पर होता है बता दो. Worst is present at the back, है ना, scapula के ऊपर it is worst, है ना. ये क्या है? Cocktail onion, है ना. And we asked, this cocktail onion is nothing but the Pacinian. P for Pacinian, P for pressure. Please remember, it is helpful for the pressure. Also, it is helpful for the high frequency vibration. कहाँ होता है ये? बहुत deep होता है. You can see over here, everything is present in the superficial dermis. This is present in the deep dermis, है ना. Pacinian हमेशा deep dermis में होता है. Please remember that. Okay, onion shape. Now coming to the free nerve ending, don't get confused between the pain and pressure. That measures the pressure. ओके, फ्री नर्व एंडिंग्स इज फॉर द पेन, है ना. पेन हमें फ्रीली मिलता है ना. वी डू नॉट रिक्वायर एनी थिंग फॉर दैट. पेन कैन बी फेल्ट इवन ड्यूरिंग द रीडिंग. आई कैन अंडरस्टैंड यू, है ना. सो प्लीज रिमेंबर, फ्री नर्व एंडिंग्स, फ्री में क्या मिलता है? पेन. ऑलवेज रिमेंबर, फ्री में मिलता है पेन, है ना. नॉन हेयरी स्किन में मीजनस आर गोइंग टू बी मैक्सिमम एज कंपेयर टू द Merkels. Please remember that. Okay, protective phenomena. पेन इज ऑफ टू टाइप, हमने पढ़ा था, फास्ट पेन एंड स्लो पेन. बता दो, कैरी किससे होता है? व्हाट आर द नर्व फाइबर्स व्हिच कैन कैरी दिस? फर्स्ट रिमेंबर, फास्ट पेन इज द सुपरफिशियल पेन एंड स्लो पेन इज द visceral pain and deep type of pain. नर्व फाइबर बताओ यार, फटाफट फटाफट, टाइम नहीं है. वेरी गुड वेरी गुड वेरी गुड. ए डेल्टा इज गोइंग टू बी द फास्ट पेन का नर्व फाइबर एंड स्लो पेन का इज सी फाइबर. एब्सोल्युटली वंडरफुल, अनमाइलिनेटेड सी फाइबर्स. मेन न्यूरो ट्रांसमीटर, यहाँ पर स्लो पेन का क्या होगा? एस फॉर सो पेन, एस फॉर सब्सटेंस पी, सब्सटेंस पी. एग्जाम्पल दो, कोई भी विसरल पेन, एमआई का पेन, एब्डोमिनल पेन, है ना, गॉल ब्लैडर वाला पेन, किडनी स्टोन वाला पेन, ऑल दैट पेन, हेपेटाइटिस वाला पेन, ऑल दैट पेन is a slow pain. On the other hand, skin injury, any skin injury is going to be superficial. Skin is superficial, है ना. So superficial injury, mosquito का kiss is going to be your superficial pain. Main neurotransmitter कौन सा होता है? Glutamate. Remember, someone said me that the mating is always excitatory. So most excitatory hormone or neurotransmitter is going to be helpful in the superficial pain, है ना. वो सब जल्दी जल्दी समझ में आ जाता है, ऐसे वाले एग्जाम्पल दो तो, है ना. एंटीरियर, देर आर 3. हमने अब रिसेप्टर पढ़ लिए. वी हैव लर्न द रिसेप्टर, नाउ वी आर टॉकिंग अबाउट द ट्रैक्स, है ना. एंटीरियर, लैटरल एंड पोस्टीरियर, दीज आर द 3 ट्रैक्स अवेलेबल. एंट से याद रखो एंटीरियर, एंट से याद रखो एंटीरियर. प्लीज रिमेंबर द एंट, है ना, ये वाली एंट. If the ant is crawling on your body, what sensation you are going to have? Are you going to have fine touch or crude touch, बच्चों? Someone saying sexual crude. Okay, crude touch and fine touch कभी नहीं होगा, है ना. Crude touch and itching, you're going to have itching also. And I don't know how to relate this, but you have to remember this sexual sensation is also carried by this anterior, है ना. Now, coming to the lateral, lath mara, someone kicks you. If someone kicks you, you'll be having pain and your temperature is going to rise. You're going to be very, very angry and your temperature is going to be very, very hot temperature. So please remember, pain and temperature is carried by the lateral. Rest all sensation is going to be carried by the posterior column, be that the proprioception or the fine touch or the stereognosis, graphesthesia, vibration, pressure, all these are carried by this. Don't remember all this. Just remember, crude touch, itching, sexual sensation, pain, temperature nahi hai. All of them are carried by the posterior column. Posterior column. Now यहाँ पर brown secret पढ़ेंगे. What we are going to run? Brown secret. क्या होता है बताओ यार, क्या होता है brown secret? बताइए जल्दी, जल्दी बताइए वरना क्लास नहीं खत्म होगी आज. हाफ सेक्शन कर दिया आपने, हेमी सेक्शन. आधा ब्रेन हमारा वो ऐसे ही उड़ा पड़ा हुआ है, स्पाइनल कार्ड भी काट दो, है ना. सो हाफ सेक्शन, दैट मीन्स हेमी सेक्शन ऑफ द स्पाइनल कॉर्ड. इफ यू कट द हाफ सेक्शन ऑफ द स्पाइनल कॉर्ड, what is going to happen? The contralateral loss of pain temperature is going to happen. Contralateral loss of anterior tract sensation and the lateral tract sensation, mainly pain, temperature, crude touch, itching. But crude touch गया करके कोई नहीं आएगा. Nobody is going to come to you as, ma'am, I'm not able to feel the crude touch. They will be coming to you via the complaints of loss of pain and temperature on contralateral side. So please remember, contralateral loss of pain and temperature, crude touch is going to be the Brown-Sequard syndrome. What about the dorsal column? See over here what is shown. First thing, this is the anterolateral tract. Anterolateral tract over here. Anterolateral tract, the pink wala is going to be shown over here. This pink this nerve is going to be the first order neuron. This is the first order neuron which is going to have the synapse in the spinal cord itself. As soon as it is going to come in the spinal cord, it is going to do what? It is going to give the second order neuron. The second order neuron crosses in the spinal cord itself. And that's why if I cut it on the right hand side, let's say यहाँ पर मैंने right में काटा और यहाँ पर भी मैंने right में काटा, what is going to happen? See over here, if I cut on the right hand side, what is going to happen? Contralateral loss of anterior and lateral column. But यहाँ से जो dorsal column, if I see in the dorsal column, the dorsal column वाला same side of nerve fiber is going to be cut. So ipsilateral loss of all these sensation which are carried by the dorsal column will be gone. So please remember, contralateral loss of pain, temperature and crude touch. All others will be lost on the same side. Please remember that. All right. This is known as Brown-Sequard syndrome. Brown-Sequard syndrome. All right. Okay. Next. Penfield homunculus. ये क्या है? What is this? This is the topographical map of your body present in your brain itself, है ना? So how much area is given to what part depends on how much you use that part. Maximally, to handle everything, we use the hands, and to see and everything, we use our face, है ना? So maximum area is given. This is known as homunculus. This is a sensory homunculus, depending on how much you use that body part. If you use that maximally, maximum area will be given to it. Maximum area is given to the hand and face, especially in the hand, it is given to the thumb and the lips. Please remember, fingertips and lips. Simple, rhyme कर रहा है. Fingertips, lips, going to have maximum area. ट्रंक एंड हिप, ये देखो इतु पिद्दू पिद्दू सा एरिया दिया हुआ है हिप के लिए एंड ट्रंक के लिए. द ट्रंक एंड हिप इज गोइंग टू हैव द मिनिमम एरिया. ये देखो हैंड के लिए इतना बड़ा एरिया है, फेस के लिए इतना बड़ा एरिया है. प्लीज रिमेंबर दैट. ओके, what do you mean by cortical plasticity? The ability to make a new synapses, neighboring neuron के साथ new synapses बनाने की ability. For example, if the person is blind, what is going to happen? He is not having the eye, but these neurons are active. These neurons in the brain are active. What they are going to do? The neurons are active. So what they are going to do is they are going to take up the action of neighboring neurons. And this can explain the phantom limb also. phantom limb also. So please remember, phantom limb आया तो either you are going to write cortical plasticity or the law of projection. Law of projection. Cortical plasticity is more accurate, so you can write cortical plasticity. All right. So please remember that neighboring neurons का work take over कर लेगा. So that is the एग्जाम्पल अभी दिया बच्चे, ब्लाइंड होगा तो देखने की क्षमता नहीं है, बट दैट न्यूरॉन इज नॉट गोइंग टू फ्रीली सिट देयर, दे आर गोइंग टू डू द वर्क. व्हाट वर्क इट कैन हैव? यू कैन सी दैट द ब्लाइंड पर्सन हैव अ नाइस smell sensation. They can have the better sensation of touch and smell and hearing, right, as compared to the normal person. That is a cortical plasticity. Okay, that is the one of the example. ये क्या है? स्पेशल सेंस में आ गए हम. ऑफ्थेल में सब कुछ पढ़ाया जाएगा. दिस इज अ फिजियोलॉजी पार्ट. एज सुन एज यू आर गोइंग टू हैव लाइट ऑन टू योर आईज, व्हाट इज गोइंग टू हैपन? देयर विल बी रेटिनल विच इज इन द सिस फॉर्मेट. 11 cis retinal will be converted into all a trans retinal. कैसे याद रखोगे? C comes first and then the T comes. And please remember, this is all, not all. All क्या होता है? It is the aldehyde. Please remember, this is also aldehyde, this is also aldehyde. It is not alcohol. Alcohol होता तो all लगता. एक मिनट दे दो. All right. So please remember that. Please remember that it is the all, not all. Okay. Let's move on. Hearing में क्या है? Just remember one thing, है ना? ये सब आपको ENT में पढ़ाया जाएगा. Just remember one thing, that because of the potassium entry, I'm going to have depolarization. ये क्या बात कर रही? Potassium entry क्यों हो रही है? Because you do have something known as tria vascularis, which is going to put lot of potassium into my scala media, है ना? So please remember, due to potassium entry, this is the only place where the potassium is more outside. वरना हर जगह हमने क्या पढ़ा था? Potassium is more inside the cell. But this is the exception where the potassium is more outside, and that's why as soon as entry, all right, please remember that is only place. Move on to auditory cortex, सुनने वाला cortex, है ना? If I ask you some question, what do? You listen to me first of all. That listening skill, you comprehend that thing, right? That means you understand. Stuck? Now okay? एक बारी refresh कर लो बच्चों. एक बारी refresh कर लो. All right. Okay, I'm coming back again. If I ask you one question, what you do? You comprehend that thing. That means you try to understand what I'm asking you. All right. Once you understood, ये understanding वाला काम कौन करता है? This the superior temporal lobe is going to do the comprehension work or understanding of the speech. That is known as Wernicke's area. All right. Now you understood what I'm asking you, है ना? You have to give the answer either via writing or via speaking out, right? So who is going to do that motor work? When you are typing something, you are moving your skeletal muscle. When you are talking, you are moving your vocal cord, you are moving your all oral muscles. So please remember, that is the motor area. Which is the motor speech area? बोलना से याद रखो, Broca's area. Broca's area is my motor speech area. Broca's area is my motor speech area. बोलना से याद रखना, right? So please remember, if I have sensory aphasia, that means my Wernicke is defective. Sensation, क्या समझ में आ रहा है या नहीं, ये कौन decide करता है? Wernicke's area. So can he talk fluently? Yes, he can talk fluently because the motor area is normal. Broca's is normal. Bolna is normal. So he is going to talk nonsense things all the time. The speech is going to be fluent, but senseless speech, है ना? बहुत सारे लोगों को देखा होगा आपने, है ना? You know such people, right? That is known as Wernicke's aphasia or sensory aphasia or fluent aphasia. But if someone has the problem in the Broca's area कहाँ पर होता है? Inferior frontal cortex में. If someone has the problem in the speaking, he can understand the thing properly, but he cannot speak. That is known as motor aphasia or non-fluent aphasia. अटक अटक के बात करेगा, right? But he can understand everything, but he will speak with the you can say in the interruptions in between. So that is known as non-fluent aphasia. Now, over here, I want you to focus on this area. This is the central sulcus. Central sulcus divides your parietal lobe and frontal lobe, right? Now, there is something known as post-central gyrus, right? These elevations are known as gyri. Okay. So post-central gyrus, please remember this is the sensory cortex. S for S, sensory cortex, right? And there is something known as pre-central gyrus. अगर central sulcus के आगे होगा, it is in front of the central sulcus, I'm going to call it as pre-central gyrus, right? Pre is for motor and post is for sensory. Please remember S and S. This question has been asked, so please remember that. That is all for this slide. Wernicke's Broca's, we have already discussed this. Let's come into the UMN and LMN. UMN and LMN. क्या होता है ये ह्यूमन एंड एलिमेंट? पहली चीज, एलिमेंट क्या होता है एंड ह्यूमन क्या होता है? लोअर मोटर न्यूरॉन डिजीज, अपर मोटर न्यूरॉन डिजीज. प्लीज रिमेंबर, अगर मैंने बोला अपर मोटर न्यूरॉन क्या है, वो सारी चीजें जो कंट्रोल करती है लोअर मोटर न्यूरॉन को. यू डू हैव टू टाइप्स ऑफ लोअर मोटर न्यूरॉन. अच्छा बच्चा दैट इज अल्फा मोटर न्यूरॉन, गंदा बच्चा दैट इज गामा मोटर न्यूरॉन, है ना? सो अल्फा बच्चा, अच्छा बच्चा को क्या करना चाहिए? अच्छा बच्चा को आपको स्टिमुलेट करना चाहिए, गंदा बच्चा को आपको इनहिबिट करना चाहिए, राइट? बट दिस गंदा बच्चा कंटिन्यूअसली माहौल बनाता रहता है ना? इट फायर्स इन एसिंक्रोनसली. दैट इज इंपॉर्टेंट फॉर माहौल बनाने के लिए. माहौल क्या है? टोन इन द मसल. फॉर दैट इट इज इंपॉर्टेंट, right? So if I cut this lower motor neuron, that means alpha motor neuron will not be activated, gamma motor neuron will not be activated, there will be no tone in my muscle, the muscle will be flaccid. That is known as flaccid paralysis. That is known as flaccid paralysis. But if I cut the upper motor neuron, now what is the problem? Please remember, I'm not going to cut the alpha motor and gamma motor. I'm going to cut down the stimulation on alpha motor. That means voluntarily I cannot do any activity. But the problem is that inhibition on the ganda bacha is gone. Mummy papa is not there in the home. What is going to happen? Tabahi, है ना? It is going to fire a lot more. Excessive firing is going to occur, right? So that is going to cause continuously high tone. I'm not going to contract it, I'm not going to relax it. High tone is going to be there, continuously contracted phase. That is known as spastic paralysis. Spastic paralysis. What is going to happen to the tone in the alpha motor neuron? The tone is going to be very very high, hypertonia. Lower motor में क्या होगा? gamma गया, lower वाला गया, so tone is going to be lower. And DTR is dependent on deep tendon reflexes. For that, the tone is required. If the tone is high, DTR is going to be higher. If the tone is low, DTR also going to be low. Muscle atrophy. If you do not use the muscle, you're going to have the atrophy present. But the atrophy will not be seen. Why? Atrophy कैसे दिखेगी? It is continuously contracting, right? So you're not going to see the muscle atrophy. You're going to have spastic paralysis over here. And fasciculation and fibrillations are present in the lower motor neuron. Please remember, upper motor neuron में you have Babinski sign. Babinski sign क्या होता है बच्चों? Whenever I'm going to struck the foot of the person from laterally towards medially, there will be fanning of the finger and dorsiflexion, है ना? So क्या दिखेगा? UMN lesion में dorsiflexion and fanning of all the toes. Fanning of all the toes like this, है ना? It is going to be fan away, right? So ये ऐसे दूर दूर जाएंगे and the great toe is going to be dorsiflex. So dorsiflexion of the great toe and fanning of all the limb, that is Babinski sign. यहाँ पर कौन सा दिखता है? You can see the flaccid paralysis. Flaccid paralysis. I hope you can understand. Are you with me? Are you with me? राइट। चलो आगे बढ़ते हैं। स्ट्रेच रिफ्लेक्स, वंडरफुल वंडरफुल, यू कैन अंडरस्टैंड। मोनोसाइनेप्टिक रिफ्लेक्स, लोडिंग रिफ्लेक्स, डीटीआर, मायोटैटिक, एक ही नाम है सबके। योर फ्रेंड्स आर गोइंग टू कॉल समथिंग टू यू, योर मम्मी इज गोइंग टू कॉल समथिंग टू यू, योर गर्लफ्रेंड बॉयफ्रेंड इज गोइंग टू कॉल समथिंग टू यू, है ना। द सेम नेम, द पर्सन इज सेम, है ना, द रिफ्लेक्स इज सेम, different different nicknames are there. All right, now when you give a passive stretch, matlab you're not going to stretch on your own, somebody else stretch your arm, what is going to happen? There will be contraction. Why? Because somebody else stretches your arm, that will be increasing the length of the muscle, but I want to maintain the muscle length, hai na, so I need to decrease it back to the normal. How this is going to happen? There are length sensors available. What are the length sensors? Muscle spindle, है ना, LE length, muscle spindle, LE, muscle spindle are going to be the length sensors. What they do, they are going to stimulate my alpha motor neuron. Alpha motor neuron कैसे स्टिमुलेट करेंगे? देर आर afferent fibers. What are the afferent fibers? 1A and 2. 1A and 2 is going to cause the alpha motor का firing, and as soon as the alpha motor is activated, I'm going to contract. अच्छा बच्चा को क्या करेंगे? अच्छा बच्चा को activate करेंगे तो muscle is going to contract, and because of that the length is going to come back to the normal level. Are you with me? Are you with me? Yes or no? बताइए जी। Now, length has been done, है ना? But if I excessively contract something, I don't have wire and I don't want to move this wire because this is kind of loose, सब इधर उधर हो जाएगा, है ना? So, let's say I contract it, I stretch it normally, the length is going to increase. But if I stretch it too much, what is going to happen? Now the tension is going to increase. When you increase the tension, आफ्टर द टेंशन यू नीड टू रिलैक्स, है ना। क्लास के बाद करेंगे हाफ एन आवर मोर, उसके बाद आप रिलैक्स करना, राइट। सो आई नीड अ टेंशन सेंसर ऑल्सो। कौन होता है टेंशन सेंसर? टेंशन सेंसर इज टेंडन, राइट, टेंडन। सो टेंडन इज गोइंग टू एक्टिवेट माई 1B फाइबर, है ना। यहाँ पर 1A and 2 था, यहाँ पर 1B is going to be there. Now it stimulates the inhibitory interneuron. Inhibitory interneuron. This inhibitory interneuron is going to inhibit, this is going to inhibit my alpha motor neuron. It is going to inhibit my alpha motor neuron, and that is going to cause muscle relaxation. Now no more contraction is going to take place. It is the muscle relaxation. How many synapses are formed here? How many synapses? One synapse here and another synapse here. That's why it is known as disynaptic reflex. इसको क्या बोला था? इसको बोला था मोनोसाइनेप्टिक रिफ्लेक्स, क्योंकि एक साइनेप्स यहीं पे बन रहा था बस, राइट। बट ओवर हियर आई एम गोइंग टू हैव two different synapses. One is towards inhibitory interneuron and next is towards the alpha motor neuron. Disynaptic reflex. इससे क्या होगा? Muscle length is going to increase, so that's why it is known as lengthening reaction. Lengthening reaction. Stretch reflex से उल्टा कर रहे थे. We were doing opposite thing in the stretch reflex. So that's why this is also known as inverse stretch reflex. याद रखना है तो क्या रखोगे? एक चीज याद रखो, that is the Golgi tendon organ and 1B. Golgi tendon organ and 1B. Intrafusal muscle fibers has two types of chain fibers and bag fibers, nuclear fibers. Two types of nuclear fiber, nuclear bag fiber and nuclear chain fiber. Now B से याद रखना, B for both. What I mean by that, B for both means it has both the fibers, that is static also, dynamic also. Nuclear chain on the other hand has only static, only static. It has no dynamic, है ना। Dynamic किसी किसी की personality dynamic नहीं होती, we can call them as chain fibers, है ना, but dynamic are present in the bag fiber. Now they can give me the change in the length per unit time. Change बता सकते हैं, that's why I'm going to call them as dynamic. So they are going to tell me about velocity and motion and everything. So they are dynamic fibers. Now what are the nuclear chain fibers? Chain fibers are going to tell me only the resting length. Before the contraction of length, what was the length? That was resting condition. And after contraction, what is the length? That is also a static condition. So initial and final length is going to be told to me by the nuclear chain fiber. Static and dynamic please याद रखना, है ना। आते हैं स्लीप में, जो आप करने वाले हो इस क्लास के बाद, है ना। मैं भी चेन की नींद सोऊंगी, राइट। So bat dance is the mnemonic. What is the bat dance, बच्चों? Bat dance is beta, alpha, theta, delta. Beta wave, alpha wave, theta wave and delta wave. अगर ये कहाँ से प्रोड्यूस होती है, जस्ट एक चीज याद रखनी है आपने, दैट इज रास. ये इस स्लाइड में और कुछ भी याद रखने की जरूरत नहीं है. जस्ट रिमेंबर द बीटा वेव. इट इज गोइंग टू बी देयर when you stimulate the RAS system. That means very highly active brain is going to be giving you the beta wave. Then alpha wave में क्या याद रखोगे? Meditation position. Meditation means you are awake but eyes are closed. Eyes closed meditating. That is your alpha position, है ना? D is seen in the deep sleep. And light sleep में you are going to see the theta wave. Beta wave is also seen in the REM sleep. What you are talking about? Yes, in the REM sleep, the person is in the sleep, but I can see the beta wave. And that's why the REM sleep is known as paradoxical sleep. Paradoxical sleep. What are the frequencies? Just write down the frequencies like this. 0 to 3, I'm going to have delta wave. Then 4 to 7, I'm going to have theta wave. Then 8 to 13, I'm going to have alpha wave. And from 14 to 30 frequency, that is 30 hertz, if the frequency is given, that is called as beta wave. So bat dance. Please remember that. है ना? NREM and REM. I just now told you that the paradoxical sleep. Why? Because you can see the beta waves in this, and that's why it is known as paradoxical sleep. REM sleep में भी सपने आते हैं. They are known as, but you remember those nightmares, right? You remember those scary dreams. Those scary dreams can be remembered later on. They are known as nightmares. And the scary dreams which are not remembered, that is known as night terror, which can be seen in the NREM. Sleep topping, sleepwalking, teeth grinding, and nocturnal enuresis, that means bedwetting. All of these are altered events which are seen in the NREM, right? NREM. What about the REM? REM may the muscle atonia is going to occur. That means you don't have any tone in the any of the muscle except you want to stay alive, right? So that's why respiratory muscle. And as the name suggests, rapid eye movement. That means eye movement is occurring, and the eye movement is going to occur via the extraocular muscles. So these two muscles are active. Except these two muscles, all are going to have the atonia, and the spikes will be generated in the sleep from the pontogeniculo-occipital area, and that's why they are known as pontogeniculo-occipital spike, which is the hallmark of the REM sleep. दो चीजें अगर याद रखनी, तीन चीजें तो याद रखना, रेम स्लीप में पीजियो स्पाइक इज द हॉलमार्क. बीटा वेव दिखने की वजह से यू कैन कॉल इट एज पैराडॉक्सिकल स्लीप. And you can remember that all the parasomnias is going to be seen in the NREM. तीन चीजें एटलीस्ट याद रखो इस स्लाइड से. हाइपोथैलेमस के डिफरेंट डिफरेंट एक्शन दिए गए हुए हैं. देयर इज नथिंग टू टीच इन दिस स्लाइड. जस्ट रिमेंबर दीज आर द न्यूक्लियस नेम. Sleep wake up cycle, that is known as circadian rhythm. Sleep wake up cycle circadian rhythm is maintained by suprachiasmatic nucleus. ANS का nucleus होता है आपका paraventricular nucleus, sympathetic and parasympathetic system. The anterior hypothalamic nuclei and the preoptic nucleus important for the sexual behavior, and thirst control के लिए I require lateral hypothalamus. Please remember, lateral hypothalamus also controls the hunger, and it also controls the anger. If the lateral hypothalamus is stimulated, my thirst center will be activated, my hunger center will be activated, my anger center will be activated. So it is also known as hungry, है ना, or hangry, है ना. Hungry or hangry. There is a terminology which is known as hangry. क्या होता है hangry? When you are hungry, you are angry. Why? Because the area is similar, right? Appetite regulation में आते हैं. कुछ हॉर्मोन्स होते हैं जो आपको सटाइटी देते हैं आफ्टर ईटिंग द फूड, राइट? दे गिव यू सटाइटी. सम हार्मोन इफ दे आर रिलीज, दे स्टिमुलेट द हंगर. हंगर न्यूक्लियस कौन सा होता है? हंगर इज जस्ट नाउ वी सॉ लैटरल न्यूक्लियस ऑफ हाइपोथैलेमस. सटाइटी इज वेंट्रोमीडियल, है ना. कैसे याद रखोगे? आफ्टर ईटिंग द फूड, व्हेन स्पेशली द अंकल टाइप ऑफ पीपल, हाउ दे डू? पेट भर गया, है ना. सो दे पुट द हैंड एंटीरियरली एंड मीडियली ऑन द स्टमक. सो ventromedial nucleus. Please remember that is present in the hypothalamus, but just for the remembering purpose. And याद कैसे रखोगे? You're going to remember mango. Mango is your hunger hormones. क्या क्या होता है? MCH is your melanin concentrating hormone. AGRP is your agouti related protein. Neuropeptide Y, ghrelin, neuropeptide Y, ghrelin, and orexin. These are your हंगर हॉर्मोन्स. सटाइटी क्या होता है? व्हेन यू आर नॉट नो मोर हंग्री. प्लीज रिमेंबर अल्फा MSH. MSH भी दिया होगा एंड MCH भी दिया होगा. हाउ टू रिमेंबर? सैटाइटी इज गोइंग टू बी कॉज बाय MSH एंड नॉट बाय MCH, है ना? C आया तो वो हंगर करवाएगा, S आया तो वो सैटाइटी करवाएगा. प्लीज रिमेंबर दैट. ओके, नॉट ओनली दैट, द लेप्टिन इज गोइंग टू बी हेल्पफुल and all the intestinal hormones are going to be important. Intestinal hormones including the insulin. So please remember all these things, है ना? स्लीप वेकफुलनेस. स्लीप के लिए दो चीजें याद रखना, जो जिसमें जिसमें ए है दैट इज गोइंग टू बी रेगुलेटिंग द स्लीप, दैट इज गाबा एंड ACH, है ना? और बाकी सारे हॉर्मोन्स है दे आर गोइंग टू रेगुलेट योर वेकिंग साइकिल, है ना? टेम्परेचर रेगुलेशन में कौन कौन काम आता है? रिमेंबर द AC. AC क्या होता है? यू मस्ट हैव सीन द विंडो AC, है ना? विंडो AC क्या करता है? इट हेल्प्स अस इन द टेम्परेचर रेगुलेशन. क्या करता है ये? If you stand in front of the AC, when the environment is hot, you're going to stand anterior to the AC. And when the environment is cold, ठंड लग रही है, but you don't have heater, you're going to stand at the posterior side of the AC. So please remember, when you want to adapt in the cold environment, you're going to stand posteriorly. Just remember as this as the hypothalamus. Anterior खड़े होंगे जब you are having the summers, that is hot adaptation, and vice versa. Don't be afraid to start over. It's a chance to build something better, है ना? So let's start the new system, है ना? Easier system, thankfully. General physiology फटाफट से कवर करते हैं. General physiology, homeostasis हमें सबने पता है कि दिया था ये WB Cannon ने, है ना? And milieu interior was given by the Claude Bernard. How to remember? MI. जब MI होता है तो if the person doesn't come to us, he is going to go in the cloud. So please remember, milieu interior given by the cloud. And regulatory systems are there. मोस्ट कॉमन सिस्टम कौन सा होता है? नेगेटिव फीडबैक. नेगेटिव फीडबैक इज द मोस्ट कॉमन सिस्टम. इफ समथिंग इज आस्किंग फॉर मोर दैट इज गोइंग टू बी पॉजिटिव फीडबैक. मोस्ट कॉमन नेगेटिव है, सो वी आर नॉट गोइंग टू टॉक अबाउट मोस्ट कॉमन. वी आर गोइंग टू टॉक अबाउट स्मार्ट स्टडिंग. वी आर गोइंग टू टॉक अबाउट फीड फॉरवर्ड एंड द पॉजिटिव फीडबैक सिस्टम. इसका आंसर क्या होगा बच्चों? नेगेटिव फीडबैक का आंसर होगा बैरो रिसेप्टर. व्हाई आई टेल यू, वी डोंट हैव टाइम, सो आई हैव टू गो फास्ट, है ना? फीड फॉरवर्ड मैकेनिज्म. फर्स्ट ऑफ ऑल, फीड फॉरवर्ड क्या होता है? फीडबैक क्या होता है? फीड फॉरवर्ड, इफ आई टॉक अबाउट फीड फॉरवर्ड, even before the variable has been changed, the correction has been started, है ना? When you study after the exam or before the exam? You study before the exam. You are correcting your things, you are correcting your answers even before going to the exam via giving lot of GTs, है ना? That means you are anticipating what is going to happen, what is going to come in the exam, and you are studying that. So what are the examples of such thing? The correction is occur even before the variable has been changed. Temperature regulation, please remember, only the core body temperature regulation is going to occur via the feed forward mechanism. Shell body temperature नेगेटिव फीडबैक होता है. जस्ट यहाँ पे इतना याद रखना. एंड जस्ट बिफोर द स्टार्टिंग ऑफ द एक्सरसाइज, योर हार्ट रेट इज गोइंग टू बी इंक्रीज, दुक 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 दुक, राइट? दैट इज गोइंग टू बी योर फीड फॉरवर्ड सिस्टम. Even you think about the food, I know you must be hungry right now, so you think about the food, or even if you see the food, you're going to be having the gastric acid secretion started. That means you are not eaten the food right now, but still you are having the gastric acid secretion. That is your feed forward mechanism. Gain क्या होता है बच्चों? Gain क्या होता है? Gain is the efficiency. To measure the efficiency, you're going to have a gain. Just formula याद रखना, correction upon error is the gain, है ना? कितना efficiently your regulatory mechanisms are working, that is nothing but gain. All right, so positive feedback की slide गायब है यहाँ से, so I think I have to write it. एक बार लिख लो, that is very very important. Positive feedback मुझे दिखा नहीं कहीं पे. All right, before going to go towards the positive feedback, H2 clamp लिख लो. H2 clamp is the Head's paradoxical reflex. Head's paradoxical reflex. Hodgkin cycle. Hodgkin cycle. Clotting cascade. Clotting cascade. LH surge. LH surge. Activation of digestive enzymes. Yes or no? Are you with me? M is for milk letdown reflex. कुछ बच्चे अभी सो के उठे हैं, गुड इवनिंग लिख रहे हैं. हमारी गुड इवनिंग तो हो चुकी थी, हमारी गुड नाइट होने का टाइम आ गया है. पार्चुरेशन रिफ्लेक्स. राइट, दीज आर द एग्जाम्पल ऑफ पॉजिटिव फीडबैक, है ना. हम हेड्स पैराडॉक्सिकल देख चुके हैं. ओपनिंग ऑफ सोडियम चैनल कॉजेस ओपनिंग ऑफ मोर सोडियम चैनल्स, कैन बी सीन इन द एक्शन पोटेंशियल. क्लॉटिंग कैस्केड एलिमेंट सबको पता है, डाइजेस्टिव एंजाइम हम उसमें पढ़ेंगे, किसमें, जीआई में. मिल्क लेट डाउन रिफ्लेक्स एंड पार्चुरेशन रिफ्लेक्स हैपेंस बिकॉज ऑफ द ऑक्सीटोसिन. प्लीज रिमेंबर दैट ऑल्सो. सेल मेम्ब्रेन में आता है. सेल मेम्ब्रेन में सिंगर निकोसल हम सबको पता है. मैक्सिमम is going to be proteins. Protein सबसे ज्यादा होता है, please remember. 50 to 55%. 50 to 55% I'm going to have a protein. 40 to 45% I'm going to have the lipids, है ना. And what about carbohydrate? More than or equal to 5% is going to be the carbohydrate, which is the main lipid. It should be main lipid. Protein कहाँ से आ गया? मेन लिपिड वी आर गोइंग टू टॉक अबाउट. मेन लिपिड कौन सा होता है? मेन लिपिड इज योर फॉस्फोलिपिड. फॉस्फोलिपिड, है ना. एंड लिपिड एब्सेंट कौन सा होता है बच्चों? ट्राइग्लिसराइड इज नो नेवर नेवर इज गोइंग टू बी प्रेजेंट. तीन तिगाड़ा काम बिगाड़ा, हमें तीन तिगाड़ा नहीं चाहिए, तो याद रखो, तीन तिगाड़ा काम बिगाड़ा, ट्राइग्लिसराइड आ गया, काम खत्म है आपका, है ना. बिकॉज इट्स अ सैचुरेटेड प्रोटीन. हाईएस्ट कंटेंट किसका होता है? हाईएस्ट कंटेंट में हम लिखेंगे प्रोटीन, नॉट द फॉस्फोलिपिड, है ना. सो हम प्रोटीन लिखेंगे, प्रोटीन लिखेंगे, है ना. यहाँ पर लिखा हुआ है एम्फीपैथिक लिपिड कौन सा होता है? एम्फी मींस दोनों प्रॉपर्टी है. एम्फीपैथिक लिपिड क्या होता है? जिसमें दोनों प्रॉपर्टी है, हाइड्रोफोबिक ऑल्सो एंड हाइड्रोफिलिक ऑल्सो. फिलिक एंड फोबिक, है ना. दिस इज द हेड पार्ट ऑफ द फॉस्फोलिपिड एंड दिस इज द टेल पार्ट ऑफ द फॉस्फोलिपिड. One is having hydrophilic property, one is having hydrophobic property. So this is none other than the phospholipid which is going to have the amphipathic property. Solubility इसी के वजह से आती है. Who is going to have the maximum surface area? You can see the tail is going to have a maximum surface area, and that's why it is allowing my lipid soluble substances to cross the membrane very very easily. So please remember, lipid soluble substances can cross the cell membrane very very easily. Stem cell की तरह रखना, हमेशा adapt करना जल्दी जल्दी different चीजों से. All right, so solubility, that means lipid soluble substances can cross the cell membrane easily. ये चीज याद रखना, आई एम टेलिंग यू अगेन एंड अगेन, बिकॉज इसी पे पूरा आपका एंडोक्राइन सिस्टम इज बेस्ड, है ना. सॉल्युबिलिटी इज गोइंग टू गिवन बाय द लिपिड, सो दे विल अलाउ द लिपिड सॉल्युबल सब्सटेंसेस. अनदर क्वेश्चन इज, who is going to give you the flexibility? The cholesterol is going to give you the fluidity and flexibility. All other things are going to happen via the proteins. All right, let's move on. Gap junction, क्या होता है ये gap junction? It is allowing the transport to happen from one cell, ICF of one cell to ICF of another cell. First cell से लेके second cell में शॉर्टकट बना दिया, ग्रुप में मैसेज डाला, एट अ टाइम मेनी पीपल कैन रीड दैट मैसेज. what is the benefit? It can cause the quick transport. Shortcut है ना, so it is going to cause the quick transport of electrolyte, and because of which all the muscle fibers, let's say in the heart or in the gallbladder or in the urinary bladder, all the muscles can contract at the same time because of the same change in the electrolyte, quick change in the electrolyte. So that is going to act as a syncytium. क्या होता है बच्चों syncytium? It is the single unit, acting as a single unit. single unit. All of the muscles are going to act as a single muscle unit, and that is known as syncytium. On the other hand, अगर barricades लगा दिए, आपने tightly बंद कर दिया, this is the cell membrane of one cell, this is the cell membrane of another cell, बैरिगेटिंग लगा दी, आपने रोड को क्लोज कर दिया, यू क्लोज द रोड और अक्लूड द रोड एंड यू पुट द जैम, what is going to happen? No transport is going to happen between the cell, which is known as paracellular transport. Paracellular transport is not going to happen. It will inhibit the paracellular transport. Please remember, the jam is junctional adhesional protein. Jam लगा दिया, junctional adhesional molecules, right? So this is present in the blood brain barrier, and this is going to be what thing? This is going to be present in the nephrons. तो क्या करना है? टाइट जंक्शन में occluding jams and the clouding, close कर दिया रोड, है ना, बैरिगेट्स लगा के, right? So we can solve this question later on. ECF में कितना volume होगा? If you can calculate, you just have to remember one formula over here. 60-40-20 rule. What is 60-40-20 rule? My total body water is going to be 60% of the weight. The ECF, ICF is going to be 40 and 20% is going to be the ECF. That is 60-40-20 rule. यहाँ पर extracellular fluid पूछा है. That means 20 से multiply करना है. 70 into 20 upon 100, that is going to be 14. So my answer is going to be 14 over here. So please remember the 60-40-20 rule. आसानी से सारे क्वेश्चन सॉल्व हो जाएंगे. Please remember that. Body weight. Body weight, जो भी body weight दिया है, let's say it is 100%. Out of that, my 60% is going to be total body water. I'm going to divide that into two parts, intracellular fluid and extracellular fluid, out of which 40% is going to be the intracellular, 20% is going to be the extracellular fluid, which I'm going to divide into interstitial fluid and plasma. कौन सबसे बड़ा लग रहा है यहाँ पर? ये वाला है ना. So I'm going to give the maximum percentage to it, right? So 15% is going to be your what thing? It is going to be the interstitial fluid. If I take 100% as my ECF, then what is going to happen? I'm going to make 4 parts of it, 3 parts. That means 75% I'm going to give to the interstitial fluid, and remaining 25% of the ECF, I'm going to call it as plasma. ये 5% of total body weight है, don't get confused, है ना. of ECF लिख देती हूँ यहाँ पर, है ना. and this is जो पर्पल कलर में लिखा है of body weight. तो ध्यान से पढ़ना, बॉडी वेट पूछा है या ECF पूछा है. ऑलराइट, लेट्स मूव ऑन. A B C याद रखना, A/C है ना. क्या है ये A/C? If I have to calculate the body volume, I am going to call it as A/C. That is, A is the amount of dye and C is the concentration of the dye, है ना. concentration से divide करूंगी, but in the body there is no ideal situation. So what I need to do, I have to subtract whatever dye is metabolized or excreted from the body. A minus E upon C is going to be the formula for calculating the volume. Please remember this formula. All right, all right, all right. Let's solve the questions later on because we are running out of the time, है ना. So इन्होंने यहाँ पर interstitial fluid पूछा है. So interstitial जो भी I से आता है, that is going to be indirect method. There are going to be direct method and indirect method. Direct method में you are going to use the dye, right? Indirect method में you are going to use two dyes, है ना. What are the indirect methods से calculated volumes? That is the intracellular fluid. कैसे calculate करोगे? टोटल बॉडी वाटर माइनस ECF, राइट. एंड ये कैसे कैलकुलेट करोगे? ECF से आप प्लाज्मा माइनस करोगे. लेट्स सी ओवर हियर. फॉर द वन एंड लास्ट टाइम आई एम गोइंग टू टेल यू अबाउट दिस बॉडी वाटर, है ना. सो इसमें हम रखेंगे प्लाज्मा, राइट. ये हो गया इंटरस्टिशियल फ्लूइड. इन दोनों को मिला के हमने बोल दिया ECF, राइट. एंड दिस इज माई ICF. अगर सब कुछ मिला दूं मैं, तो दैट इज गोइंग टू बी टोटल बॉडी वाटर, है ना. टोटल बॉडी वाटर में से मैंने अगर ICF हटा दिया, दैट सॉरी, टोटल बॉडी वाटर में से मैंने ECF हटा दिया, आई एम गोइंग टू get the ICF. That's what I have written over here. टोटल बॉडी वाटर से ECF हटा दो, है ना. ICF बच जाएगा. ECF में से अगर मैंने इंटरस्टिशियल दिस ECF में से मैंने अगर प्लाज्मा हटा दी, आई एम गोइंग टू गेट द IF, राइट. अब डाइज पढ़ते हैं, हम डाइज पढ़ते हैं। डाइज कौन कौन से होते हैं? पहली चीज, अगर टोटल बॉडी वाटर मेजर कर रहे हो, व्हाट इज द फॉर्मूला फॉर वाटर? H2O. So you are going to use D2O, T2O and aminopyrin or antipyrin. These are the dye for total body water. And what are the dyes for the ECF? ECF के लिए कौन सी डाई होती है? Simon is the dye, है ना? क्या होता है? सुक्रोज, इन्यूलिन, inulin, mannitol, mannitol, and then you have the Simon is the mannitol, MAN. MA and N is the sodium iothalamate or radioisotopes, लिख दो, radioisotopes, है ना? मोस्ट एक्यूरेट इज गोइंग टू बी इन्यूलिन, सुक्रोज। साइमन याद रखो, मानसी याद रखो, वन एंड द सेम थिंग, राइट? रिमेनिंग इज द प्लाज्मा। प्लाज्मा इज हैविंग द आस्मा। आस्मा कैसा होता है? ब्लू ब्लू। सो कौन सी ब्लू डाई? इवांस ब्लू डाई यू आर गोइंग टू यूज. And if that is not in the option, radio labeled albumin can be used, because albumin is the heavy molecule. It cannot come outside of the plasma. It cannot come outside of the plasma. That's why I'm going to use the plasma over here. So यहाँ पर interstitial fluid का पूछा हुआ था, तो क्या आंसर आएगा? इन्यूलिन जो ECF को मेजर करेगा, राइट, एंड इवांस ब्लू जो आपके प्लाज्मा को मेजर करेगा। इसको माइनस कर दोगे, यू आर गोइंग टू गेट द इंटरस्टिशियल फ्लूइड। ऑलराइट, नेक्स्ट लेट्स मूव ऑन टू दिस फैगोसाइटोसिस। क्या होता है फैगोसाइटोसिस? दोनों पे देयर इज नो रिलेशनशिप बिटवीन द कॉन्सेंट्रेशन ग्रेडियंट, दैट इज द आंसर। लेट्स टॉक अबाउट ट्रांसपोर्ट अक्रॉस द मेम्ब्रेन। ये कुछ सिमिलर सिमिलर सा लग रहा है। स्टडिंग इज वेरी हार्ड, है ना? स्टडिंग एंड फॉरगेटिंग इज वेरी इजी, दैट इज पैसिव। एक्टिव पैसिव में डिफरेंस क्या है? दिस गोज अगेंस्ट द ग्रेडियंट, ग्रेडियंट के अगेंस्ट जाता है। दिस गोज अलोंग द ग्रेडियंट, है ना? एटीपी कौन यूज करता है? व्हेन यू गो अगेंस्ट द ग्रेडियंट। पढ़ाई करने में एनर्जी लगती है, फॉरगेटिंग में एनर्जी नहीं लगती। सो जाओ, अपने आप भूल जाओगे 4 महीने बाद, है ना? सो फॉरगेटिंग इज इजियर, वी डोंट टू डू सम डिफिकल्ट वर्क, है ना? एक्टिव में देर आर गोइंग टू बी 3 ways, 3 things in the active. Active में क्या होता है? Primary active, secondary active and the vesicular transport. Vesicular transport. प्राइमरी एक्टिव में क्या होता है बच्चों? प्राइमरी एक्टिव में आई हैव पंप्स। कौन कौन से पंप्स? सोडियम पोटेशियम पंप्स एंड द कैल्शियम पंप, हाइड्रोजन पंप्स। पी 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 याद रखो, पी फॉर प्राइमरी, पी फॉर पंप, S for secondary, S for simports. सिम्पोर्ट। अब डिफरेंस क्या है? सिम्पोर्ट में भी तो एनर्जी लग रही है, एनर्जी इज यूज्ड एवरीवेयर, बट प्लीज रिमेंबर दिस एनर्जी इज यूज्ड इनडायरेक्टली। इनडायरेक्ट यूज ऑफ एनर्जी इज देयर टू क्रिएट द ग्रेडियंट. The primary pump use the energy and this is dependent on the primary pump. Symport example दो, SGLT, है ना? SGLT बोल लो, या NCX, that is the antiport, है ना? क्या होता है NCX? सोडियम कैल्शियम एक्सचेंजर, राइट? जो भी सोडियम सोडियम वाले हैं ना, दैट इज गोइंग टू बी, इफ दे आर सिम्पोर्ट और एंटीपोर्ट, they are dependent on the primary pump because the energy is used to create the gradient, है ना? वेसिकुलर ट्रांसपोर्ट में आएगा आपका एक्सोसाइटोसिस, एंडोसाइटोसिस एंड ट्रांससाइटोसिस। ट्रांससाइटोसिस, प्लीज रिमेंबर वेसिकुलर ट्रांसपोर्ट इज ऑल्सो एक्टिव, है ना? ये क्या पूछा हुआ है? फैटी एसिड का ट्रांसपोर्ट पूछा हुआ है इसमें। फैटी एसिड में आपका ये वाला आएगा, क्यों? बिकॉज रिमेंबर आगे, हाँ, डिफ्यूजन आते हैं पैसिव में। पैसिव में आप डिफ्यूजन की बात करते हो, सिंपल डिफ्यूजन, फैसिलिटेटेड डिफ्यूजन। रिमेंबर सिंपल डिफ्यूजन में यू रिक्वायर नो कैरियर प्रोटीन, नो एनर्जी, एनर्जी भी नहीं चाहिए, कैरियर प्रोटीन भी नहीं चाहिए, right? So what are the example? Gases and all the lipid soluble hormones, lipid soluble vitamins, they are crossed via the simple diffusion. That means, see over here, if you increase the concentration of substance, the rate of diffusion is going to increase linearly. ऐसी एक straight line आएगी, that straight line is nothing but simple diffusion. Straight line, simple diffusion. All right, but in the facilitated one, I require the carrier protein. प्रॉब्लम क्या है? carrier protein are having limited capacity. Yes, they are going to increase the speed a bit in the first go, but the saturation is going to occur, है ना? जैसे ही the saturation it is going to reach up to their final limit. अब जैसे आपका saturation बनता जा रहा है, you cannot grasp any more what information, right? Similar saturation is going to happen in the carrier protein. So please remember, ऐसे कुछ parabola type this thing graph is shown, that is nothing but your carrier protein. They have saturational kinetics. They follow saturational kinetics, है ना? ये straight जब हो जाता है V max, that means they have reached their maximum limit. Smallest step in the right direction end up in the biggest step in the life. Let's take a smallest step towards next किडनी, दैट इज नेक्स्ट सिस्टम, है ना? क्या दिखाया है? दो नेफ्रॉन दिखाए हैं. व्हाट आर दे आर फंक्शनल यूनिट, स्ट्रक्चरल एंड फंक्शनल यूनिट. ध्यान से देखो, this is going deeper in the medulla. Let's say this is cortex, this is outer medulla, and this is inner medulla. Just I'm going to take 20 minutes more, है ना? 20 और मैक्सिमम 30 मिनट्स, है ना? कॉर्टेक्स, इनर मेडुला, आउटर मेडुला. जो इनर मेडुला में जाता है वो क्या है? द इनर मेडुला में जक्स्ट्रा मेडुलरी नेफ्रॉन्स, जक्स्ट्रा मेडुलरी नेफ्रॉन. जो कॉर्टेक्स में है सबसे ज्यादा, दैट इज नोन एज कॉर्टिकल नेफ्रॉन्स. क्या क्या डिफरेंसेस हैं बताइए जल्दी जल्दी, क्या क्या डिफरेंसेस हैं इसमें? कॉर्टिकल नेफ्रॉन्स किसके लिए इंपॉर्टेंट होते हैं यार? सबसे ज्यादा ब्लड फ्लो कॉर्टेक्स में जाता है, याद रखो, है ना? और कॉन्सेंट्रेशन ऑफ यूरिन में कौन इंपॉर्टेंट है यार? कॉन्सेंट्रेशन ऑफ यूरिन में हमारे जक्स्ट्रा मेडुलरी नेफ्रॉन्स इंपॉर्टेंट है, कॉन्सेंट्रेशन ऑफ यूरिन में, है ना? वासा रेक्टा किसमें होती है? वासा रेक्टा आर नथिंग बट द ब्रांचेस ऑफ पेरिटिबुलर कैपिलरी, जो कि आपके इनसाइड वाले न्यूरॉन में, इनसाइड वाले नेफ्रॉन में होते हैं. सो प्लीज रिमेंबर दैट वासा रेक्टा इज प्रेजेंट इन द जक्स्ट्रा मेडुलरी नेफ्रॉन्स, है ना? जक्स्ट्रा मेडुलरी, जक्स्ट्रा मतलब क्या होता है? नियर. जक्स्ट्रा मेडुलरी नेफ्रॉन्स. ऑलराइट, तीन लेयर होती है ग्लोमेरुलर फिल्ट्रेशन मेम्ब्रेन की. देयर आर थ्री लेयर्स, राइट? व्हाट आर द थ्री लेयर? ग्लोमेरुलर कैपिलरी एंडोथेलियल सेल्स, basement membrane, and epithelial cells of Bowman's capsule, right? If I draw like this, so suppose this is the afferent arteriole, glomerulus, efferent arteriole, right? And this is the Bowman's capsule, right? So there are going to be endothelial cells and their basement membrane, right? What is the function of the basement membrane? Mainly basement membrane is going to have lot of negatively charged molecule. They are going to have maximum negatively charged proteins. What is the function of this negatively charged protein? फटाफट से बताओ. Are you there with me? हाँ जी, क्या होता है इनका फंक्शन? यस, डेफिनेटली दे आर गोइंग टू रिपेल द नेगेटिवली चार्ज substances, especially the albumin and proteins. They will not allow the protein to filter into my Bowman's capsule. I cannot afford to lose the protein, right? Protein is my building block, right? So they are going to be helpful in the repulsion of the protein. So please remember that sialoprotein is one of the negatively charged protein. पहला, छन्नी के बारे में बात करते हैं. कौन सी छन्नी? चाय वाली छन्नी, हाँ ऐसा ही कुछ, है ना? सो इट इज एक्टिंग एज अ स्ट्रेनर, है ना? जिसमें से चाय छनते हैं ना हम, चाय पत्ती ऊपर रह जाती है. सो इट इज एक्टिंग एज अ स्ट्रेनर, राइट? सो how it is dependent that which is going to get filter, which substance is going to get filter and which is not going to get filter, it depends on the size as well as charge. Please remember, if the size is less than 2 nanometer, it is going to be freely filtered. That substance is going to be freely filtered. If the size of that molecule which is coming in the glomerulus is more than 4.5 nanometer, it is not filtered. It is not going to get filtered. Now, if it falls in between, it is dependent on the charge. Okay, if it is positively charged, it is going to get filtered. If it is negatively charged, it is not going to get filtered. Example is albumin. Albumin. If I lose these negatively charged protein which were there inside the basement membrane, what is going to happen? They will allow the albumin to come into my filtrate, to come into my Bowman's capsule. क्या डिजीज बोलोगे? इफ द एल्बुमिन इज प्रेजेंट इनसाइड द यूरिन, that means I don't have these negative proteins in my nephron. I'm going to call it as, yes please, I'm going to call it as nephrotic syndrome. Nephrotic syndrome. All right, very good. Proteinuria is going to be there, है ना? So इस स्लाइड पे नहीं लिखते हैं, अदरवाइज कंफ्यूजन हो जाएगी. प्रोटीन यूरिया मतलब ही आपका नेफ्रोटिक सिंड्रोम. नेफ्रोटिक सिंड्रोम इज गोइंग टू बी देयर, है ना? बात करते हैं ट्यूबुलर ट्रांसपोर्ट की. फटाफट आंसर दो, फटाफट फ्री करेंगे आपको. पीसीटी इज गोइंग टू डू मैक्सिमम वर्क. सबसे ज्यादा हार्ड वर्किंग कौन होता है? डॉक्टर्स. हाँ या ना? बिल्कुल हाँ जी हाँ. देखो 11 बजे भी हम लोग पढ़ रहे हैं ना. सो yes, tubular transport, PCT is going to be most hardworking part. It is going to do maximum reabsorption of all substances. But medicine इतनी आसान होती तो बात ही क्या होती? सब exception तो there ना. Some doctors do not read, है ना, नाम खराब करते हैं ना. So maximum reabsorption of all the substances except, what are the exception? Please remember, tell me what is the exception over here. The exception, reabsorption of all the substances except the magnesium. The magnesium reabsorption is going to happen where? It is going to happen in the PCT? No. Where it is going to happen? It is going to happen in the ascending limb of loop of Henle. Ascending limb of loop of Henle. So please remember that. Maximum secretion of all the substances is going to happen in the PCT, but except the potassium and urea. Potassium secretion is going to happen where, bacho? Potassium secretion is going to happen in the distal convoluted tubule, and CD I can call together as DT, है ना? And यूरिया का सिक्रीशन कहाँ पर होता है? प्लीज रिमेंबर, इस पे मैंने क्वेश्चन डाला हुआ है. यूरिया सिक्रीशन इज गोइंग टू हैपन इन द लूप ऑफ हेनले, स्पेशली द असेंडिंग लिम्ब ऑफ लूप ऑफ हेनले. असेंडिंग लिम्ब ऑफ लूप ऑफ हेनले, प्लीज प्लीज रिमेंबर दैट. ऑलराइट, चलो आगे बढ़ते हैं. एसजीएलटी क्या है बच्चों? नाउ प्लीज रिमेंबर, एसजीएलटी इज पीसीटी. पीसीटी में क्या है? Maximum number of SGLT are SGLT type 2. You do have two kidneys, one intestine. So please remember, SGLT1 maximally present in the intestine. Both the types of SGLTs are present in the kidney, but maximally two SGLT2 types. That is 90% are SGLT2 types. They are only present in the PCT. So glucose reabsorption only can happen in the PCT. Please remember that, है ना? आगे बढ़ते हैं. लूप ऑफ हेनले में आते हैं. डायरेक्ट क्वेश्चन पूछा जाएगा, डायरेक्ट आंसर देना. क्या है लूप ऑफ हेनले में? इज समथिंग नोन एज काउंटर करंट मैकेनिज्म. व्हाट इज काउंटर करंट मैकेनिज्म? काउंटर मींस अपोजिट, करंट मींस फ्लो, है ना? किस लिए इंपॉर्टेंट है ये? We want to conserve the water. क्यों करना है water conserve? Why you want to conserve the water? Because my body, 60% of my body weight is made up of water. I want to conserve the water. For that, what is required? Concentration of the urine is required, so that I can absorb more and more water inside my blood, and urine should be concentrated, right? So how I'm going to do that? With the help of hypertonic medullary interstitium. Okay जी, मान लिया. I have to do the hypertonic medullary interstitium inside my kidney. How can I do that? I need two things for that. What are the two things that I required? Counter current multiplier, which can multiply the gradient, है ना? 300 से 1200 तक. Multiply the gradient inside my interstitium, right? And who is going to do that? It is going to be done with the help of ascending limb of loop of Henle, as well as the medullary collecting duct. Medullary collecting duct. Okay ji, what they are going to do? They are going to create the hypertonic medullary interstitium. How they are going to create? By absorbing lot of salts from the tubule into the medullary interstitium, right? And that's why they are going to increase, they are going to multiply the osmolarity of the intestine via 4 times, that is 12, so is 1200 milliosmol per liter is the maximum osmolarity possible, right g? Okay, what is the next thing that is important? Counter current exchanger is also important. What is the counter current exchanger G? It is nothing but the vasa recta. What the vasa recta is going to do? It is going to maintain. Now you have created it. You have created the momentum via attending these classes. It is important to maintain this momentum, right? Till the time of exam. So how that is going to do? That is going to happen via continuous study. And same over here, that medullary interstitium needs to be maintained throughout, right? And that is going to be done by the vasa recta. How? The vasa recta doesn't allow that concentration to get diluted. It absorbs lot of water via water reabsorption back into the blood. It is going to cause the maintenance of hypertonic medullary interstitium. Let's move on forward. There is DT. That DT means distal tubule. Distal tubule mein you are going to have CD, that is collecting duct, as well as distal convoluted tubule. कौन से दो cells होते हैं? Please remember P cells and I cell. Question is going to come on this. Okay, P cell and I cell. P cell क्या होता है? Principal cell. राइट आई सेल क्या होता है? इंटरकैलेटेड सेल. इंटरकैलेटेड सेल. व्हाट इज द रोल ऑफ प्रिंसिपल सेल? व्हाट इज द रोल ऑफ द प्रिंसिपल सेल? हाँ जी बताइए, क्या रोल होता है प्रिंसिपल का और आई सेल्स का? हाउ टू रिमेंबर? प्रिंसिपल, दो आयंस आर प्रिंसिपल. व्हाट आर द टू प्रिंसिपल आयन? सोडियम एंड पोटेशियम. I'm going to reabsorb the sodium and I'm going to secrete the potassium. That is the main thing. Via that I can reabsorb the water also. But principal role kya hota hai? See over here. Via the ENaC channels and via the sodium potassium, this sodium chloride reabsorbing this channel, I'm going to reabsorb lot of sodium in the DCT, and ENaC channels are mainly present in the CD. All right. So via that I'm reabsorbing the sodium, and via ROM-K channel, renal outer medullary potassium channel, I am secreting the potassium. Okay, just remember this. I क्या करते हैं फिर? I cells, I'm going to remember like this. Right? What is I? I is doing the acid secretion. I don't want acid in my body, so I'm going to secrete acid via the intercalated cell. यहाँ पर देखो, यहाँ पर acid secrete हो रहा है, and this is also throwing out the acid outside. Who is going to stimulate these cells? These cells are stimulated by aldosterone. Aldosterone is going to stimulate both of these cells. So please remember, aldosterone is going to act on the DT and it is going to stimulate principal cells and I cell. ADH. ADH क्या करता है बच्चों? ADH is going to act on the V2 receptor. After acting as V2 receptor, it will increase the aquaporin 2. Aquaporin 2. What the aquaporin 2 is going to do? Aquaporin 2 is going to help me to reabsorb the water, that is H2O. So please remember V2 receptor, aquaporin 2 and H2O. V2 क्यों बोला? Because the ADH is also known as vasopressin. हाँ या ना? वेजोप्रेसिन. सो प्लीज रिमेंबर वेजोप्रेसिन का ये रोल होता है. लेट्स मूव ऑन टू द टीएमजी. क्या था टीएमजी? ट्रांसपोर्ट मैक्सिमम या ट्यूबुलर मैक्सिमम ऑफ ग्लूकोज, है ना? तो एक्सपेक्टेड वैल्यू क्या होती है जी इसकी? एक्सपेक्टेड वैल्यू होती है 375 mg/minute. बट एक्चुअल रियलिटी में क्या होता है? एक्चुअल वैल्यू इज वेरी वेरी लेस, दैट इज 180 to 200 mg/minute. हो या नहीं हो यहाँ पर? सो ये जो डिफरेंस आता है, द डिफरेंस इज नोन एज रीनल स्प्ले. क्या बोलते हैं डिफरेंस को? रीनल स्प्ले, है ना? एक्सपेक्टेड क्या है कि सबको आए कितने मार्क्स? 200, 300 आउट ऑफ 300, बट आते कितने हैं? 200, है ना? वी आर ओके विद इट, बट वी वांट मोर, है ना? ये दिल मांगे मोर. दैट डिफरेंस इज नोन एज रीनल स्प्ले. रीनल स्प्ले, ठीक है, याद रखना. अब आते हैं क्लियरेंस पे. व्हाट इज द क्लियरेंस बच्चों? व्हाट इज द क्लियरेंस? क्लियरेंस इज सिंपल फंडा. व्हाट इज द क्लियरेंस का फंडा? दैट अगर कोई सब्सटेंस सिर्फ फिल्टर हो रहा है, only getting filter, neither reabsorbed nor secreted, how much will come into the urine? Whatever is filter, that is going to come in the urine. What is such substance? That substance is nothing but inulin. Inulin. How that is useful? It is the most accurate substance for the measurement of GFR. GFR measurement के लिए most accurate substance है. If I say that little secretion will happen, what is going to happen? Yes, except it will the GFR will be there. That means maximum. Let's say 20% is getting filtered. Only 1% or let's say 0.5% got secreted. It is very close to the GFR, but it is not accurately measured. But if that is present endogenously, I'm going to prefer that substance. I don't have to give it IVly. Okay. So what is that substance? That is nothing but the creatinine. Creatinine is that substance, right? So it is the most common substance which is used for the GFR estimation, and most accurate pucha, you're going to answer it as inulin, right? Both are used for GFR estimation. If I filter the substance but completely secreted, है ना? Let's say 100% came in the renal plasma flow, 20% got filtered, and 80%. Now the 80% got 80% is got secreted. How much is going to come into the urine? This 100% is going to come in the urine. Complete secretion कौन है ऐसा substance? Para amino hippuric acid. किसके लिए यूज करूंगी? रीनल प्लाज्मा फ्लो के लिए यूज करूंगी मैं पैरा एमिनो हिपेरिक एसिड. रीनल प्लाज्मा फ्लो के लिए आई एम गोइंग टू यूज इट. व्हाई? बिकॉज वट एवर केम इनटू द प्लाज्मा it came into the urine. It's same. So I'm going to measure the renal plasma flow. If the substance got filtered and completely reabsorbed it, है ना? Our tubule reabsorbed it completely. Tubule से reabsorb हो गया how much? Tubule से reabsorb हो गया how much? Whatever got filtered, that completely got reabsorbed back again. So that is going to cause what thing? That is going to cause the complete secretion. Urine में कितना आएगा? 0%. 0/0. अंडा आएगा, अंडा, है ना? What is the such substances? The glucose. Glucose is completely reabsorbed because it's a salary, that is energy, है ना? Amino acid, that is also energy. It is complete reabsorbed back again. Glucose आया यूरिन में, what you are going to expect? डायबिटीज मलाइटिस, है ना? कुछ गड़बड़ जरूर है दया, कुछ तो गड़बड़ है ना? So if the glucose came into the urine of the patient, you are going to suspect something is wrong, है ना? Clearance का formula याद रखो. It is UV/P. U is the urinary concentration of the substance. Urinary flow rate is V, and plasma concentration is going to be your P. U and P is the concentration, urine का concentration and plasma का concentration. V is nothing but urinary flow rate. राइट, प्लीज रिमेंबर दैट. आते हैं जीएफआर पे. जेजी सेल्स, मैक्यूला डेंसा एंड लासिस सेल, तीन चीजें इंपॉर्टेंट होती है. जेजी अपैरेटस इज फॉर्म बाय थ्री थिंग्स, है ना? व्हाट कैन बी द क्वेश्चन दैट कैन बी आस्क्ड? सिंपल है. लासिस सेल पे कोई क्वेश्चन नहीं पूछेगा, बट बिकॉज इट हैज नो रोल पर से इन द जेजी बीपी मेंटेनेंस और एनी अदर थिंग. It is just used as anti-inflammatory cells. They can ask you which are the chemosensors are there. Chemosensors are macula densa, है ना? ये वाले जो cells दिख रहे हैं आपको, that is macula densa. Now, what chemical they are going to sense? They are going to sense the sodium and chloride. Please remember, sodium and chloride. Granular cells, what they are going to secrete? They are going to secrete the renin. कैसे होता है इनका वर्किंग? whenever you are going to have higher GFR, they are going to activate the RAS system, है ना? एंड दे आर गोइंग टू कंस्ट्रिक्ट दिस afferent arteriole. Afferent arteriole का कंस्ट्रिक्शन कर देंगे. whenever the GFR is going to be increased, the JG apparatus is going to be activated and the GFR is going to be brought back to normal again. इतना याद रख लो, है ना? रास सिस्टम एक्टिवेट हो जाएगी और रास सिस्टम से आपका एफरेंट आर्टीरियोल कंस्ट्रिक्ट हो जाएगा. सो लेस प्लाज्मा इज गोइंग टू कम, लेस फिल्ट्रेशन इज गोइंग टू अकर. सो दैट इज गोइंग टू बी definitely increased GFR होने पे they are going to get activated and the result is going to be decrease in the GFR. That is not the stimulus. Okay, that's what I wanted to tell you. Okay, नाउ देर आर टू टाइप्स ऑफ फोर्सेस, है ना, क्या दो टाइप ऑफ फोर्सेस होते हैं? फर्स्ट इज द हाइड्रोस्टैटिक प्रेशर एंड सेकेंड इज द ऑनकोटिक प्रेशर. Hydrostatic pressure is the pushing pressure. It pushes the water away. On the other hand, oncotic pressure is the holding on pressure. These proteins are loves to hold on to the water, है ना? So this is the oncotic pressure. कितना कितना होता है? Value दिया हुआ है. Hydrostatic pressure inside the glomerulus is going to be 60. Bowman's capsule में it is going to be 80. Now my question to you is, what is the oncotic pressure in the Bowman's capsule? बताइए कितना होता है oncotic pressure, क्योंकि colloid osmotic pressure is nothing but the oncotic pressure. That is in the glomerulus it is going to be 32. Absolutely wonderful, Prakash, Subhash. It is going to be 0. Why? Because this is present because of the proteins. यहाँ पर प्रोटीन्स आए ही नहीं, तो इट इज गोइंग टू बी 0. एंड हाउ टू कैलकुलेट दिस नेट फिल्ट्रेशन प्रेशर? कैसे कैलकुलेट करेंगे? HP माइनस ओपी, HP माइनस ओपी एंड HP माइनस ओपी. जस्ट यहाँ पर आपने क्या लगाना है? पहले ग्लोमेरुलस, है ना, एंड देन यू आर गोइंग टू पुट द बोमेन्स कैप्सूल का प्रेशर ओवर हियर. पहले हाइड्रोस्टैटिक प्रेशर से ऑनकोटिक प्रेशर माइनस करो, 60 से 32 माइनस करो, है ना, और उससे 18 माइनस करो, राइट? सो यू आर गोइंग टू गेट अराउंड 10 mmHg प्रेशर. ऑलराइट, एसिड सिक्रीशन में आते हैं. एसिड सिक्रीशन इज डिफरेंट, एसिडिफिकेशन इज डिफरेंट, है ना. मैक्सिमम एसिड सिक्रीशन इज गोइंग टू हैपन इन द पीसीटी, बट पीएच में कोई चेंज नहीं आता. क्यों नहीं आता? इफ आई ऐड 10 molecules of acid and 10 molecules of buffer, what is going to happen? pH is not going to change. Unless and until the pH is not going to change, I'm not going to call it as acidification, right? क्योंकि हमने सारे buffers use कर लिए हैं. But if they ask maximum acid secretion, where it is going to occur? It is going to occur in the PCT. The acid secretion is also going to occur in the CD and DCT, but please remember it is going to be much lesser. But we don't have any buffer to neutralize it, है ना. यहाँ पर let's say हमने 5 ही molecule of acid डाले, but we don't have any buffer to add into it. Definitely the pH is going to decrease. The pH is going to decrease because we used all the buffer in the PCT itself. So that's why the acidification is going to happen in the DT, that is CD, or in the DCT, right? Why? Because there are no buffers to neutralize the pH. All right. नॉर्मल यूरिन का पीएच क्या होता है बच्चों? 6 to 8, है ना, और मिनिमम क्या होता है? 4.5. दैट इज नोन एज लिमिटिंग पीएच. दैट इज द मिनिमम लिमिट. ओके, मिनिमम लिमिट. वेरी 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 गुड. ऑलराइट, लेट्स मूव ऑन. Okay, so small steps, not the giant steps, about to most lasting change. छोटा छोटा पढ़ेंगे और मार्क्स ले आएंगे, है ना. एंडो और जीआई बचा है, छोटे छोटे सिस्टम से. वी आर गोइंग टू फिनिश इट ऑफ, है ना. याद रखो, वी हैव टू डिवाइड द हार्मोन फर्स्ट ऑफ ऑल इन द, let's talk about the receptor. Lipid soluble या water soluble? Are you alive, guys? You are there or not? Please let me know. Are you alive? Intracellular and extracellular रिसेप्टर्स, है ना. तो क्या क्या करना है? इंट्रासेल्युलर में आई एम गोइंग टू टॉक अबाउट न्यूक्लियर, साइटोप्लाज्मिक या बोथ. याद कैसे रखोगे? न्यूक्लियर में देयर इज अ न्यूमोनिक विच इज नोन एज न्यूक्टैड. क्या है मैडम ये न्यूक्टैड? It is nothing but the thyroid hormone, vitamin A or vitamin D, which can act as a hormone, which are going to have the nuclear receptors. What is the cytoplasmic receptor for? Only through the cytoplasmic receptor my mineralocorticoid is going to act. What is the mineralocorticoid, sir? Bataiye please. It is none other than the aldosterone, right? और बाकी बचे ग्लूकोकॉर्टिकॉइड एंड योर दिस थिंग सेक्स स्टेरॉइड. दे आर गोइंग टू एक्ट थ्रू द both, right? Sex steroids mainly act through the nuclear. Sex steroids, they are mainly act through the nuclear receptor more than cytoplasmic. Please remember that. If you want to choose one, go with the nuclear receptors such as progesterone, testosterone, estrogen. They act through the मैक्सिमम थ्रू द न्यूक्लियर रिसेप्टर, है ना. सो न्यूक्लियर में याद रखना न्यूक्टैड. थायराइड तो याद ही रखना, राइट? कैसे याद रखोगे? विच आर द लिपिड सॉल्यूमेंट जिसके एंड में ऑइड ऑइड आ रहा है? थायराइड, corticoid, steroid, right? So please remember they are going to come under the lipid soluble hormone. let's say these are not lipid soluble hormone, they are water soluble. So I have to check whether they are pig hormone or not. If they are pig, they must be dirty hai na. So what is dirty? Tyrosine kinase. Tyrosine kinase is going to be the receptor for this pig hormone. What is the pig hormone? Prolactin, insulin, and ग्रोथ हार्मोन, ग्रोथ फैक्टर. दिस इज द रिसेप्टर. पाथवे पूछा तो क्या बोलोगे? इंसुलिन इज गोइंग टू एक्ट वाया मैप काइनेज. मैप काइनेज करके कुछ पाथवे होता है, उससे वो एक्ट करता है, राइट? नोबडी इज गोइंग टू आस्क यू अबाउट दैट. बट प्लीज रिमेंबर दिस ग्रोथ हार्मोन प्रोलैक्टिन, दे आर गोइंग टू एक्ट वाया जैक स्टैट पाथवे. जैक स्टैट पाथवे. इसके साथ साथ याद रखो लेप्टिन भी जैक स्टैट पाथवे से काम करता है. So leptin, prolactin and growth hormone, they are going to act through JAK-STAT pathway. याद रखोगे ना? करो प्रॉमिस कि याद रखोगे. And then if it is not lipid soluble, not pig hormone, they are going to act via GPCR protein. क्या होते हैं ये GPCR protein? They produce secondary messenger. कौन कौन से secondary messenger? IP3DAG, cyclic AMP या cyclic GMP. अगर ये है नाइट्रिक ऑक्साइड या ये है ANP, that is atrial natriuretic peptide, they are going to act through cyclic GMP. नहीं मैम, ये वो भी नहीं है, ये लिपिड सॉल्युबल भी नहीं है, ये पिग हार्मोन भी नहीं है, बट दे आर कॉन्ट्रैक्टाइल हार्मोन. इफ दे आर कॉन्ट्रैक्टाइल हार्मोन मैडम, तो देन दे आर गोइंग टू एक्ट थ्रू द IP3DAG. एग्जाम्पल दो. एग्जाम्पल इज वेजोप्रेसिन. नाम में ही है, प्रेस कर रहा है वेसल्स को. दैट इज नथिंग बट द ADH. बट मैम ADH तो V2 से एक्ट करके एक्वापोरिन 2 ओपन कर रहा था. यस, इफ इट इज गोइंग टू एक्ट थ्रू द V1 रिसेप्टर, it is going to be using the IP3DAG. but please remember ADH अगर act कर गया V2 receptor से, it is going to open up the aquaporin channel, it is going to act through the cyclic AMP. please remember that, right? Then comes the oxytocin. यूटराइन कॉन्ट्रैक्शन, ब्रेस्ट फीडिंग के टाइम पे मायो एपिथेलियल सेल्स ऑफ द ब्रेस्ट that get contracted with the help of this oxytocin, that becomes the contractile hormone again, right? Then comes the adrenaline. Adrenaline, if it acts through the alpha-1 receptor, causes vasoconstriction. Then acetylcholine, if it acts through the M1, M3 and F5 receptors, right? And the angiotensin 2. At least please remember for me, vasopressin V1 receptor and these three, है ना? Angiotensin B. So please remember these, and GnRH, GHRH and TRH. GnRH, GRH and TRH. What are they? They are not contractile hormone, but medicine इतनी आसान होती तो बात ही क्या होगी? Please remember these are exceptions. They are not contractile hormone, but they act through the IP3 DAG, IP3 DAG. Rest all hormones, if they are not lipid soluble, if they are not pig hormones, they are not NOANP, they are not contractile hormone, they are not GnRH, GHRH or TRH, all of them are going to act through the cyclic AMP. As simple as that, है ना? पर पहले you have to exclude all the things, है ना? Please remember that oxytocin, prolactin, ये क्या करता है? This is going to help in the ejection of milk, right? I can write it as ejection, है ना? Ejection. So please remember oxytocin is going to be helpful in the ejection of milk. Prolactin is going to help me in the production of milk. ऑक्सीटोसिन पे बहुत सारे क्वेश्चन आए हैं बच्चों, बहुत बहुत सारे. सो प्लीज रिमेंबर दैट, डोंट डू अ मिस्टेक इन दिस. इजेक्शन ऑफ द मिल्क इज गोइंग टू हैपन विद द ADH, है ना? ग्रोथ हार्मोन एंड IGF, इसका क्या फंडा है? ग्रोथ हार्मोन से एक ही चीज में अगर आपको बोलूं, so please remember this is going to cause decrease in the insulin sensitivity if it acts directly, but indirectly देखो insulin like activity ये करवा रहा है. This is a major difference, राइट? एंड लाइपोलिसिस ये करवा रहा है, ये एंटी लाइपोलिटिक एक्टिविटी करवा रहा है. बट इफ यू वांट टू रिमेंबर वन थिंग, प्लीज रिमेंबर दिस थिंग. सो ग्रोथ हार्मोन, इफ इट एक्ट directly, it can produce diabetes, right? So it can produce diabetes, so that's why it is known as diabetic hormone also. Growth hormone is also known as a diabetic hormone. If it acts directly, it decreases insulin sensitivity. That means it can provoke the insulin resistance. So it is like a diabetic hormone. Please remember that. Okay. Next come the thyroid hormone. Thyroid hormone mein you have to remember few things. See over here. First of all, see over here. Concentrate over here for the next 2 minutes. है ना? पहली चीज, I have to trap the iodine, but iodine cannot be trapped directly. So I'm going to trap iodide molecule, right? With the help of the sodium. So sodium iodide symport. सिंपोर्ट कौन सा एक्टिव ट्रांसपोर्ट होता है? प्राइमरी एक्टिव की सेकेंडरी एक्टिव? बताइए जी. फर्स्ट ऑफ ऑल सी ओवर हियर, सोडियम बाहर जा रहा है तो सेल में सोडियम कम रहेगा. तो सेल में यहां से हमने सोडियम अंदर लिया थ्रू द gradient. It is acting through the gradient. First of all, we decrease the sodium inside, and via that gradient use, I'm going to take sodium inside as well as the iodide inside. Wonderful. It is the secondary active transport. But that was not sufficient. Why? Because the thyroglobulin is there inside the colloid. It is not inside the cell. So I have to send this iodide molecule into the colloid. Which is going to do that? Pendrin molecule is going to do that. Okay. So please remember, this is known as trapping of the iodine. Trapping of the iodine is going to happen with the NIS, that is the sodium iodide symporter, as well as पेंड्रिन प्रोटीन, राइट. NIS कहाँ कहाँ पर होता है? ये आपके ब्रेस्ट में होता है, ये आपके प्लासेंटा में होता है. This is also present in the thyroid glands. Okay. This is also present in the parotid glands, but it is not present in the pituitary gland. Please remember that. Except पूछा जाएगा और pituitary option में होगा, so mark the pituitary. Please remember that. Okay. Then हमने iodide अंदर लिया था, not the iodine, है ना. I minus लिया था, I2 नहीं. So I need to create I2 now. What I'm going to do? Going to add 2 I's over here, and I'm going to make the ऑक्सीडेशन. कौन सा एंजाइम हेल्प करेगा इन ऑल ऑफ दिस? द TPO is going to help me. Thyroid peroxidase is going to help me out. Okay. Oxidation is going to happen, right? Then I'm going to bind that iodine, है ना. So iodide से हमने iodine बनाया, है ना, TPO के help से, right? That is oxidation. Then I'm going to do binding, which is also known as the conjugation or organification. Conjugation or organification, right? क्या किया मैंने? I'm going to attach iodine onto the tyrosine amino acid. I'm going to form MIT and DIT with the help of thyroid peroxidase again, right? So I'm going to attach the one iodine on the tyrosine, that becomes monoiodotyrosine. Two iodine on the tyrosine, that becomes diiodotyrosine. Once MIT and DIT is formed, I'm going to cause the coupling of them. Coupling of them, right? So coupling is going to occur. That means I'm going to form T3 and T4. ये कैसे हुआ? If I attach, एक iodine already था, MIT was there, I attach DI to it. That means MIT was there, monoiodotyrosine was there, diiodotyrosine came and mixed with that. It becomes triiodothyronine. That becomes T3. If DIT was there, I attach DI2 to it. It becomes thyroxine. That is nothing but the tetraiodothyronine, right? That is T3, T4. Now, once the T3, T4 is formed, where it is formed? It is formed inside my colloid. I need to endocytose it and keep it in the vesicle. And then what I'm going to do? I'm going to exocytose it into the blood vessel. Exocytose it into the blood vessel, right? So endocytosis and release. Whenever I'm going to have the stimulus, I'm going to release it. So please remember, everything is going to be done with the help of TPO. हाइपरथायरॉइड में क्या होगा? वेट लॉस होगा. यहाँ पर सेफ्टी पिन देख लो, और इसको हीट अडेप्टेशन नहीं होगी. हाइपोथायरॉइड में उसको ठंड लगेगी एंड इट इज गोइंग टू कॉज द वेट गेन. कोल्ड अडेप्टेशन इज गोइंग टू बी वेरी वेरी पुअर एंड ही इज गोइंग टू हैव वेट गेन, है ना. इंसुलिन सिक्रीशन फ्रॉम β2 cells. Please remember, insulin is going to have इंसुलिन इंडिपेंडेंट चैनल, दैट इज GLUT2 रिसेप्टर्स. कहाँ कहाँ पर होते हैं? बीटा सेल्स में GLUT2 रिसेप्टर्स होते हैं, किडनी में भी होते हैं, एंड यू डू हैव लिवर पे भी you do have GLUT2 receptors, है ना? And GLUT4 receptors are present adipocyte, cardiac tissue, and your skeletal muscle, है ना? And we do have अगेन द पोटेशियम चैनल. ग्लोमस सेल में कौन से थे? कीमो रिसेप्टर में ऑक्सीजन सेंसिटिव पोटेशियम चैनल. ओवर हियर वी आर गोइंग टू हैव द ATP dependent potassium channel because we are going to break down the glucose and form the ATP, right? So it is going to decrease the glucose by shifting it from blood to the cell. क्या करता है ये? Insulin is going to activate, open up a lot of GLUT4 channels. Via that, what is it going to do? Blood से glucose लेगा and it is going to put up into the tissues, into the cell. And that's why in the blood, my glucose levels are going to go down, and that's how I'm going to get prevented via the hyperglycemia. All right. Adrenal gland में 3 layers होते हैं. First of all, 2 layers are there. First is the medulla, and outside it is going to be the cortex. Cortex is divided into GFR. What is GFR? Zona glomerulosa, fasciculata, and reticularis. G never goes with G. इससे glucocorticoids नहीं release होंगे. G never goes with G. Please remember, it is going to release the mineralocorticoid. Fasciculata is going to be releasing the glucocorticoids. Reticularis is going to release the sex steroids, है ना? Sex steroids are going to be released from the reticularis. What about the medulla? Medulla is going to release the epinephrine and norepinephrine. Medulla is going to release epinephrine and norepinephrine. Applied aspect क्या है? Cortisol बढ़ गया, क्या होगा? कुशिंग्स डिसऑर्डर, है ना? कुशिंग्स में क्या दिखता है? स्ट्राया दिखते हैं, बहुत सारे स्ट्रेच मार्क्स दिखते हैं, बफेलो हम्प दिखता है, मून फेस, है ना? एंड लेमन ऑन स्टिक अपीयरेंस. क्या होता है लेमन ऑन स्टिक? दैट मीन्स द हैंड्स एंड द लेग्स आर गोइंग टू बी एक्टिंग एज द स्टिक, है ना? एंड द फैट इज गोइंग टू गेट accumulated in the central zone, right? Last part in the endo, that is calcium homeostasis. Please remember, PTH is going to increase the calcium, but it is going to decrease the phosphate. It is going to do the bone resorption. It is going to eat up the bone, take the calcium and put it into my blood. Calcitonin क्या करेगा? Calcitonin is going to decrease the calcium in the blood and decrease the phosphate in the blood. But what it is going to do? It is going to take that calcium and phosphate, form a paste with the water, and attach that paste onto my bone. So what it is going to do? It is going to actually inhibit the bone resorption. It is helping me to strengthen my bone, right? So it is going to prevent the bone resorption. On the other hand, calcitonin and the vitamin D is going to be absolutely opposite. It is going to increase both the things. कैल्शियम भी इंक्रीज करेगा, भी फॉस्फेट भी इंक्रीज करेगा. कैसे? बोन रिजॉर्प्शन करके? नो, इट इज गोइंग टू रीअब्सॉर्ब द कैल्शियम एंड this phosphate from the GIT as well as from the kidney. It doesn't act on the bone. Act on the bone whenever it is extreme condition. But please remember, if the vitamin D is higher, it is going to reabsorb the calcium and phosphate from the GIT and kidney. Help me in the bone mineralization. जब blood में बढ़ेगा तो automatically it is going to shift into the bone. So it is going to help me in the mineralization, right? Actually this can be vice versa also, है ना? क्योंकि अगर mineralization, calcitonin क्या कर रहा है? It is putting that onto the blood. So please remember, can be possible that this can be opposite. But please remember what is going to happen to these values. All right, just wait करो, 10 minutes में हम GI भी खत्म कर लेंगे, right? सेरोसा लेयर, मुझे बताओ सेरोसा लेयर किसमें नहीं होती है? Esophagus ऐसा इकलौता this thing, the organ is there where the serosa is absent, okay? And we do have muscularis layer, then we have submucosa layer, and finally the mucosa layer. Intrinsic में there are 2 nerve plexuses. What are the 2 nerve plexuses बच्चों? First is the Meissner's plexus. SS बड़ा लिख लेते हैं. Meissner's plexus, which is also known as submucosal plexus, right? And I have myenteric plexus also. Myo means क्या बच्चों? which is also known as orbax plexus, right? Myo क्या होता है? Muscle. So this is going to give me the motility है ना? मोटी वाली मोटी नहीं, मोटी means the contraction and relaxation, peristalsis वाला, and this is going to cause the secretion है ना? So याद रखना S से secretion होता है, right? And myo से क्या होता है? Motility आती है, right? Then extrinsic system क्या होता है? It is your ANS system. The sympathetic system, if the sympathetic system is activated, it is going to inhibit the secretions via inhibiting the Meissner's plexus and inhibits the motility via inhibiting the myenteric plexus also. Parasympathetic system क्या होता है यार? Parasympathetic is rest and digest. It is stimulating the motility and it is going to stimulate the secretion also. So इसीलिए बोलते हैं constipation हो गया तो क्या करो? Relax करो, right? Motility increase, right? Peristalsis कैसे होता है यार? पहले बताओ, what are the pacemaker cells? Pacemaker cells are interstitial cells of Cahal, which we have already written. Interstitial cells of Cahal, right? What they are going to do, once they are activated, they are going to increase the contractile wave, है ना? तो contractile wave कैसे आती है यार? पहले तो मुझे food bolus बनाना पड़ेगा, right? Food bolus के आगे there are some neurons which are going to get stimulated, which is going to cause relaxation in the front. Food bolus का relaxation कौन कौन से करते हैं यार? नाइट्रिक ऑक्साइड एंड VIP, वेजो एक्टिव इंटेस्टाइनल पेप्टाइड, NOVIP. They are going to cause relaxation. So this will look something like this. Okay, this will look something like this. Relaxation करेंगे, and at the back what is going to happen? At the back there will be constriction. There will be constriction. Who is going to help me in the constriction? Acetylcholine, serotonin, and even the substance P is going to be helping me out to contract. What is going to happen? आगे से प्रेशर कम हो रहा है, पीछे से प्रेशर बढ़ रहा है. The food particle is going to move forward. That is known as peristalsis. This is known as anterograde help. This is known as retrograde. Retro से push कर रहे हैं, anterior से dilate कर रहे हैं, so that I can go आगे. No VIP, आगे जा रहा है. Mass movement क्या होता है? Mass movement is nothing but the defecation. Potty आना is nothing but mass movement. Simple. Massive wave of propulsion, that is nothing but mass wave, है ना? 1 to 3 times a day is normal. 3 से ज्यादा बार आ रही है तो चेक करवा लो, थोड़ा एंटीबायोटिक प्रोबायोटिक ले लो, है ना? It is going to be very very strong in the infants, and as soon as they eat they feel the urge to go to the potty, है ना? कैसे आती है? As soon as the new food comes in the stomach, it is going to stimulate the colonic activity, right? But remember, whatever food he has just now eaten, that is not going to come out. The previous remnant particle, what was there, the feces is going to come out. Why? Because it is cleaning the GIT for better absorption of new nutrients that are coming through the stomach, है ना? So stomach, as soon as the food is going to come in the stomach, that is going to activate the peristalsis in the colon, so that we can clear out that feces particle. All right. So please remember, this is known as mass movement. What is migratory motor complex यार? हंगर पैंक्स जो आपको अभी आ रहे हैं, पेट में चूहे दौड़ना, दैट इज योर हंगर पैंक्स. ये कब आते हैं? जब आपका पेट खाली होता है, खाने के बाद नहीं आते. दे आर प्रेजेंट इन द इंटर डाइजेस्टिव फेज. You have eaten your lunch long back. Now you are waiting for your dinner. So during this phase, you are going to have the hunger pangs. And till what point it is going to go? Whole. From the stomach, it is going to cross over till the intestine, that is distal ileum. Stomach and distal ileum में, that means stomach and intestine में, you can see this migrating motor complexes. कितने बार के लिए होते हैं? 90 to 110 minutes. Okay. Now what they are doing, they are also removing the remnant particles, whatever were left there, right? If the new guest is coming, you clean your room. right? So same happens over here. If the new food is coming, we are going to remove the old particles, and that's why it is going to clear the GIT, clean the GIT. That's why we call it as sweeper of the GIT, or it is known as broomstick of the GIT. Who is going to help us out? Motilin. Motilin is secreted by MO cell, and please write down, it is not M cell, it is MO cell. Okay. Now, gastric acid secretion, there are three phases. Remember, maximum acid secretion is going to happen in the gastric phase, right? And the gastric acid secretion will be reduced and the bicarbonate secretion will be started as soon as my food goes in the intestine. Cephalic phase of gastric acid secretion कहाँ पढ़ा था? Which regulatory mechanism बच्चों? Please बताओ मुझे, फटाफट से बताओ. I cannot wait now. Feed forward system, feed forward, wonderful, wonderful, right? And who is going to help us out? Mainly in this two, vagus is going to help us out. Acetylcholine is going to help us out. When you are thinking of food, I'm talking about the food, है ना? Delicious food, burger, pizza, और हम देसी लोग हैं तो दाल रोटी, दाल मखानी, या फिर पनीर, जो भी आपको पसंद हो, है ना? If you see the food, if you think about the food, or the smell of the food is coming, aroma of the food is coming, your vagus nerve is stimulated, and 20 to 30% of the gastric acid secretion will start. As soon as the food goes in the stomach, that is also going to activate the vagus, and that will cause the maximum acid secretion, that is nothing but 60 to 70% of the secretion. ये solve करो. Inaccurate कौन सा है? इसमें आपको याद करना है silk या G silk. जी सेल से निकलता है गैस्ट्रिन, एस सेल से निकलता है सिक्रीटिन, आई सेल से, आई सेल से क्या निकलता है बच्चों? आई सेल से निकलता है सी सी के. यू हैव टू रिमेंबर दिस टू, है ना? और के सेल से निकलता है जी आई पी. आई किस में आ रहा है? आई इसमें आ रहा है, बट आई सेल यहाँ पर है. के इसमें आ रहा है पर के यहाँ पर है. सो दैट्स वाई प्लीज रिमेंबर दीज टू आर डिफरेंट, है ना? एल सेल, एल सेल से क्या निकलता है? बताओ बताओ बताओ, एल सेल से क्या निकलता है? आई एम गोइंग टू हैव GLP, राइट? एंड एमओ सेल से जस्ट नाउ वी टॉक्ड अबाउट मोटेलिन, है ना? नाउ दे हैव रिटन एम सेल्स ओवर हियर, तो ये गलत है, ये इनएक्यूरेटली मैच है. एम सेल्स क्या होते हैं? दे आर माइक्रोफोल्ड सेल्स विच आर इंपॉर्टेंट फॉर द इम्यूनिटी. आपने पढ़ा होगा गाल्ट. क्या होता है गाल्ट? GIT associated lymphoid tissue which are present in the Peyer's patches, है ना? So these are the microfold cells. They are present in my Peyer's patches. They give the immunity. They are not going to release the motilin. तो G silk MO याद रखना, है ना? अब आते हैं parietal cells पे. Parietal cells पे I'm going to have three things which are going to increase my H plus acid secretion. कौन कौन से हैं? Vagus nerve which is going to release the acetylcholine, right? Then histamine कौन से रिसेप्टर पे एक्ट करते हैं? प्लीज लिख लो, H2 रिसेप्टर पे. अगर आप इसको ब्लॉक करना चाहोगे, फार्मा हो चुकी है, बता दीजिए. रैनिटिडिन, फैमिटिडिन, सिमिटिडिन, ये सारे टिडिन 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 वाले ड्रग कौन से होते हैं? हिस्टामीन ब्लॉकर्स होते हैं. और असिटाइल कोलिन को ब्लॉक करने के लिए ये वाले रिसेप्टर, स्पेशली M1 के लिए पायरेनसिपिन पहले यूज होती थी, अब नहीं यूज होती, है ना? एंड इफ आई वांट टू ब्लॉक दिस, then this H plus secretion is reduced slightly, but if I block this proton pump itself, that too reverse irreversibly, that is going to be your PPI. But who is going to inhibit the acid secretion? Somatostatin is going to inhibit the acid secretion. Please remember that. Okay, please remember that. यहाँ पे inhibit लिखो. All right, coming to the second last slide. The iron reabsorption, you have to remember that iron reabsorption के बारे में क्या पूछा हुआ है, right? Iron cannot be reabsorbed in the Fe3 plus form. Ferric form में नहीं हो सकता. We have to convert that into ferrous form. अपना अपना अस वाला form भी वो अपनाएगा कब? जब अस वाला फॉर्म होगा, है ना? So we need to convert that from Fe3 plus to Fe2 plus. Now, once I convert it with the help of reductase, DMT1 is going to help me to reabsorb from the lumen into the cell. So please read the question carefully whether they have asked reabsorption into the cell. Question पूछा हुआ है into the enterocyte, then my answer is going to be DMT1. But if they asked into the capillaries from the enterocyte, my answer should be ferroportin. Ferroportin. All right. And please remember, this is the hephaestin. Hephaestin क्या होता है बच्चों? Hephaestin is going to help me to convert this Fe3 plus into Fe2 plus back again. क्यों? क्योंकि Fe2 plus ही है which can cross the cell membrane. All right. Fe3 plus में it cannot cross the cell membrane. So hephaestin is going to help me out to convert that into Fe2 plus. And who is going to transport the iron? Transferrin. ट्रांसफेरिन इज गोइंग टू ट्रांसपोर्ट. स्टोर किस फॉर्म में होता है? एपोफेरिटिन में स्टोर होता है, राइट. ट्रांसफर होता है ट्रांसफेरिन में. ऑलराइट, सो प्लीज रिमेंबर दैट. नाउ टू क्वेश्चन ऑन दिस टॉपिक. डेलिकेट, वेरी डेलिकेट हार्मोन, विटामिन कौन सा होता है? B12. नाजुक कली है ना. कौन होता है? छुई मुई. विटामिन B12 वेरी छुई मुई है ना. इट रिक्वायर्स प्रोटेक्शन फ्रॉम एवरीवेयर. Protection from the stomach. This acid is given by the heptocorin, which is released from the salivary gland. Remember, there are two things about the intrinsic factor. कहाँ से रिलीज हुआ intrinsic factor? Intrinsic factor is released from the parietal cells. Okay, but the intrinsic factor is not going to bind to the vitamin B12 in the stomach itself. It is going to go in the duodenum first. When the heptocorin is separated from the vitamin B12, then only the intrinsic factor is going to bind to it. And where this vitamin B12 is going to get reabsorbed. प्लीज रिमेंबर, टर्मिनल आइलियम में आपके विटामिन B12 का रीअब्जॉर्प्शन हो जाता है. अगर मैंने लगाया क्या? एंटीबॉडीज. आई हैव क्रिएटेड और जनरेटेड एंटीबॉडीज अगेंस्ट माय पैराइटल सेल्स. The intrinsic factor cannot be produced and it cannot protect my vitamin B12 into the intestine from various enzymes. So I'm going to have the pernicious anemia where the vitamin B12 deficiency is going to be there. This is the homework for you. You have to do the homeostatic points, right? Most common regulation कौन सा है? जैसे for example, negative feedback is the most common regulation. Main lipid कौन सा है? Phospholipid. Barriers कौन होता है? Tight junction. सेंसेशन कौन होता है? गैप जंक्शन. वाटर का रूल क्या पढ़ा है हमने? 60-40-20 रूल. टोटल बॉडी वाटर, ICF एंड ECF है ना. then dyes used for this is the Simon and plasma is the Evans का blue dye है ना. Evans का blue dye. active and passive लिख लो. प्राइमरी एक्टिव, सेकेंडरी एक्टिव, वेजिकुलर ट्रांसपोर्ट. इसमें आता है आपका डिफ्यूजन एंड ऑस्मोसिस. डिफ्यूजन में आपका सिंपल डिफ्यूजन एंड फैसिलिटेटेड डिफ्यूजन. like that you have to cover all the slides. These are the homeostatic points you have to remember. okay, डाइवेलेंट कैटायन कौन सा होता है? डाइवेलेंट पूछा तो मैग्नीशियम. ये कौन सा? इक्विलिब्रियम पोटेंशियल इज गिवन बाय विच फॉर्मूला? नर्स्ड इक्वेशन, नर्स्ड इक्विलिब्रियम. राइट दैट. नोकिया बाइंडिंग साइड्स, ये वो सब कर लो. राइट. if you have any problem, please let me know in the group itself. right. अगर नहीं आता है, we can solve these points again. right. now thank you so much for being with me. thank you so very much. A little progress each day adds up to big results. You have to remember this. why? Because remember, I know that you are going to feel anxious. I know that it is going to be difficult, but you have to continue. अगर यहाँ पर give up कर दिया, you are going to lose the race. फाइनल टाइम पे आके नाइट्रो बूस्टर ऑन करना होता है, गाड़ी को शट ऑफ नहीं करना होता. सो प्लीज रिमेंबर, नो मैटर, आई नो दैट दुक 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 इज गोइंग टू हैपन ऑल द टाइम, बट नाइट्रो बूस्टर ऑन करो, गाड़ी को स्टॉप मत करो. दिस इज द फाइनल लाइन. यू आर वेरी नियर टू द फाइनल लाइन. You have to turn on your nitro boosters, है ना. Thank you so much for being with me till the last moment of this class. Very good. All right. Thank you for being such a nice student, such a nice wonderful comments I saw. It feels very lively. Otherwise it feels very stupid to talk to the camera. Okay. Yes, if you pass me, please let me know also that ma'am, we have passed. I'll be feel immensely happy. All right. Chalo, take care. Bye bye. Good night. Have a good meal and have a good sleep. Before sleeping, please, please, please solve that homeostatic points. Okay? Bye bye. Party karo. Chill maro. Relax karo. It's time for the diastole. Okay? Good night. Good night. Thank you so much. Thank you so much. All right. Bye bye. Good night.